Working fairly? No? Oh, there we go. Good morning. I'm Bob Adler. I'm the Dean of the S.J. Quinney College of Law, and it's my pleasure to welcome you to our new home, our brand new home at the College of Law, which we opened in September, and to the second day of this symposium. There are several reasons why we are celebrating here today. This is the first event, this symposium, co-sponsored by our brand new Center for Law and Biomedical Sciences, which was just given final approval by the Board of Regents about a month ago. I'd like to congratulate my colleague, Professor Leslie Francis, who must be here somewhere, but I don't see her. Maybe she's outside. And her colleagues who were the architects of that center, a forum for interdisciplinary collaborations like that in which you are participating yesterday and today. The second reason for celebration today is that interdisciplinarity is what the center is all about. This is a perfect example with the collaboration between the College of Law, the Huntsman Cancer Institute, and the School of Medicine. And I want to particularly acknowledge and thank my colleague, Professor George Contreras, who spearheaded the symposium from the perspective of the College of Law. The really neat thing is that most of the collaborations that we're looking for are intellectual. This one is geographic as well, in which we had a dual location yesterday at the School of Medicine, today at the College of Law. Intellectually speaking, precision medicine is clearly an area which is ripe for perspectives for many disciplines. I know that yesterday's event was primarily the science and the medicine of precision medicine. Today's focus shifts to economics, to law, to regulation, and to ethics. So again, these are areas that are intricately linked, that are integrated. That's what the symposium is all about. That's why the symposium is so valuable. I hope you enjoy the second day of the symposium. And with that, I turn it over to my colleague, George Contreras.
Thank you very much, Dean Adler. It's a great pleasure and honor to be able to welcome you today to day 2 of the Frontiers in Precision Medicine Symposium. So for those of you who were not there, yesterday we heard a series of compelling talks painting a new and exciting landscape of precision medicine, from basic scientific discovery in fields of genetics, genomics, and pharmacogenomics to the search for genetic clues, to both rare and common diseases, to the use of powerful computing resources and big data techniques to tackle the deluge of genomic data that is currently upon us. So today, as Dean Adler mentioned, we're going to shift the focus from the lab and the clinic to places that are less discussed in the world of precision medicine, but just as important if we want to make the promise of these new discoveries a reality. And of course, I'm talking about places like the Food and Drug Administration, the Patent Office, Congress, the courts, HMOs and payers across the country, and ethics committees that are both national and local. So these institutions will play a large role in defining the future of precision medicine in this country and around the world. We hope that by bringing together yesterday's rich discussion of science and medicine with today's equally rich discussion of law, policy, and ethics, we're going to gain a more holistic understanding of the landscape that awaits precision medicine in this country and how we here at this university and elsewhere can help to bring the inspiring scientific vision of yesterday to fruition tomorrow. So with that, I will turn the floor over to our first panel, which will address a critical question that we all have in our minds, which is who is going to pay for precision medicine? With that, I'll let the first panel come up and invite them to take the floor. Great. And chairing the first panel, we have Dr. Norm Weitzman from the Department of Economics and the University Health Society and Policy Program. So with that, I will turn it over to Norm. Thank you very much.
Well, good morning. It's a pleasure to be here, and I'm Norm Weitzman, professor of economics, health economist at the University of Utah, and we are tasked, as the introduction indicated, with addressing who will pay, and as it turns out, that is not as easy a question to answer as you might expect, and not just because complexities keep us academics in business, but because it truly merits stepping back and establishing a framework and addressing the challenges in that framework. I think that really contextualizes what we'll be addressing today. So for those who came to write down who will pay, we might be a little disappointed this morning. So I think the prior questions, really, to contextualize our panel, is what are we paying for? What ought we to pay for? Which requires a framework and maybe a model or models. And who ought to pay under what circumstances? And there are several challenges, of course, given the complexities of our healthcare delivery system and the development of our new pharmaceuticals and devices. So what's important in that context is also the alignment of incentives. So we're privileged this morning to have three distinguished panelists to address these issues in a methodical framework. And to provide that overview and some aspects of the framework, we have Will Deere, the Presidential Endowed Chair in Internal Medicine for Diabetes Research, Professor of Internal Medicine, Executive Director, Personalized Health, Co-Director, Clinical Translational Research here at the University of Utah Health Sciences Center. And to draw out the framework further, we have Mark Tresheim, Visiting Scientist at MIT Sloan School of Management. And he's been a special government employee for the FDA's Office of the Commissioner and founder of CoBio Consulting. And he's also former president, board member of Massachusetts Biotechnology Council. And to bring the perspective of a major payer, we are privileged to have Eric Hales from Regent Blue Cross Blue Shield. We're going to go in that order. I think there's some method to that madness. And afterwards, each of the panelists will have some dialogue, perhaps amongst ourselves, and then open it up for Q&A. So, Will.
Thank you very much, Dr. Weitzman. And what I'd like to do for you this morning, over the next 15 minutes, is to talk about value. So just as an overview for my presentation, we're going to first talk about value. Why is it value that we're focusing on in terms of reimbursement now, rather than the volume that has heretofore been the basis for reimbursement of medicines, devices, and the like? Secondly, I want to highlight the importance of perspective. That in the United States, we have to take into account various stakeholders as we look at the entire healthcare system and how we look at our healthcare interventions. The third aspect that I'd like to emphasize is the importance of quantitation. We are quantitating more in the evidence-based medicine arena. Other countries around the world are starting to quantitate in terms of value in the economic sector, so we'll touch on that. I fourth want to emphasize the importance of stratification as we determine thresholds by which we as a society make decisions about what will be reimbursed in terms of an intervention and the like. And finally, I want to emphasize the importance for all of us in the research endeavor and the search for clinical excellence about the importance of innovation, and I'll use the example of cardiovascular disease. First, for some definitions, though, because we've used the term precision medicine, which was highlighted in President Obama's January 20th, 2015 State of the Union address. I'm going to move more toward what I think is a more holistic view of how I think we should look at patient-centered healthcare, which is called personalized health. But first, just for some short definitions. If you look under personalized medicine, under the NIH, there's a heavy emphasis on genetic, understanding the genetic profile of an individual that will help guide decisions with regard to prevention, diagnosis, and treatment of disease. As you look then at the different definitions of precision medicine, I've just thumbed out what I think kind of what the key themes are. And it's really interventions that are tailored and optimized in some way for an individual person. It then goes beyond those things that we've observed in large clinical trials in evidence-based medicine, where we look at Group A versus Group B and say, well, if Group A does better, this ought to be adopted in the healthcare system. The questions in personalized medicine or precision medicine are focused around what subset of patients best respond, what subset of patients do not respond and ought to get a different intervention, and who are the rare individuals, or can we identify those patients at risk for adverse reactions? So patient-centeredness, tailoring and optimizing according to a patient is really at the heart of precision medicine. And we've adopted here at the University of Utah, I think, a broader definition that in our minds really encapsulates how we should be looking at this era of precision medicine. And it is the following: that the right patient should get the right intervention at the right time for the right cost. And as you can see then, if you think about this particular sentence, it really encompasses a relatively broad number of matters that I think we as a healthcare system should address. A former resident here, now a very distinguished professor at Dartmouth, Gil Welsh, published a book called Less Medicine and More Health, because in a number of instances, doing less actually enhances health. And Gil highlights then such things such as in not all instances is action better than non-action. In not all instances is newer better than older. I mean, you get the drift. But the point here is that as we look at the broader field of precision medicine and enhancing an individual's health, sometimes less is more, which was highlighted in an article in The New Yorker by Dr. Atul Gawande entitled Overkill. And the article really focuses on the number of interventions that are done here in the United States that actually aren't necessary. There are about 26 interventions ranging from stenting in patients who have stable coronary artery disease all the way to getting an EEG for patients who have an otherwise uncomplicated headache that actually we are doing. And in fact, as you look at Medicare participants over a one-year period of time, it's estimated that up to 40% of them are getting interventions that professional societies view as unnecessary. In the United States, 300 million people, 100 million MRIs and CT scans done per year, 15 million nuclear medicine scans, and about 10 billion laboratory tests. Most, we hope, are necessary, but some are not. Another way that we can look at this entire broader area of enhancing healthcare for individual patients is to identify patients who are at the highest risk for utilizing healthcare resources or who would benefit by a more aggressive approach to their healthcare needs. It's estimated in the study by Atul Gawande, again, that 1% of the population is using about 30% of the healthcare dollars. So we can identify those individuals who are at particularly high risk and would benefit from earlier intervention to prevent going to hospitals, emergency rooms, or the like. We would benefit. We have looked at this within the University of Utah very, very intensively, because much of what I've said with the last three examples is really getting at cost. And one of the things that we've observed is that we actually don't fully understand our cost. The University of Utah, as highlighted in this New York Times article featuring Dr. Vivian Lee, who's the head of the Health Sciences Center, really tackles that and really shows that the University of Utah is trying to, in fact, bend the cost curve and decrease our costs. But I think one of the beauties here in terms of looking at the University of Utah healthcare system is a more comprehensive view of cost, and in fact, emphasizing one of the key themes within our healthcare system as it's evolved is looking at value. And I'm going to spend some time just focusing our attention on this particular equation. That value, as we look at it at the University of Utah and now other healthcare groups are looking at, is really a ratio looking at outcomes in the numerator, which can be measured in various ways, such as quality of care, patient satisfaction, patient service, and the like, over cost. So as we have our discussion around value, we look then to see how can we maximize value. In some cases then, it's enhancing the outcome, the numerator, and keeping the cost stable. In some instances where you have a high quality system and excellent outcome, it moves to decrease costs. And in some instances then, as you look at this ratio, it's a question if you have an expensive intervention, are you having substantively improved outcomes that justify the increased cost? Now that's looking at the value system with the value within a healthcare system. We can learn from other countries as they look at new health technology advances and make decisions about what they reimburse and use the same concept of value, namely outcomes, a ratio of outcomes and cost. And such is done particularly in single payer systems going back to the 1990s when Ontario, Canada, and Australia published health economic guidelines as to how they are going to evaluate new health technology advances. Now, as we look then at value and try to use that same definition of value more broadly, it's important in a country with multiple stakeholders that we look at perspective. Value from whose perspective? And I just used 3 key stakeholders here in this article from Weeks et al. From Dartmouth and American Journal of Medicine, just to highlight that they can differ. Differences in looking at the time horizon between society, and I will come back to this in my concluding slide, an insurer, a patient. I've not discussed even the physician, an employer, but the point is there are a number of key stakeholders within the healthcare discussion. And I want to highlight sometimes conflicts between the two or competing priorities, and let's focus on insurer and patient. How do you improve the denominator? How do you decrease cost? From an insurer's perspective, is one way to do so would be to increase out-of-pocket costs. And from a patient's perspective, it is to reduce out-of-pocket costs. Clearly different needs based on the perspective of the external stakeholder involved. I will then now move to this notion of how we quantitate value. Can we quantitate value? And I'm going to spend about a minute with this rather could be complicated slide looking at value in an evidence-based medicine perspective and quantitation, because frequently I as a physician don't like to quantitate that much because we like to just use judgment. But this slide depicts the use of statins in cardiovascular disease, which I think have just been wonder drugs. And along the x-axis is the 10-year risk of atherosclerotic disease as depicted from 5% up to 25%, 10-year risk. Along the y-axis is the number of patients needed to treat in order to derive benefit of decreasing a cardiovascular event. In this case, the estimate was about a 35% reduction in cardiovascular event. The curve, as you see, should highlight an important aspect in the importance of stratification. As one's risk of cardiovascular disease goes up from 2.5% to 25%, the number of patients needed to treat in order to prevent one atherosclerotic event goes down dramatically, from over 100 at 2.5% to under 10 with 25%, with the point being stratification is a means by which we can enhance value of our intervention. The other thing to consider is the horizontal line at the top, which is NNH, is the number of patients needed to treat in order to confer harm, which in this case is the 1% additive risk of getting diabetes mellitus during the period of intervention. So as you see, again, the value of stratification and quantitating how we are looking at clinical outcomes, you can see visually that as one's risk of cardiovascular disease increases, the importance or the value from a clinical perspective of the statin also widens. The same concept then of cost and outcomes has been utilized in economic assessment in a very, very systematic way. Very, very briefly then, it's program A would be an example of using a statin. Program B would be the group who would not use a statin. And how economic analysis and quantitation of economic analysis works is looking at the costs and the effects and comparing them between programs, which in an economic analysis is called an ICER, an incremental cost effectiveness ratio, which is a quantitation of outcomes and costs. And in this case, with economic analysis, we're just flipping the numerator and denominator in terms of how it is routinely depicted. But it's a comparison, a quantitative comparison of cost and effects of a particular program. Frequently, my colleagues, my physician colleagues say, well, you know, health economics and economic analysis is kind of a black box. So my intent over the next 3 slides is just to give you an illustration that it isn't a black box, that quantitation certainly is possible for acute and for chronic diseases. The Markov model is frequently used in terms of chronic diseases, and in this case, it's depicted as a group of patients starting off at time 0, all of them healthy, and then looking over time to see what proportion of them become sick and then die, and which may be healthy and die suddenly without going through that intermediate diagnosis of some chronic illness. And as you can see from this, again, it was arbitrarily stated, let's just take a cohort of 1,000 patients at the beginning, and you can quantitate based on what we know of the natural history of disease, what happens over time after year 1, after year 2, and after year 3 in terms of how many have died and how many become ill. You can then use that same notion in looking at this particular model to see, well, what happens if you use a statin? What happens if you give an intervention that decreases risk by, in this case, 50%? And you can go through those numbers also and model what happens after year 1, year 2, year 3, and look at the cost and the benefits and the effects of what will occur to this cohort of patients. Now, a common, which has occurred in this case, in which you see the differences at year 1, let's say, which I've highlighted in the red, between the sick and the people who have died. So cost and outcomes, and a common thing that we need to do then in the setting of looking at competing and things that are cardiovascular disease, breast cancer, other illnesses, is to say, well, what is that common outcome? And what is frequently used in the cost effectiveness world is a life year saved. How many people's lives are you indeed saving? So you have a common outcome so that you can compare the costs of competing technologies. I've talked nothing, zero, about genetics thus far, and I'm going to use these two slides, the next two slides, just to highlight the importance of genetics and the role that genetic diagnostic testing can play in really helping us to identify those patients at increased risk, to stratify those patients who would potentially most benefit from an intervention. A study from The Lancet using a panel of 27 genetic tests. And in addition to what we routinely use, hypertension, LDL cholesterol, and the like, in terms of cardiovascular risk, these genetic single nucleotide polymorphisms actually help differentiate the population further. And it was highlighted also in cytochrome P450 genetic tests that can be done, an important set of tests that determine how well we metabolize a particular drug. And that in a paper published that is actually in press right now from my colleague in the College of Pharmacy, Dr. Diana Brixner, demonstration that if you stratify patients at highest risk for having an adverse event, you can identify those who should get this type of diagnostic testing. I conclude my comments for us then as members of this society to look and how we should look at our healthcare interventions. And I refer to a paper by Brian Luce and colleagues published in Value in Health in 2006, which looks at cardiovascular care over the preceding 30 years. Numerous interventions, you're not designed to read these, but numerous interventions have been used, ranging from diagnostic testing with troponins, new medicines such as ACE inhibitors, surgical interventions such as stents and bypass, ways in which we improve care within a coronary care unit, and the like. But there have been numerous ones that have eventuated in substantive improvements in our coronary heart disease rates. With this slide from Elias Zerhouni, the previous head of the NIH, which projects what the deaths according to coronary disease would be if you looked at it in 1970 at over 1 million, and what actually happened in part due to these innovations in 2000. You see a dramatic reduction in mortality and cardiovascular disease with this type of economic investment made for us as a society. So as we look at various stakeholders, insurers, physicians, patients, it's important for us as a society to recognize the importance of innovation and research as we look at the health of our country. Thank you.
Well done. So, thanks, Will, and now we're changing things over here. Being, how do I minimize his?
You can drop, just go to the red dot there. I'm sorry, I should have done that for you. And then bring up yours.
So, I'm Mark Trusheim. Thanks very much for having me here. And I think we got that working. So we're good to go on the slides when they come up. Pleased to be with you. I'm from the business school at MIT called the Sloan School of Management. You heard some of my background before. What wasn't mentioned, but I feel you should know, is I worked in industry for many years, both in drug marketing and running a gene sequencing center. And you'll see these themes of combining marketing, business, as well as the science in the talk that that I'll share with you here, as I'll focus again on the multi-stakeholder kind of perspective that Will was good enough to begin with, and drill down on that a little bit. And coming from MIT, you'll see that they did select for phenotype. You'll see more numbers in this presentation, but hopefully we'll go through them reasonably quickly and well. And the idea is to give you a good impression, sort of a pointillist, impressionist picture of all this through lots of data points, and we can go into more detail as necessary, either in the discussion or offline if you want to talk to me. So you might sense that Will and I coordinated a little bit. I'm starting off with the cardiovascular slide in many ways that he ended with, because I thought it was important before we talk about precision medicines that we get, again, grounded in what have we paid for value, and what have the economics of our more empirical medicines looked like. And so Will just went through the cardiovascular death rates, and you've seen what a great success story that is. What I'd like to, there we go, talk about a bit here is how we lower those cardiovascular events with statins, but talk about it now from those numbers needed to treat and how much did we actually spend for those events before. So, and how might that look different under precision medicine. So to avoid one fatal event, a little different than what Dr. Deere talked about, you have to treat for 5 years 83 people. That's from a meta-analysis. And in the old days when the drugs were on patent at $1,000 a year, over those 5 years we spent $415,000 to avoid one cardiac event. So when you start to hear about other oncology drugs costing $50,000 or $60,000 for an additional life year, et cetera, remember that in the old empirical days, it cost us $400,000 to save one person dying from a heart attack. A cardiovascular event like a non-fatal heart attack is a different and lower number, but if you actually want to save a life, you spend $400,000. Okay? Now, under today's generic rules and pricing, it only costs $50,000. But of course, that $50,000 isn't what led to the medicine to start with. That's now that we have it and it's off patent. That's now what we pay 20 years after the fact. So now think about precision medicine. If we knew who the one person was who was going to have the heart attack, we didn't need to treat the other 82. Okay, think of how that would have done. They all had risk, but only one person realized the risk and was actually saved. We just didn't have the tools, and we still don't, to know which one person that is. But that's changing in other conditions such as oncology, autoimmune disease, increasingly now we hope in diabetes and cardiovascular as well. And so through the use of a diagnostic, we can now split that population into those who will have the higher response rate and those who we know really won't have that benefit or effect. And that not only saves us the cost, it saves them the adverse events, and in some conditions that are critical, such as oncology, the savings in time is just as important because they don't waste their time on a treatment that isn't going to help them, and they now have the ability to seek other treatments that might. So, unfortunately for the economics, fortunately for patients, the science continues to advance. And so we don't have the world anymore where it's just one group of patients who respond and don't. We now begin to stratify the populations into many, many subpopulations. Who has what kind of a mutation in gene A versus gene B versus gene C. And combinations, you'll see some people are orange on top and blue on bottom. That's sort of a depiction. They have two different mutations that might be affected by two different drugs that you'd want to give in combination. And what this doesn't show is that resistance to these, particularly in oncology, resistance to the treatments evolves over time. So it's not a single snapshot, but this changes. And then you got other subpopulations coming from after that. So the question from an economic standpoint, is there a limit both for the developer? Do the markets become so small and the time it takes to build the evidence to show that the drugs works becomes so great under our current classic approaches that it just isn't possible to do anymore, and that for people like my right, like Eric, who have to pay for these things as payers, does become unaffordable. Those are two different sides of the same coin. We're going to try to relate those coming together through this. So for targeted cancer therapies, just to give you a sense again of how it used to work, for a large cancer population, you'd spend about $400 million in 7 years to develop it. You'd get 6 years to get it to peak sales. You get $20,000 a year at 40% market share. That gave you $625 million of net cash flow. The big number at the right is how much money you'd tell your board of directors before you did the investment what the net present value of the program was going to be, which was over $1 billion. Now that's a net present value, not a sales number, but that's sort of the numbers people were used to looking at. So you also see that number at $400 million in 7 years. Wow. Is a little high, or a little low. There's numbers today that say about $1 billion to $2 billion to develop a drug. Those are not in oncology in some of these targeted spaces. So we're taking perhaps a more conservative and low number here. Now, if you only have 7,000 patients in one of these stratified areas, but it still costs you an FDA clinical trial program of $400 million in 7 years to do it, you only have a very small market now. At the $20,000 price, and you get better share, say it's 60% instead of 40, you wind up with a real loser of an investment proposition. It loses $200 million. You can't get anyone to invest in something like that, right? It makes no sense for these things. So what do? Do you give up, or can precision medicine really change the economics of this whole process? So that's what we just saw at minus 194. If you do it faster and cheaper, and you get better adoption through evidence-based medicine, that it goes through the population faster, and you keep the same numbers. So if I cut the time and cost basically in half, and the adoption by about a third, you still wind up losing money, although you've almost broken even. If you do it incredibly fast, only $150 million, and you only do it in 3 years, that's a really accelerated program from first in man to getting an approval hardly ever seen, and you get 90% market share. You give the company nearly exclusivity on that indication. No one else can compete in that. You get it back to be positive. But who wants to give exclusivity? That gives too much pricing power to various groups, et cetera. And frankly, $103 million is barely investable because there's so much risk. While you would think that seems like a positive number, hardly anyone's going to invest if it's that tight to losing money. All right, you got to get that number higher to really get anyone to pay for these things on the front end. Because if you don't get it to the market in the first place, Eric doesn't have to worry about paying for it at the end. So we're starting at the beginning, okay? So if you do a balanced approach at $200 million a year, very fast, take about the 6 years because physicians are somewhat conservative, really want to see a longer track record. But you raise the price to $60,000 instead of 20, and you get 60% market share, which is about what we thought before. It now becomes pretty much investable. These numbers, by the way, are pretty close to what the net numbers for many oncology drugs today look like. So when you see prices published in the papers, you have to realize those are published list prices. It's like buying a mattress. Whoever pays the list price for a mattress, they're always 50% off, okay? So with drugs, the list price, what the manufacturer actually gets after all the rebates and payoffs to Medicaid with their lowest price and to the Express Scripts of the world, et cetera, they wind up with about half of that list price. So $60,000 is about $120,000 list price, which is actually on the high side for many of the drugs that you see today. So this is why the drugs cost $60,000 to $100,000 a year today in oncology. But we find that perhaps unaffordable going forward, and these development paths just don't really make much sense. Now, those of you who are good scientists and developers in the background said I stacked the deck because, of course, oncology drugs work for a whole bunch of different subpopulations and different disease types, and therefore these numbers are wrong. Well, Gleevec by Novartis is probably the most prolific supplemental indication cancer drug that's ever been out there. They've got 3 different biomarkers and companion diagnostics. And if you look at this, you say, well, they've gone into about 6 or 7 different indications over time and globally. What you don't see, but if you go to clinicaltrials.gov, is all the places where it didn't work. Okay, so there's no guarantee, and Gleevec has the most supplemental indications of any oncology drug yet today. Most get 1 or 2. So the original numbers that I was talking about weren't really that far off. And as you see other people talk about, oh, the incremental indications don't cost much, they usually only look at the winners. They don't talk about all the failed clinical trials on the side. So now we're going to connect this to the science a little bit. So if you use a diagnostic, if it's a perfect one, you get all the people who respond on the right side in blue, and all those who don't respond on the left. You set a cutoff value. You have to score over 30, say, on the diagnostic, or 2x gene exposure, et cetera, and you wind up with then better improvement, because you don't a better improvement in the performance of the drug as it shows on the label, because you get rid of all the people who don't respond and drag down your averages. That leads to faster adoption, market share, and price. Unfortunately, science doesn't work that way. Practically always, the companion diagnostics are imperfect. And you have now what sets up for today, in our discussions, real ethical and economic questions. Where do you set the cutoff value on the diagnostic? Do you set it low, so that practically everyone who might respond in blue has access to the drug. Well, then you wind up with not as much enrichment, the performance doesn't improve as much as it might, and you expose all those false positive yellow patients to harm or delay in what they might do. So ethically, maybe you want to set it to the far right so you don't harm anyone. But then, if that's your cutoff for evidence-based medicine, you just denied care to all the blue people to the left. So what's the right balance, and how do you understand this? And from an economic standpoint, of course, if you move to the far right, your potential market is much smaller, and if you're on the far left, it's bigger, but your impact and what you're claiming to the patient and the doctor is lower. What's the right thing to do? It's not clear. Now, if you think about competition and all this, how many times do you see these kind of choices playing out, and does it make a difference through this? The blue columns here are all the drugs that are launched by some targets in cancer. The red lines up above are the number of competitors coming on top of that are in the pipeline. If you go off across the right, those are all the different targets and the number of compounds in development in oncology. For those of you who are scientists, this is competitive intelligence by mass spec diagram. So what you wind up with is by the time a target, a particular mutation, has a drug that addresses it and you get it to the marketplace, for the 35 targets in phase 3 with no other approved products, only 12 of the 141 compounds in development face no competition. There's tremendous competition going on, so these questions about where to set the cutoff values aren't just ethical, theoretical questions. They turn into business competition questions as well. Where do you want to set it? And what's the public health impact and the payer impact for that? So now consider 3 essentially identical drugs going after the same target. Where do you set the cutoff value? So I could say, well, I don't want to use a biomarker at all. And if I have a drug where I give a year of added overall survival for a third of the patients, I'll wind up with a 4-month overall survival benefit in my clinical trial. A third of the patients get a year, 2/3 of the patients get nothing. The average on the clinical trial will be 4. Okay? Simple, straightforward math on all that. The price that I could expect for that, given this recent meta-study that was done that showed in the US, we pay about $140,000 for a year of added life in oncology. I'd expect a price, list price of $46,000 for that. The benefiting patients would be about 7,200. I'd have to treat 21,000 to get those benefiting patients. And the payer to Eric over here, he'd have to spend about $1 billion for doing all that. All right? Now, if I set a companion diagnostic cutoff fairly low, I can enrich the population with those who respond. So my number of months of overall survival goes up by over 50% to over 6, almost 7 months. The price that I would expect for that, given the value, quality, ICER kind of things that Dr. Deere went through, I'd now expect a price of $77,000. The drug really hasn't changed. It's only how I've selected patients that has changed. Okay, these were 3 basically competitive, identical drugs. All we're doing is selecting patients differently, so the diagnostic is adding really all this value. I only now have to treat 13,000 patients to get to 7,200 benefiting ones, and Eric still pays $1 billion through the whole thing. So, if I go to the very high end, I deny care to a whole bunch of people who might have benefited, but my months of overall survival is now up to 10 months. Perfect would be 12, right? But now we're up to 10. On the basis of that quality ICER-based approach, I'd now expect a price of $119,000. Thanks for the time. We'll finish up here in just a moment. The drugs are the same. The value and how they select patients are different. The value to the 7,200 patients who were treated is identical. The value to the patients who don't have to get the drug, who wouldn't have benefited from it, is actually higher at the higher price. The payment system, the reimbursers, are still paying $1 billion, so they're indifferent. You could do different scenarios where they come up better or worse on these things, but if you think the $140,000 was fair, this is still a fair approach. And now you see why when you talk about precision medicines and all these discussions about the price of the drugs are going up, it's all a bunch of hooey. It's about value. All right? Would you rather be a patient paying $46,000 and not knowing whether it's going to work for you or not, a 1 out of 3 chance? Or would you rather be the patient who has a nearly 90% chance of responding to it, and you're paying $120,000, and from a societal standpoint, it's a wash? Okay? That's the power of precision medicine, but it upends all the rules about how do you compare one drug to another. It causes huge problems in payer discussions. You can see the confusion that's often happening now in the public press about high-priced drugs and low-priced drugs, et cetera. What you also see through all this, and I got just 1 or 2 more slides, and I'm going to go through very quickly, is that the diagnostics companies, people get none of this value. Practically all goes to the companies that make the drugs. The people who make diagnostics get basically paid cost plus. And what that has led to is you only see precision medicine happening for the new drugs, where the drug companies pay for the diagnostic development. All the old drugs, like statins, we're not developing diagnostics to help us find the 1 out of 83 people who would respond. The result is we're paying for drugs for 82 people who it doesn't matter, right? So we can find the 1 person who will benefit. But we're not spending the money on the diagnostics because we won't pay them more than $50 for a test, which they can't make any money off the clinical trials they'd have to do, which would still be several $100 million to do that. It's a huge missed opportunity, which then makes a huge societal problem for us. Because when you come through, you talk about healthcare inflation, you see these sorts of numbers coming around. You know, the health price under the ACA is up 3 or 4%, the drug costs are up 12%. Well, the drug costs for many of the new ones, they're not giving you your old healthcare status at a higher price. For the most part, that health price inflation on the drug side is because there's new drugs that are improving people's health, and you're actually paying a society for greater health for the whole thing. It's a combination of effects, but what we're not doing is finding precision medicines for the legacy treatments that would then save us money. So you wind up with only 1/2 of the precision medicine story, and the prices wind up going high. The question for us as a society and ethically is, as we talk about increasing healthcare and precision medicine, do you want to pay for new health and cures, or are you really wanting today's health status cheaper? And the debate often gets confused between those 2 aspects. If you don't want any more new drugs, you don't have to have them. The current branded drugs will go off patent, and we'll have 2015 health status forever, right? If you want new drugs, right, then you should be willing to pay for more health. But if as a society we can't pay for more health, like Greece at the moment, really can't afford for that, we may want to make a different social choice. But you ought to be clear about the choice that you're making and not just say it's costing too much, right? There are challenges on what you do with large background things, et cetera. Do you want to also include the costs of making people with multiple sclerosis now able to have a job and get off the dole, or do you not want to include those kinds of benefits to the whole thing? And you also have to talk about the value of compassion. So a quick economic view, we would never develop an orphan drug, right? It's not cost effective. We ought to focus on cardiovascular and respiratory disease. The poor people with the rare diseases, you know, maybe in a century or 2 we can afford it, but if you did strict health economics, utilitarian calculations today, you would never develop an orphan drug. That's not the compassionate society we are today, but you also have to then count that in as to how do you think about the economics of compassion, which is also very difficult. There's some new approaches to change the way that we collect the evidence through all that, but that requires that payers, regulators, and companies all collaborate and give and gain a little bit. Most companies make commitments to long-term data collection. Payers wind up paying for early access to the drugs for patients, and regulators take a little bit more risk at the beginning, but only for very high benefit populations, and then they wait for more evidence before the label gets expanded through all that. We call it adaptive biomedical innovation. The Europeans call it adaptive pathways. You see it with breakthrough and other sorts of designations here in the US, and we'll just skip all of these and say that at the end of the day, right, we have to find a way to connect all these different perspectives in an integrated conversation, and that's part of what we're doing here today, and that at MIT we have approach that we do that, which I'd be happy to talk to you more about later. So with that, Eric, it's you.
Well, good morning. Is that on?
Show screen.
Is it on now?
I'll just give him mine.
Great. Nope, this works. Great, thank you. Good morning. I'm Eric Hales with Regents Blue Cross Blue Shield here in Utah. And I want to try to tie some of what's already been discussed together. Treatment of medicine is delivered in a very personal or individualized manner. And what I mean by that is you take some of the things that Mark was saying, that the cost of drugs are extremely high, and the things that we've been talking about and who's going to pay for it is very expensive. And you do one of these kinds of things to say, I'm not going to pay for it, you're going to pay for it. Well, we all are in this endeavor together, because the way that insurance works, if you don't mind me doing a little quick education, is that your employer purchases benefits, and you have a premium that comes out of your paycheck each week to pay for those benefits. And the things that we've been talking about that are increasing the cost of healthcare get passed on to each one of us. So it's not one of these, it's one of these that all of us have some skin in the game. I also want to talk a little bit about some of those new type of therapies or treatments that come out. Sovaldi is a classic, recent example that treats hepatitis C, that for one course to cure that disease, I mean, it's a tremendous benefit and amazing advance in medicine, is $80,000 for 1 year for that individual. So when we think about healthcare for the population, it tends to be something, well, that's really not affecting me until it affects me. And then I want all the money and all the resources paid to help me or to help my child who is suffering. So it's important that we keep that perspective. On this opening slide, you'll see Regents on your left and Cambia Health Solutions on your right. And I need to explain that quickly before I get into my presentation. Regents is an insurance company. We're in 4 states, Utah, Idaho, Oregon, and Washington. And our parent company is Cambia Health Solutions. And that's important because I'm going to give you a very important commercial at the end of my presentation. There's a culture and infrastructure changes that are occurring in healthcare. There's really 3 important things that are happening. There's population risk stratification, clinical integration, and empowering patients or individuals to maximize self-care. What do we mean by each of those? Risk stratification is really to identify groups of patients or individuals that have common diseases. And you look at diabetics or those with asthma or those that have congestive heart failure, and you give them a risk score based upon how much healthcare they're consuming or not consuming, their lifestyle, and then you develop treatment plans around them. Clinical integration is a bringing together, like Mark's last slide there was, we need to have a community talking together, patient, doctor, payer, families, community resources to help provide care for individuals, and that's what clinical integration does. And empowering patients to maximize self-care. So I started out by saying we all have skin in the game, so that means we have ownership and accountability and a responsibility to make sure that we ourselves are taking care of our own health, but also seeking care when needed. So let me ask a question, and this is kind of an interesting way of a panel discussion, is by including the audience, but how many have gone through the exercise of having your genetic marker mapped? Raise of hands. So I see a couple of hands. That's not very many, and that's probably indicative of the entire population. The other question then as a follow-up is how many of those 2 or 3 hands that I saw have downloaded your marker on your app, and you can take it to your doctor and say, hey, here's my genetic marker, treat me based upon what you see here. One individual. But that's where we're going. but it's very costly and it's very time consuming, but that's the future of where healthcare is going. So let's talk a little bit more in depth about risk stratification. There's really, you can break it down into 3 patient populations. You have on the right side of your screen, you see that pyramid, and that bottom portion is low risk. That's about 75% of us. Then there's a rising risk, which is about 20% of the population. And the rising risk are those that are somewhat unhealthy, but you might have some genetic markers in your family and in your map that says, I am at risk for heart disease. I'm at risk for diabetes, but I'm not manifesting any symptoms. And then you have the high risk, the 5% of the population, that they've already experienced an episode of heart attack, or they are in full-blown diabetic and need a lot of treatment, or they've had some type of catastrophic illness. On the left-hand side, you'll see this is Medicare spending, and really what I want to emphasize is that bottom bar on the right-hand side. So that's the percentage of total Medicare spending, and you'll notice that 43% of the total spending is spent on that high risk. That smallest part of the triangle is consuming most of the dollars. In clinical integration, the American Medical Association terms it this way, that it's to facilitate the coordination of patient care across conditions, providers, settings, and time, in order to achieve care that is safe, timely, effective, efficient, equitable, and patient-focused. And so the way that you align incentives is that you, and I'll be talking about this in a minute, but to get to the results, you first have to align incentives, provide knowledge through that coordination, through medical record passing back and forth between providers, and also to the individual. So there's a point where we'll all be able to walk around with our smartphones, with our medical records, so that we can pass it back and forth to providers. And that's to help our behavior, and that's what drives action and gets results. So our focus at Cambia Health Solutions and at Regents is to put that consumer, the individual, at the center of all the resources. And our investment in this endeavor of precision medicine is to help each individual make the best decisions for ourselves. And I won't go into all of the details here, but the provider is really at the core of making sure that this endeavor works. And so it's important that we have incentives with providers and payers so that individuals can maximize their health. So there are methods, or there are opportunities for us as payers to engage with providers. And so the old way is called fee-for-service reimbursement, meaning that I, as a health insurer, have a contract with a hospital or with a healthcare provider, and every time a patient goes to see that provider, I cut them a check. It's like going to the grocery store and buying bread. You go to buy the bread and you pay for it. That's how the traditional model of reimbursement has worked. But on the other side of that is that up front, the insurer can provide the money to the provider and say, here's all the money that you would need to care for the patients that you're seeing in your office. Now it's up to you to keep them healthy. If you spend more money, it's coming out of your own pocket. If you spend less money, you get to keep the difference. So there's a shift in the way that we are paying for medicine. And so there's a continuum here of fee-for-service, pay-per-performance contracts, shared savings, and that full global capitation is what we call it when we give that pot of money to the provider. So here are some things that, just to simplify that previous slide down a little bit, some things that we are aligning physicians and hospitals through incentives. We have a pay-for-performance model with hospitals where we will say, here's those catastrophic patients, a lot of times they will go to the hospital and then they go home and then they are readmitted. So we will pay the hospital for reducing the number of readmissions. We have total cost of care arrangements with providers. And in those, I'm going to jump to one slide forward and just talk about this for a minute. So we look at quality measures through looking at women's health, asthma, diabetes, heart disease, respiratory infections, depression, back pain, and even including something that Will talked about, which is that member or that patient satisfaction. Those are the things that we have indicators that we use HEDIS measures, and we say if you meet certain qualifications and are treating people with diabetes appropriately, we will give you a bonus. Then in shared savings, it's very, very simple. That we might set a target and say, all right, let's try with you as a physician, look at the patients that you see. If you, over a course of a year, meet the certain target in terms of the number of dollars that you expend treating for your patients, if you go below that target, we will share in that savings with you, and then there's full risk. This slide, it could be many more, what's the word that I'm looking for, icons on this slide. But these are companies that Cambia Health Solutions owns. And this is where the commercial is, so I don't mean it to be a commercial. But what I am intending to show you is some of the things that we are doing in our investment, and other insurance companies do very, very similar things to help individuals take accountability to work with your physician, your provider, to maximize your health and your care. It could look like a NASCAR kind of slide, I guess. So Polkadot, it's one of those play on words of polka dot. It's a marketplace, and it's a software platform where it's an app today where you can pull up the doctor that you want to see and make sure that they can treat your disease, so what is their specialty, but you could also work with that provider for a discount beyond the insurance discount. And so it's a very transparent tool that works on your phone or on the web so that you can make better choices of which provider you're going to see. Another one is Best Doctors. This one's pretty exciting. This one was developed out of Mark's backyard in Massachusetts, where there's physicians who are the best minds in the country. And your physician can get on a phone call or be able to discuss the treatment. And sometimes, treatment can become very complicated, and you want to have access to the best care, the best minds possible of how to treat that. And Best Doctors is an option for our members to be able to seek that type of expertise. Next is CareMerge. So earlier I was talking about bringing that community together, the patient, the provider, the family member, and the community resources like long-term care and that type of thing. CareMerge is that platform. One of the barriers that we see in healthcare is that it's my private information, and it's very difficult to share that information because of federal rules called HIPAA, which prevents us from sharing data publicly. But CareMerge is a very secure way where families can, and the provider and the family, patient, and provider can all log in together and see the progress that is happening with somebody who is in a long-term care facility or a rehab facility, for example, so that in real time you can be able to understand the care that's being provided. Spendwell, it's another online marketplace where providers set their own prices. So a lot of times, the insurer and the provider, they work out an agreement, but the provider has the opportunity through Spendwell to say, you know what, I understand your hardships. They understand their patients sometimes have other things going on in their life that make seeking care very difficult. So physicians can set their own price and negotiate that with the individual. And then finally, remedy grade. And this is probably one of the most exciting ones for me, at least, that this is a new one. And what this company does is it looks at the cost of drugs. And we were just discussing just a moment ago about the rising cost of drugs through R&D and the pharmaceutical companies. Remedy grade takes all of those costs of those drugs and provides a transparent tool to the individual to say, this is where I can get this drug, and these are the prices, so that they can go and make the best choice possible for them that meets their needs, so that they can say, this is what works for me and my family, I have easy access, and it's at the best price. And it also helps the provider to notify them if there are risks involved with taking certain medications because of the indications that it might interact with another drug and that type of thing. So it's a way for a lot of coordination and a lot of safety to be provided when we're looking at prescription drugs. The last thing I want to say is, so Will was talking about newer is not always better, and more is not always best. And I want to kind of make that in a real example. So yesterday I was up in Portland for some training, and we learned about a story of, not from my organization, but another health organization, where a patient had breast cancer. And this patient wanted to have the latest and best and the most aggressive treatment for her, and so she demanded to have bone marrow transplant. And the insurance denied that treatment. And so she took it to the governor of the state where she was living in and filed a lawsuit. And this particular insurance company said, sure, we'll go ahead and pay for it. And so the individual received the bone marrow transplant, the bone marrow treatment for her breast cancer. Well, we've since learned that bone marrow transplant does not treat breast cancer whatsoever. In fact, it's very harmful. So, and the end of the story is very tragic, where this individual ended up passing away. But it's because these new treatments, these new kinds of technologies come out, and we all jump on the bandwagon. We want to say, I need that, I want that. But we need to do this in a way that is safe, that is appropriate, that is cost effective, that's at the right place at the right time, so that we as a society can treat diseases that are harmful to us and life-threatening, but do it in a way that is affordable for all of us. Thank you.
Well, I think that there's a lot of questions that arise and potential dialogue here. Do we go till 10? Is that what the... Okay, so we have 15 minutes. I'm going to be sensitive to potentially questions from the audience. Oftentimes, the types of questions, and if I use the prerogative of the moderator to engage here, I think that it's going to come through anyway. If I can get just a sense as to how many people are inclined to ask a question. So if we could, I know there's probably some additional dialogue that we would like to have, but why don't we open it up to some of those questions? We have a gentleman, a question again. Yes.
Yeah, there are students with mics are going around, so definitely speak into the mic so that you can be heard on the webcast. Otherwise, you won't get that.
Hi, thanks. I'm Chuck Norland. I'm a general pediatrician, and very interested in comparing the precision medicine and the focus of healthcare interventions on individuals with the societal implications of public health and the environmental, socioeconomic, social determinants of health, and how we think about investment in those compared to the investments to be made in affecting individual health.
Great question. So in terms of background, one of my favorite slides, which I didn't show, is by Steve Schroeder. He looked at determinants of premature mortality in the United States. And that which we have talked about today, or actually that Mark and I have talked about, I think Eric's view is even a little bit broader, is really focused around 10% of interventions that we do within a healthcare system are considered to have an impact on premature mortality, right? 40% of the effects on premature mortality occur from socio-behavioral interventions, and the list goes on. The role of environment being estimated to be 5 to 10% or the like. So what you've highlighted is very, very important. Let me emphasize that as we as a society look at how we're going to utilize our resources, we think, based on our discussion today, it's critical to focus on improving the quality of our healthcare and our medical care system. With that, though, and certainly as you look at broader definitions of precision medicine, the genetic and, say, environmental and socio-behavioral impacts on health, the other impacts that you have alluded to are vitally important. Obesity, drug addiction, the list goes on. Thank you.
Any other comments?
You did a good job and got a lot of questions.
This gentleman, you had a question? Yes. Oh, okay, you take it. You got it.
We'll go next.
My name's Kent Birmingham. I'm a U of U grad. I'm a patent attorney. It sounds like if you had a futurist up there, they would be telling us that we all need to have our genome mapped, perhaps very early in life, maybe even prenatally, if that can be done. But who's going to pay for that? And how, at this point, as that technology comes online, will the average consumer of medical services be expected to pay for it or get someone to pay for it? Is this going to be like getting inoculations when you go to school and that?
Can I take a first crack at that one? So the cost of getting yourself completely gene sequenced is likely to be under $1,000 within the next couple years, and you'll see it probably decline to $400 or $500. So that will be, at one end, very affordable if you think that's your life. The challenge we have actually is not generating the data. That's where everybody focuses. It's what's actionable out of all that, and how do you create the data over time, the evidence, to know which actions actually make a difference. Because we've had a lot of lifestyle interventions for 30, 40 years that frankly aren't very effective in actually changing people's lifestyles, or otherwise we wouldn't have the obesity problem that we have today. So the real challenge, I don't think, while people focus on the petabytes and all the gene mutations and what that means, the evidence base for which of those really confer risk, and then what are the actions one can take to reduce that risk that actually work, those are the bigger challenges. And I think that ties back to some of the first questioner's points, that we haven't built that connection yet between some of the genotypes, the phenotypes, and then what are the interventions that make a difference that actually change phenotype at the end of the day. Did you?
Any others?
And just a brief one to bring the two questions together, which are both important, so thank you, is that the healthcare system of the future, and I hope that it is here, and I believe we have, according to the Harvard professor Michael Porter, one of the best chances here, is actually to have a very consolidated approach in that regard. What part of big data is really useful information that we can act on, and how can we as a system impact other areas such as the environment, behavioral aspects of health, so that the broader health of the group that we support is better?
Yeah, one of my real fears is that genomics will go the way of nutrition. You know, no one in my family pays any attention to the latest news blurb about a study that shows X will raise your risk of name your disease, or it's a better way to lose weight. The whole field has no credibility anymore. I'm sorry if I've insulted anyone in the room. I probably have, sorry. But we don't want to get to that position on the genomics, and the difference is, will we collect robust, solid evidence that connects these? And there will be the temptation to publish putative results as definitive findings, and I think that's a real risk in the field.
It's clear that we've had a gross distortion on some level of resources in the healthcare economy. We have a $3 trillion healthcare economy by some estimates coming out of the Institute of Medicine and others. 1 trillion of those constitute the absence of any benefit or some benefit with respect to any relationship to the expenditures. A significant portion, as Will pointed out, is associated with overtreatment, and the vignette that you shared, Eric, is very much in line with that kind of, that actually came bubbling up from the patient, which is not rare, by the way. One of the ones in Gwande's piece in Overkill was this Mrs. E, where Gwande actually, as a surgeon, felt that he was ethically challenged in treating this woman because he did a surgery which he felt wasn't necessary. But the orientation of the system, I think coming out of some of the questions, is certainly one to do more within the disease category where we feel as though the latest indications or the latest is going to somehow come up to speed with our expectations. So there's an information flow, both the generation and transfer of it, and then there's a resource, a dollar flow that is parallel. All of those have organizational facets that we have misaligned incentives, and I think that we've touched upon those, some of those here in the talk. That's why it's so complex. So at any rate, more questions.
First of all, congratulations on a series of excellent presentations. To follow up on the first couple questions, I think I want to focus on the last thing you talked about, the remedy grade. How do you deal, and I'm thinking here specifically of MS drugs, with such enormous variability in effectiveness across the different classes of drugs, and yet you're talking about medications that are $50,000, $60,000 plus MRIs and clinical visits and things of that sort? How do you deal with that from a recommendation point of view?
So the things that we've been talking about are that the drug's effectiveness are researched, and that takes many, many years and a lot of approvals before they become available to the public. So one of the assumptions that we make is that the drugs that are on the market are in fact going to treat the diseases that are meant to be treated, and the drug companies need to make up the dollars that they spent in that R&D. So what we are doing, and what remedy grade does, is it provides a lot more information to the physician and to the individual about the effectiveness of those drugs. Mm-hmm. So that the individual and the physician can make that decision together of what is the best course of treatment for any disease, not just specifically to MS, but for all diseases, for anything that is being treated. So it's providing that information in a more real-time manner, getting the studies and the outcomes and all those things in a very simple way so that the physician and the patient can have that meaningful dialogue together.
Can I add one thing onto that, sure. Just building on? Many of the guidelines that we put forward don't really take into account patient preference at all. And patients do have different preferences of what kind of symptom alleviation is most important to them. Is it bending down to pick up a grandkid, or is it being able to run the triathlon? I mean, there's all different sorts of grades of what people want and what toxicities and adverse events they want to endure to get those other reliefs. We in general do a poor job, whether it's from the provider standpoint or the information provided by industry or insurance companies, to really help patients understand what those full treatment trade-offs are. And I think if we did more of that, it would make our lives a little more complicated, but we'd have much better outcomes at the end of the day.
A question regarding economics. John Besant, dermatologist. When I was in high school in debate, in 1964, the resolution was Social Security benefits should be extended to include complete medical care. At that time, I could find, and we all could find, experts on both sides, if it was appealed to experts, data on both sides from reputable people, and the beat goes on. When I saw Jonathan Gruber, your colleague, before Congress,
Oh, please, I'm
That-
sorry.
it was abysmal. He used the same high school techniques, MIT professor, so he said that over and over, appeal to authority, and then he said complex computer analysis, so he was appealing to complexity. He was using all this smokescreen jazz, and nothing like Bertrand Russell described Keynes. He said that when he had an engagement with Keynes, he felt as though he was taking his life in his own hands because he was such a sharp analytical mind. Now, how can we separate truth from fiction when it comes to the economics of all of this? As an aside, my wife is from Finland, and one of your Bostonians, Marcia Angel, is a big proponent, she and her former husband, of a single-payer system, physicians being salaried, about $125K a year, I think is what they threw out. And that's less probably than you make, isn't it, Will, with your presidential endowment?
I think so.
Yeah, I'm sure.
I have to ask Julie.
So, anyway, my wife, again, being from Finland, they seem to be quite happy with a single-payer system. A nephrologist from the University of Utah who did a Mormon mission overseeing the missionaries there in Germany, he said in Germany, about half the docs were quacks, about half were good to very good, but they always had a private practice where you walked in. He said he would walk around with a pocket full of 50 and 100 euro notes. And if the missionary needed any kind of care, he went to the Goethe Hospital. He knew the good people, and he would go in, and the secretary, he would explain what he wanted, and he would pull out the X number of bills, and she just said, yeah. And for instance, a missionary had a big crunch, had oculoplasty.
So that counts as corruption in the German system. They were supposed to provide it for free, but needed a 1,500 euro bribe to treat the person?
It's one of these, almost all of them had these private practices, so-called, where it was cash and carry. So I doubt that there was any bookkeeping. And so it was all in pocket. And
Oh, yes. Okay, I just want to understand.
so if you have something, if you want to pay less, far less, he gave the example of a missionary that was in a crunch. He had to have an oculoplastic person come in, neurosurgeon, and so on. And the total cost of all of the care, everything, was about $10,000. Here, it would have been 10 times or more that. But again, this is all with cash.
So the question was truth or fiction?
Yeah, truth or fiction in terms of what we're hearing about the economics of healthcare and what you're presenting and so on. Because one of your former MIT alumni, Richard Feynman, made the famous statement, everyone lies, all scientists lie, and so on. So
Well, I'm glad you broadened it there. I thought you were, while criticizing my colleague for appealing to authority, I thought you were trying to do the other logical approach of trying to slime me by making me associated with people I don't work with, right, but have the same brand. So I knew you would never do such a thing, but it was coming close there. So it comes down to evidence and trust, right? So if you generate evidence, what you've just said is many facts we don't trust anymore. I made sort of the same comment about some of the nutrition studies, right? So if you don't have trust amongst the players, which includes probably some ways to check up on each other, transparency is a good place to start, but also real peer review and real understanding of what the numbers underneath mean. And I think you need some real evidence and understanding that. Those are good places to start. The other point that you bring up, which is often not talked about, but I'm glad you did, is you often see these comparisons of U.S. healthcare costs versus the rest of the world and how the rest of the world is so much cheaper. About 2/3 to 3/4 of that is factor pricing differences. which is they pay their doctors $100,000 a year, and we pay ours about $300,000 a year. So America costs three times as much on the physician side, but winds up with the same number of man hours, right? And so if you really do what in economics we call purchasing power parity, and you readjusted Europe, they're not that much cheaper than we are. They just pay people a lot less. And they also keep a lot of their facilities costs off books, so they don't put in their hospital capital costs as part of their healthcare costs.
We've busted through the barrier at the end of the session. Do we have time for one last piece? Oh, we have time for Dr. Vivian Lee.
That's a lot of pressure. I bet I have a good question. Thank you for that outstanding panel. I'm actually very interested in the dialogue between two of you in terms of the issue of, I thought, Mark, your economic presentation was really, really compelling, and I was interested in Eric's response to it. Because while you said there's no incentive for us to develop companion diagnostics for drugs that are already on the market, from my perspective, from the outside, I would think that the insurance industry would be very motivated to develop companion diagnostics after the fact in order to reduce that 83 they have to reimburse to 1. So I wonder about whether Cambia or Blue Cross, whether there's been much conversation within the insurance industry to help develop companion diagnostics or to develop more precision medicine.
One of the things that we are developing with providers in coordination with them is a common care plan. So what you see on the insurance side is a whole cadre of nurse case managers that are working with individuals who have certain diseases, and we call them, some may term that harassment, but we call them to make sure that they are getting the treatment that they need in the follow-up care. And then you also have the physician or the hospital who's also doing the same kind of activity, which is very duplicative and very expensive. So in terms of addressing that 1 billion, it's a very big number that, who's going to pay for. So you address the things that you can influence and the things that you can address. And so where we focus our attention is how can we remove some of the duplication that's occurring. And so we have, like I was describing, this common care plan where we'll work with physicians, practices, and our care managers and have one treatment plan and one schedule of who's going to be calling and following up so that we can eliminate some of that waste that's in the healthcare system. Some of the other things that we are doing is that we do pay for clinical trials, at least the treatment, the routine treatment of clinical trials. That was something that was in the Affordable Care Act that insurance companies do pay for that. So we're now part of that, that evolution of trying to figure out what can, some of those trials, what are the best treatments possible so that we now have a little bit more information, a little bit more skin in the game so that we're helping make the best decisions for the patients.
So, Vivian, great point. I have another whole set of slides I won't bore you with about some of that. But one quick anecdote and one statement. Insurance companies used to do that. The first mammogram trial was funded by a New York insurance company. It was not funded by either the instrument maker, nor was it funded by the healthcare providers, nor was it the government. It was an insurance company that paid for the first mammogram risk identification study. So they had that heritage. They've lost it over the last number of years. Free rider issues, all sorts of reasons, cultural issues about what they thought their role in society was to price and pass risk, not to change risk, a whole bunch of cultural things. But I think they're beginning to regain that a bit, so I think there's hope. The other part that I would say that's the provocative side, and builds on the single payer comments that we heard over here, is if you look at NASA and our space efforts, and if you look at the military, we have an integrated government supply chain from innovation through purchasing and distribution. NASA decides they want to go to Mars, they tell different companies to develop certain parts of it, they pay for that R&D work, they have competitive bids as who gets to build the rockets that you've seen lately. Then they decide what they want to do, and they distribute it. We do the same thing with everything from guns to missiles, right? But for healthcare, even though Medicare pays at the end, and NIH pays at the beginning, and FDA regulates throughout, we have no connection or coordination upon what does Medicare really think the needs are, that therefore NIH ought to be funding, that FDA ought to be understanding the regulatory path. And just like Lockheed and Boeing and others play really important roles through that whole process, and private sector is important, it is much more connected. And in healthcare in the United States, for whatever reason, we haven't grown that way, but we have in other parts of the government, and those work pretty well. We have the best military in the world through an integrated product development process, and we don't do it in healthcare, and I just don't quite understand.
Very nice. I think that some of that actually will be, it's a nice way to end, because it really anticipates some of the later sessions, I think, today with respect to regulation process. So thanks very much to the panel. Sorry we went over.
Bear with us for just 2 minutes as we do a quick scene change and switch to the next panel. There will be a coffee break after the next panel, but obviously if you need to grab something or step out, please come back. We'll be resuming in about 2 minutes.
George, how do you want us? 1, 2, 3 in order of presentation?
Sure. So we can have, looks like, what, Rachel, Hans, and you?
Sure.
I think, yeah.
Actually, Hans, you don't have...
Testing. Hello?
So much.
Why don't we do it the other way? Because you don't have slides. You have slides? You do have slides. Okay. Then, Hans, you don't have slides, right? So
Testing.
Let me put myself in the middle because Hans doesn't have slides, and this way we'll both be close to the clicker. There is a clicker here, right?
We can find one. I'm not sure if there is or not.
Is there a click? Right.
Yeah, you can hit the space bar or forth. Yeah,
Testing.
I believe some of them left there, so.
Yep.
So Michael, if you can see if people did leave their gift behind, just get the stuff out.
Okay, let's just crank it all the way up. Is it port 6?
The things with the ribbons are like a gift to you guys.
Where do you want?
She's nowhere. She's out.
Oh, okay.
Put it away. So it's
Okay, let me make sure I have everybody's.
Right.
You have one?
I gave it to you earlier. It's the Sarnoff, Utah, right there at the bottom right.
Okay.
Nice to meet you as well. Hi,
Josh,
How are you? Nice to
Thanks
meet
so
you.
much.
Oh, yeah,
yours
of
is on
course.
here.
It's so nice to meet, put a face to all the emails. So, I hope everything's been okay.
It really is.
Oh, good. I'm glad. Good.
Yep.
Okay, well, welcome.
So you're going to open and figure it out?
So it's going to be you, Hans.
So I brought for us to celebrate some Garrett's Yum caramel corn. Do you know Garrett's caramel corn?
All right, so we've got your two.
Wonderful.
Once with
I
me,
definitely
and
would look at
we'll
these
have that.
before. If you want to put that in your seat, you're welcome. Yeah, oh, if you want to put the gift with your bags and whatever you're.
I'm just so curious what it is.
Just click that one off, go to mine, right? Right. Double click?
Just single click there.
Single click to the left. Great.
Space bar will also.
Okay, great. Thanks.
And we will blink the screen while you're.
Testing. Testing. 1, 2, 3.
Seems like it works. I'll stick mine over on this side too.
Okay.
Do we need another chair up here, Maria?
No, we don't. She's back at withdraw.
Okay.
Never made it.
Amelia.
She's got a good excuse.
Okay. Are we set? Okay, great. If we could try to ask people to take their seats, we'll try to catch up a bit and get started with the next panel. here second. 1, 2, 1, 2. Okay. Okay. Well, welcome back. Thanks so much for joining us. This panel is called Patenting Precision Medicine, and the subject is fairly self-explanatory. What do the patent laws and recent developments in case law in the United States, particularly the Supreme Court, have to say about this new field of invention and technology? And I think you'll see in the discussion that this ties in very closely with what the last panel discussed. The cost of therapies and diagnostics in this country is tied very much to the patent regimes, and we saw on Mark's slide very interesting differences in pricing between therapeutics when they were patented and not, and that has a lot to do with what we'll be talking about today. So I have fantastic panelists who will share their experience and their wisdom with us. To my left is Rachel Slade at Michael Best and Friedrich, a patent specialist, attorney. To her left is Joshua Sarnoff, professor of law at DePaul University School of Law. And then at the far end of the table is Hans Sauer, who is the chief IP counsel at the Biotechnology Industry Organization, or BIO, in Washington, D.C. So we will start with Rachel, and I turn the floor over to you.
All right. Thank you, Professor Contreras. It's a pleasure to be here. It's an honor. And as an alum of the law school here, I must say this new facility is absolutely gorgeous. So thank you. What I'm going to be doing is kind of setting up a general baseline of hopefully to bring some of the non-patent people up to speed. And I'm going to be focusing mostly on the Supreme Court jurisprudence in the past, 25 years or so, which has really changed significantly lately and is impacting precision medicine specifically. All right, first, why are there patents? The federal government about 200 years ago set up the patent system, and in exchange for an inventor providing all the gory details about their invention, they can obtain a limited monopoly, 20-year term right now for those inventions. Ideally, back then and even now, the plan was that the patents can act as an incentive to promote investment in research. And these days, that comes as, if you're a startup company, if you're trying to get some funding, you better have some tangible IP to show, and that usually is evidenced by patents and patent applications. On the flip side, and this is the public policy issue, the patent system and granting patents to inventors can sometimes limit or delay the public use of this technology. And there is a large concern then as now, and perhaps even more now, that patents can impede rather than promote scientific progress. So what the heck can be patented? USC Section 101, inventions patentable, outlined here, short and sweet. Whoever discovers or invents any new and useful process, machine, manufacture, or composition of matter, or any new and useful improvement thereof, can obtain a patent therefor. So this outlines kind of the four main patentable type inventions: a process, that's usually in our world, a method of use, method of treatment, a machine, a manufacturer, or a composition of matter. So composition of matter is usually a chemical entity or DNA entity. What can't be patented? And obviously, we're going to be talking about patentable subject matter, so this is it. Non-patentable subject matter are laws of nature, natural phenomena, and abstract ideas. These are not patentable subject matter under the code. And I'm going to be getting into some of these details, obviously, in a little bit. And again, this goes back to what is allowed to have a monopoly. Whoever owns a patent can exclude others from making, using, selling that invention. These types of ideas, subject matter, are so important that nobody's allowed to get a patent. And so that's why there's excluded from patentability. And who the heck makes these decisions anyway? Supreme Court of the United States actually has the last say. And they, in general, try to guide the United States Court of Appeals for the Federal Circuit. They try to. They're commonly referred to as the Federal Circuit. And then that's kind of a specialized patent court for the United States. So they deal with most of the intellectual property patentability cases. And then they, in turn, their decisions will guide how the USPTO, Patent and Trademark Office, interacts and what they can grant patents on. And as a patent practitioner myself, I deal directly with the USPTO. So I'm going to be doing just a very broad overview of kind of some history on the Supreme Court cases that are relevant to precision medicine, and some of the ancient history. And for cultural context here, this isn't that old. I think it was Star Wars movie came out in 1977, and The Empire Strikes Back came out in 1980, 81, something like that. So this is relatively recent, but in our world, it's ancient history. So I'm going to go back through these a little bit opposite. I'll start at the bottom. The Diamond v. Deere case, referred to as Deere usually, reiterated what these exceptions to the patentability subject matter were. The laws of nature, natural phenomena, and abstract ideas are not patentable. However, an application of a natural law to a process or a method may in fact be patentable. The next one up, the middle one, Diamond v. Chakrabarty, near and dear to my heart, was probably the first case where a biologically engineered organism was found to be patentable. They found this to be patentable because it wasn't found in nature. However, they also reiterated in the decision, products of nature are not created, and again, focusing on the public policy aspect, manifestations of these natural laws, abstract ideas, are free to all and reserved exclusively to none. And then back in even 1978, even before the Empire Struck Back, Parker v. Fluke was there. And that case, again, reiterated that you need a law of nature is not patentable, but inventive application of the law of nature may be. And again, beware, it's not crafty claim drafting efforts that can get it to be patentable if it's still a law of nature. And you have, for example, the best patent lawyer, patent drafter, claim drafter in the world, you still can't get it. Then in more modern history, slightly seemingly irrelevant, was Bilski v. Kapos in 2010 and Alice v. CLS Bank in 2014. And these two cases were directed towards business method patents. And so you'd think at first, well, why is this relevant? But they are somewhat. In Bilski v. Kapos, the claims were directed toward a method of using a mathematical formula for hedging, attenuating risk. And the Supreme Court said, hey, nope, that's an abstract idea. It's not patentable subject matter. But they reiterated the fact that not all business methods may be abstract ideas. So some of them may, in fact, be patentable. Great for the business, the banking industry. Not so relevant, you'd think, to precision medicine. And then Alice case in 2014 involved methods which used a scheme for mitigating financial risk, but they performed it on a computer. And so that was an abstract idea which was performed on a computer. And so that was, the thought was, would that be an inventive concept performing it on an idea? And that, of course, was bounced as well. It's not patentable subject matter. You must have an additional inventive concept if you're going to be trying to take a patent ineligible subject matter idea or concept and bring it into a patentable subject matter. It's not just, you can't just do anything to it. You have to do something to it, but it's got to be an inventive concept. And now to the more relevant modern history. Three cases that primarily seem to be important for precision medicine. LabCorp v. Metabolite, which was famously not decided in 2006. Mayo v. Prometheus in 2012, and then the Association for Molecular Pathology v. Myriad Genetics in 2013. The first two cases here involved claims, method of use claims, method claims that correlated in LabCorp levels of homocysteine and vitamins in the body. Mayo v. Prometheus was more of an analysis of drug metabolite levels so that you could calibrate dosages of a patient. And then the Myriad Genetics case involved composition of matter claims with isolated DNA and cDNA. And as a disclaimer, I just want to let everybody know that I worked for a subsidiary of Myriad Genetics before going to law school, and actually I noticed some former Meridians out in the audience as well. And believe it or not, your last panel has an inventor from some of these patents at issue from Myriad Genetics. All right, so what the heck is LabCorp all about? Supreme Court granted cert. The issues were fully briefed, but then they dismissed the case, which is why it was not decided in 2006. Claims at issue involved methods for detecting deficiencies of these vitamins in a warm-blooded animal, where you assayed a body fluid for the levels of total homocysteine, and you correlated that level to whether or not you needed to give more of this vitamin or less of that vitamin. This relationship between homocysteine levels and the vitamin deficiency was known in medicine before this was patented. Unfortunately, this wasn't decided. However, the dismissal was dissented to by 3 justices saying, hey, patentable subject matter needs clarification. Hello, hello, hello. This is the canary saying, I'm not quite dead yet, but look at me. And notably, Justice Breyer, in his dissent, said the process is no more than an instruction to read some numbers in light of medical knowledge. Nothing really happened then until Mayo v. Prometheus in 2012. This is a typical claim. It's a little bit more involved. However, it's basically a method of treating a gastrointestinal disorder using a drug, and what you're doing is administering the drug, you're watching some metabolites, and then you determine what the level of those metabolites is in a patient's blood, and if it's very low, if it's less than this amount, then you need to increase the amount of the drug given to the patient. And if it's more than about this amount, you need to cut it down. And if you don't give enough drug, obviously it's not going to be effective. If you give too much drug, it can be toxic and you don't want to kill your patient. This has significant aspects in the personalized medicine aspect because metabolism of drugs is very much relevant to your individual profile of your drug metabolite or your metabolizing enzymes. The Supreme Court, however, said the relationship between the concentration of these metabolites in the blood and optimizing the drug dosage is just a law of nature. So the claimed process is not patentable unless it has an additional feature, an inventive additional feature to provide assurance that the process is really an application. It's not patentable unless you have an additional feature that shows that it's not just an application of the natural law. And again, crafty claim drafters, beware, don't monopolize these correlations. And then finally, AMP v. Myriad in 2013. Again, this is a little bit different. The claims at issue here were composition of matter claims. And these were directed towards isolated DNA and cDNA for the BRCA1 and BRCA2 genes. The Supreme Court found that the isolated DNA is not patentable subject matter because that's found as is in human bodies and it's a natural phenomena. This was surprising because this was very different, a 180-degree turn from what patent policy had been before. So until then, Human Genome Sciences, Myriad, all the other gene discovery companies were able to do this and grant patents. This is also contrary to most of the rest of the world, where isolated DNA is considered patentable subject matter. Supreme Court did determine that claims directed toward the cDNA are patentable subject matter because those slices of DNA are not found naturally in the body. In dicta, they also said that the following types of things would likely be patentable subject matter: methods using the isolated DNA and new applications of knowledge about these two genes and mutated or non-natural DNA. So where does this leave us? What do I tell my clients? There's clearly case law still in flux, and it's radically different than before, and it'll be an interesting next couple of years. Therapeutic methods seem to be patentable subject matter, but maybe not so much diagnostic methods. It's still getting worked out. Regardless, clients can expect narrower claims for sure, with multiple additional concepts added. The days of getting a nice broad claim set that you can use defensively to, discourage competitors from entering your area, those days are long gone, unfortunately. And this also provides basically another tool in the tool chest for potential competitors to try to torpedo your patents. So expect litigation from competitors. They now have a slot, a way of another way of saying your patent's not valid because it's not patentable subject matter, and this very much will impact, biomarker technology, analytical techniques, and those patentable, the business method patents will definitely affect clinical data usage and patient data usage. So all this stuff is a brand new world, what do they say, and it'll be interesting to see how it works out.
Rachel, thank you very much. We'll now ask Hans Sauer to tell us a little bit about what he's seeing from his perspective in the biotechnology industry, and especially how the lower courts, including that Federal Circuit, may be dealing with these Supreme Court decisions that have come out a few years ago, and what impact that's having on the ground in the industry.
Yes, so I'm sure many in the audience have wondered, well, what's so hard to deal with what Rachel explained? It all seems straightforward, right? If you find something in nature, like a human gene, of course you can't patent that. That shouldn't be so difficult to apply. Or likewise, if you identify a law of nature, of course you can't patent something like E equals mc squared or the law of gravity. That all doesn't seem so hard. I can tell you, though, among patent lawyers, or kind of a close-knit community, there is not a subject of substantive law that is being discussed and debated as hotly and as intently as this question. Right? So to be clear, for those of you who aren't patent lawyers, a patent can be defective for a large number of reasons. Right? What we've been talking about was only one particular reason why a patent can be invalid or why a patent application might be denied. The normal reasons we think of when we try to decide whether a patent is a good and valid patent or a bad and invalid patent that should never have been granted, those normal reasons usually involve comparing what's claimed in the patent to pre-existing technology that existed at the time the patent was applied for, right? Was this invention new at the time they applied for the patent, right? If it wasn't, then the patent shouldn't have been granted. That makes a lot of sense. That's always been the law. It's intuitively clear. Was this invention perhaps obvious to other skilled scientists or engineers at the time the patent was applied for, right? If it wasn't really a big improvement over pre-existing technology, then maybe the patent shouldn't have been granted. That too, the concept of obviousness of patents makes a lot of sense. And in fact, most patents go down, if they go down after being attacked for those reasons that I described. It used to be very uncommon for a patent to fall for the reasons that Rachel described, right? Rachel described the section of the patent that talks about the kinds of things that would even be considered for patenting, whether they're new in technology or not, whether they were previously known or not. It's just the kind of thing or not the kind of thing that we will even let through the door in the patent office. So just like, for example, one cannot go and ask for a patent on a musical composition or a beautiful painting. It's just not the kind of thing that we give patents for. There is this little section in the Patent Act that says, patents are only available for compositions of matter. That means things that are composed by man as opposed to found in nature, like chemicals and a new plant found in the wild or a new mineral found in the earth wasn't manufactured or made by anyone. And so, of course, it's not patentable. Everybody has agreed with that for a very long time. Other things that are patentable, right? Machines, new processes, and the like. So Rachel described all that. And that never used to be much of a question in patent law. Right? Occasionally, people would come into the patent office and ask for a patent on something very strange, like a signal for watermarking a document of sorts, and it could be an electronic document, but generally people, so in instances like that, Courts would say, what is a signal? It's not an article of manufacture, it's not a chemical composition, it's certainly not a machine, and it's not an improvement to any of these things. So it does seem to fall outside the categories of things that should be patented. So out you go, it's not the kind of thing that's patentable. People were always able to follow the logic of these decisions until the Supreme Court started to apply this section. And over the last couple of years, as Rachel described, the Supreme Court has looked into this particular area of patent law, patent-eligible subject matter, with renewed interest. There have been 4 decisions in 5 years. Well, that's a lot. And in fact, over the last 30 years, the Supreme Court has looked into that section of the Patent Act more than it has looked into any other provision of substantive patent law. So the other things I talked about, newness of an invention or obviousness of an invention, have received, even though they're so much more important in patent practice, have received less interest from the Supreme Court than this one provision which we always thought was really arcane, not comfortable to apply, not very useful in patent examination practice, not very useful in litigation. And the Supreme Court has worked this section into something that now has real teeth in patent litigation. A lot of patents go down. A lot of patent applications are being denied, and I'm through half my time before I even got to the issue of how does industry, how do businesses, and how do those who invest in healthcare innovation react to this development of the law. So of the cases that Rachel showed, right, I think maybe let me start with the easier one, if you will, to illustrate its impact. In the myriad so-called gene patent case that went to the Supreme Court said that a claim to an isolated human DNA sequence is not the kind of thing that's patentable because it's too close to what exists naturally on all our own chromosomes and the like. Right? So even though Myriad didn't snip the gene out of anyone's chromosome, they cloned it in yeast and bacteria, it is still a human DNA sequence in the way in which it was claimed, and the Supreme Court said that's not different enough from what occurs on our chromosomes. It should be unpatentable for the same reason that we don't allow patents on iron ore that's just extracted from the ground, right? But you didn't do anything else to it, or for the same reason that we don't allow patents on plants that are found in the wild, right? The gene is a bit like a plant that's found in the wild, in the Supreme Court's words. So the decision concluded by saying, well, DNA is not patentable merely because it was isolated from a natural source and isolated away from surrounding genetic material. So the Patent Office then very quickly, and patent examiners very quickly started to wonder, well, why just human DNA? Right? If human DNA isn't patentable because it was isolated from a natural source, then why not the DNA of an obscure fungus that was never before known to man, but nonetheless, right, should also not be patentable? So it's not patentable. What about the antibiotic that comes from the same fungus? If you can't patent the DNA you get from the fungus, you can't patent the novel antibiotic that's discovered in that fungus. So novel antibiotic molecules that were always patentable if claimed in the form of purified preparations in the Patent Office became unpatentable in the PTO, people's patent applications became rejected. What about industrial enzymes that are found in environmental samples? Companies that have nothing to do with human genes or genetic diagnostic testing are patenting enzymes for grain ethanol production, even enzymes that go into laundry detergents. And those enzymes, would you know it, are discovered in obscure microbes, sometimes discovered in extreme environments. So there are actually companies that go and they look at hot acidic springs or other extreme environments. Enzymes today are discovered in like Arctic ponds, in undersea vents, And the enzymes that are produced by microbes that live there work under industrial conditions that nobody would have thought possible, right? So you can get enzymatic activity above boiling temperature in high acid environments, under high pressure, or enzymes that work at very cold temperatures. So it's great, I think, for industrial applications. Things like that, if they're found originally in a natural environment, are no longer patentable. So, right? So there's, I think, a lot of surprise among broader segments of the biotech industry who see today, 2.5 years after the Myriad decision, that patent applications are being rejected and that patents are being invalidated that nobody would have thought at the time would be vulnerable when the Supreme Court rendered these decisions. And I think the development that I'm describing is more easily traced and more transparently traced when you look at subsequent court decisions. Myriad itself had been told repeatedly when the Myriad case was percolating up through the courts and going to the Supreme Court that the particular claims that were being challenged by the ACLU were probably unpatentable anyway because they were otherwise too broad. But it was okay to strike them down under this Section 101 of the Patent Act as well, because it kind of fit into the framework that the Supreme Court was developing and that the Court of Appeals for the Federal Circuit, the next lower federal court, had developed. Right. So, for example, Myriad had not only claims to purified DNA preparations, they also had claims to the application of those, like diagnostic methods. And some of these claims were stated in very broad and generalized, almost disembodied terms. Right? It's like determine the sequence of the BRCA gene in a patient, and if there is a difference between that patient sequence and the wild-type sequence, then you can make a conclusion that the patient may be at an increased risk. Right? Nobody was ever treated, nothing's ever really tested. And so these very broad claims were invalidated because they were vulnerable for a number of reasons, including Section 101 that Rachel described. But along the way, Myriad had also been told, well, you have narrower claims. You have like a number of patents with lots of different claims. So you have narrower, much more particularized claims. That's the way you should have claimed it. And those will be just fine. Right? So you shouldn't worry that your claims are being invalidated because you have lots of other claims. And these things were said even by appellate judges. These things were quoted with approval. These statements were quoted with approval by the Supreme Court in its decision. Right? Myriad has other claims that survive. So it's not a proposition that somebody who discovers a new gene and seeks to patent diagnostic applications thereof, nobody says you can't get patents on these things at all. It's just Myriad's overbroad claims that were being struck down. Okay, so Myriad took the court by its words and said, well, okay, if we have lots of other claims that you tell us are probably good, well, we just have a number of competitors that enter the space of BRCA testing. We think they infringe some of these other claims that were never invalidated of ours. They sued on those. So that case then also went up to the courts, went back to the Federal Circuit, and the Federal Circuit struck them down as well. Right? Something had happened in the meantime from these benign statements of, oh, we're only striking down the very broadest claims relating to genetic diagnostic testing, those that are disembodied and abstract. From that to striking down Myriad's much more particularized claims, I think we had undergone a development in the courts. The Supreme Court had revisited this question again in a software case, the Alice case that you mentioned. Right? And so when Myriad came back saying, you told us that some of our other claims are good, the court no longer had an answer of which claims those might be. Right? So to give you an example of, I think, where the law is right now, and maybe I'll mostly use this second Myriad case in the Federal Circuit. All right, so Myriad had claims not to isolated DNA, isolated human DNA, which may have included DNA that's isolated from a live biological sample or from somebody's blood sample. They brought claims to primers for DNA, PCR primers, which come in pairs. Right? or claims to probes that can be used for hybridization. Right? So these are manifestly not isolated or purified from nature. They're always synthetic. They're always designed with particular parameters in mind. In fact, there's very much of an art in designing primer pairs for PCR. Right? So they're synthesized, they're short, they don't occur naturally, and especially they're single-stranded and they don't occur naturally in combination, in the combination in which they were claimed. So there was really no question, or there wouldn't have been a question 2 years previously that a primer pair for PCR, that's clearly not a product of nature. I mean, by no stretch of the imagination. By the time the second Myriad case had come to the Supreme Court, the law had evolved in a way where the judges said, well, you know, the Supreme Court actually didn't say that the distinction is between synthetically made and extracted from nature. The Supreme Court only said, in fact, there was the Dolly the Sheep case, right, which was the big intervening case. So anyway, the Federal Circuit said, here's how the Supreme Court jurisprudence works. Right? The Supreme Court said things that occur in nature are unpatentable. It doesn't matter whether they are in fact made artificially. If you make an artificial copy of something that occurs in nature, it's also not patentable. Single-stranded DNA is just like double-stranded DNA, except it's isolated away from its other strand. And if you package two pieces together in a vial, that's a pair of primers for PCR, then each is unpatentable on its own, and when you put them together, they're both unpatentable together. Right? There's just nothing here. Okay, Myriad also had other claims, not generally to detecting somebody's sequence and comparing the sequence to a wild type and drawing a conclusion. They had more particularized claims saying, well, detect the sequence of the BRCA1 gene using primer pairs, doing PCR, doing multiple steps, and so on. So it looked much more like a real laboratory method. And in that respect, the Federal Circuit said, we still lack an inventive concept. You're still just detecting something that occurs in nature. That which you're detecting was unknown before you discovered it, but that doesn't impart patentability on your claim. Right? Just the fact that you discovered something cannot make your thing patentable, your invention and your process and your lab procedure. So we have to look at what else there is in this claim to make it patentable, and we don't see anything because anything else that's in your patent claim, in your process, was routine and well-validated conventional technology. You're using PCR, or you're using hybridization, or northern blotting, or whatever it may be. These things have all been invented before, and just because you apply them to something new, to make a diagnosis that wouldn't have been possible before, that doesn't make it an invention. So we are left, I really want to wrap up fast, but we are left right now at a point where about half the judges on the Court of Appeals for the Federal Circuit, so that's the next lower court below the Supreme Court, through which all patent appeals go, about half the judges on this court are at this time, while they're obedient to the Supreme Court's mandate, very concerned that the Supreme Court's decisions have provided so little guidance that they can't tell, you know, what outer bounds there are to the application of this theory. So in other words, they don't know how a diagnostic method can be patentable unless you invent basically a new laboratory procedure. Judge Dyke, who is not known for giving people a break in the Federal Circuit, has said, even I worry that the Supreme Court seems to have said that if you discover something new, either in nature or you discover something new in medicine about the way a drug is metabolized or about the way a person's physiology predisposes them to react to a drug, right? If you make these kinds of discoveries, that those things can never make a diagnostic procedure patentable, right? You basically, the only way you can get a patent in diagnostics today is if you invent basically a new research tool, right? But the things that are discovered with that research tool cannot be patentable under Section 101. I'm paraphrasing, and people might debate, but I'm trying to give you the basic impression, and that, I think, leads to a lot of concern among jurists, even among judges, who feel that while the Supreme Court seems to have given this direction, and they have to follow it, that this direction may be pointing the wrong way, and we may be going not where we should be going, right? And maybe we can talk a little later about some anecdotes about how like real-life businesses have responded to this that I've heard. So thanks for now.
Perfect. No, we definitely would like to get back to that. But Professor Sarnoff, I turn it over to you for some additional light on this topic.
So first, thanks to George for the invitation, to Aaron Reardon for coordinating, and it is always a pleasure to be on the panels with Hans, and also to be on the panel with Rachel for the first time. I'm going to take something like a skunk at the picnic approach, because I'm going to focus on some of the downside of patenting genes, diagnostics, and other applications of discoveries of nature that relate to genetic information, other natural phenomenon. I'm not going to focus specifically in these downsides on product pricing and patient access, which ties back to a little bit of what Mark and Will were talking about, but more about the discovery process itself. And in that regard, I think, as you just heard from Hans, this really is a critically important area, and I'll come back to patent-eligible subject matter at the end. Do we want to fund the discoveries of nature through the patent system or not? That's really what's at issue here. For various reasons, as you'll hear at the end, I disagree with Hans and a little bit with Rachel's description of the history and what the actual standard is, that this stuff has actually been the standard for a very long time. And the Federal Circuit actually changed much of it, as well as the Supreme Court in the Deere case. I also need to make the caveat that I represented the AMA in both of its briefs below, in the lower courts in the Myriad case, and AARP in the Supreme Court in the LabCorp case, and law professors in the Bilski, Myriad, and Mayo cases. So with that, let me broaden the focus a little bit to the Bayh-Dole Act. As many of you know, in 1980, the Bayh-Dole Act created a uniform federal policy for universities and small businesses, later large businesses by executive order, to take title to the inventions that were made in the course of research with federal grant and contract money. The premise of the act was that the government wasn't good at developing products, socially useful products, from the basic research which the government held patents for, and that the research wouldn't have sufficient commercial incentives to actually reach the market to develop products otherwise. Much of the academic research around the Bayh-Dole Act actually shows there's been a tremendous expansion of product development, as well as commercial spin-offs from academia and consequent growth of academic industry collaborations as a result of the Bayh-Dole Act. And to that extent, the Bayh-Dole Act has been a tremendous success. However, on the downside, when you start looking at funding targets and other things, it's recognized that reliance on the private sector for commercial development has changed government research funding decisions. Bayh-Dole Act has certainly contributed to what you see up here, which is the reduced share of funding provided by the public sector compared to the private sector over time. Since 1978, non-federal funding of R&D has exceeded federal funding as a percentage of GDP, and the disparity is growing. Obviously, this affects the kind of research targets that is looked at as they increasingly focus on research that has significant commercial profit potential rather than social welfare enhancement potential. This is true both because of substitution effects of relying on the business sector to provide the funding, as we increasingly oppose taxation and government expansion in our market system, but also because federal research is increasingly being performed by the business sectors or by academics having business considerations in mind. So one thing is the targets that we fund that has changed. Another thing is it shifted the norms of science itself, particularly in the university system. There's some evidence of normative shifts in regard to Mertonian norms of open and collaborative science because of the focus on patenting and monetization. I'll return to some of the downside consequences of that when I talk about the experimental use exception in a minute. But the normative effects go well beyond patenting to sharing of materials, data, and other forms of collaboration. There are also additional delays in publication as commercial collaborators and funders, including government funders of the information, need to review and research scientific discoveries for potential patenting and prepare and file patent applications before these things can be published and potentially lose worldwide rights. These opportunity costs are hard to document and harder still to value, but they're likely substantial. Again, they just don't observe them. Similarly, their normative shifts go beyond simply having immediately commercialization in mind, being less willing to share and collaborate. For one example, think about how the commercial potential from patenting and spin-off changes the willingness of star scientists to stay at their universities or to remain in academia at all when they can move to a spin-off and make millions. One substantial opportunity cost from that is graduate student training. And again, all of these things are hard to document and harder still to value. Of course, there's always quality of life, too, just from the perspective of a former law firm lawyer. The change from the law firms to a business model from a trust model, I think, has led to lack of security, constant stress and competitiveness, and the opportunity costs of lack of quality work. I think some of those things may happen in the scientific discovery stuff, as well as there's constant cost pressure and underbidding. Finally, there is the Bayh-Dole patenting efforts to monetize around universities' discoveries. And there, it's been well documented that university and patenting and technology transfer activities are expensive. A few well-funded major research institutions have extensive portfolios and derive substantial revenue from them. It still remains true that most universities lose money on these activities. And stated differently, patenting is like a lottery for universities with regressive effects that harm those least able to engage in activity. And it's because of the prospect of a big payoff, they seem to be unable to stay out of trying to play the game. Okay, let's turn to experimental use and the big picture of scientific R&D activities to look at how the actual patents affect scientists. In a case called Roche back in 1984, Roche v. Bolar, the United States Court of Appeals for the Federal Circuit, which you heard was the intermediate appellate court that was lobbied for by patent lawyers to create national uniformity, expand respect for patent rights. The Federal Circuit in the Roche case basically said that it was a violation of patent rights for a generic drug producer to perform stability, dissolution, bioequivalency, and blood serum analyses using a patented drug so as to seek approval by the FDA before the patent expired. Specifically, the Federal Circuit, and you can see that's the 271A language, what the standard is for anyone who makes, uses, or sells a patented invention. So what they said was it violated the use right to use patented inventions to get FDA approval for generics. So specifically, go back up. Specifically, the Federal Circuit held that the traditional experimental use exception to infringement, which was an interpretation of this language, and the court referred to as a so-called experimental use defense, didn't apply because the generic was engaged in commercial activity with patented invention, i.e. it performed the experiment solely for business reasons, and was further held that the experimental use exception was severely limited to amusement, to satisfy idle curiosity, or for strictly philosophical inquiry. Because of the significant delays that would accrue to generics if they had to wait until after the patent expires to actually perform comparison studies and then seek marketing approval, Congress obviously understood the opportunity cost here. They immediately, same year, reversed the decision, created the language of Section 271E. It shall not be an act of infringement to make, use, a patented invention solely for uses reasonably related to the development and submission of information under a federal law which regulates the manufacture, use, or sale of drugs. Even if you are doing it with the express commercial intent of being a generic to lower the price on the market, you can do it because the consequence is the opportunity cost to society of having these patents delay innovation. I've also written separately about why the Federal Circuit wrongly constrained the experimental use doctrine, which again is not an exception or a defense, but simply the limit of the patent right, just as the language of E1 says. It's just not an active infringement to do this. But more importantly, it was never meant for the patent right to prohibit experimental activity at all, even for potential future commercial advantage. But we don't have the kinds of opportunity costs that I just discussed, transparent that for drugs and medical devices that relate to all forms of other scientific discovery. Congress recognized the importance of those costs, made a clear policy decision, but it only made that clear policy decision, again, in the context of FDA approvals. After Congress enacted that, another case came before the Federal Circuit in 2002, a case called Mady v. Duke University. The case held Duke liable for using something called a free electron laser in research after its inventor was fired from Duke, having first been lured away from Stanford. Mady was significant because the court held that the university research was within the scope of the patent right, even though it was performed on a not-for-profit basis, because the commercial value of the research to educational institutions, including acquiring grant funding and attracting students and researchers, meant that it was commercial activity. I won't give you the quote from this case, but basically said all academic work is commercial. Following Mady, therefore, academics became very concerned that all scientists might be subject to licensing demands in their research and that it would shut things down. John Walsh and Wesley Cohn performed a number of studies at that time, and what they found was that there was no substantial change to scientific research behavior after Mady. There was some, but they did notice some delays in research and inability to obtain some materials through material transfer agreements. The important point, though, was their conclusion that there was no substantial damage to how science went forward was premised on widespread infringement of those very patent rights, either through willful ignorance or willful infringement by the scientists and willful acquiescence by the companies that they simply wouldn't sue researchers. That's obviously a terribly unstable position. Not only is it unstable, it's not an accurate description of some areas. So just recently, John Walsh and Tanya Bubala, Saurabh Vishnubakat, and Robert Cook-Deegan did a study of the genes on the Swedish mutation for the Alzheimer gene patent. And they've documented the significant opportunity costs to research that were engaged in because of assertion of those Swedish mutation patents. Specifically, those patents were directed to nucleic acids, purified proteins, isolated cells, and transgenic mice. They were suited against pharmaceutical and biotechnology companies, as well as public and private research organizations, and notwithstanding contentions by the patent owners that they did not assert their patents. I'll quote from their conclusion: corporate strategies to block access to research tools were adopted to protect in-house pharmaceutical R&D, all of which failed to protect therapeutics. In other words, eggs were forced into a limited number of baskets to the detriment of scientific and clinical progress. It seems likely that the bulk of licensing revenue went to support the litigation, much more than research. There's little public record to support AIA, the owner's contribution to research, and much legal documentation that indicates that it imposes enormous costs on the research institutions and private companies it sued. AI's contentions that it did not hamper research is incredible. And even more importantly, some of those patents were found invalid for improper ownership. They probably would have also been invalid for ineligibility. So you have high costs of patents to the scientific research process, caused in part by patents that were held invalid and should never have been issued. Who knows how many other areas of research have been adversely affected, and in particular, think about the Cohen and Boyer patent, which most people don't know was never issued in Europe because of prior art, which Hans referenced, and was likely invalid in the US, but no one challenged it simply because they were willing to license at a low enough price that no one was willing to sue or needed to sue. Had they done so at a very high price, it would have dramatically slowed things down. So I'm going to shorten what the rest of what I was going to say is, but it leads me back to the subject matter issue. In regard to eligible subject matter, we really have to ask, Are we going to fund the scientific discovery process through the patent system? Obviously, there are and truly important discoveries that will need to be made and funded, but patent rights are only one means to do so. We need to think about the opportunity costs, and particularly the opportunity costs of patents on fundamental building blocks for all of our technological advances that are the reason why we don't allow patents and historically have not allowed patents on science and nature itself. So just to quote from Lord Camden, back in 1774, scientists were entrusted by Providence with the delegated power of imparting to their fellow creatures that instruction which heaven meant for universal benefit. They must not be niggards to the world or hoard up for themselves the common stock. Similarly, in 1890, William Robinson, a seminal patent treatise writer, to benefit by the discoveries of his fellow men is not only a natural right, it's also the natural duty which every man owes to himself and society. The mutual universal progress thence resulting is the fulfillment of the earthly destiny of the human race. So, since the 1850s, those sentiments have been codified in American patent law by saying that scientific principles, natural discoveries are not patent eligible. The real disagreement is whether or not those discoveries, when made, will allow the patenting of transparent applications of them, which are the diagnostics when you discover something, the use as a pharmaceutical when you discover it. Here, again, I think that there's a much longer history, which I won't go into. I disagree with Hans that it's only the recent Supreme Court cases that established this case law. Fluke, I think, went back to some of the earlier case law and adopted it. The most important thing, though, and there's a terrific article by a guy named Jeff Lefston on this concept of whether you need inventive application, is that if you treat that natural discovery like Lord Camden said, as if you have to disseminate it freely, then it's treated as if it was prior art. That means that if you have an invention, the invention isn't the discovery, it has to be a creative application of it. Therefore, what Hans described as maybe only laboratory methods is probably not as too restrictive, but it does mean that anything that nature itself suggests that you discovered would not be patent eligible. That may mean, if that's the law, that we aren't going to be able to fund natural discoveries through the patent system. Or it may mean that we're going to see legislation to do so. That's really the critical question, and for all of the opportunity cost reasons that I've identified, it makes a huge difference. So with that, I'll stop and look forward to questions and discussion.
Okay, great. Well, thank you very much to all three of you. We obviously have different perspectives, and in fact, we could spend the entire two-day conference talking about these very topics. Since we have about 10 minutes for Q&A, first I want to see if there are any pressing questions from the audience. Otherwise, I can, yeah, there's one over here. We've got the mic coming up.
So given that you described pretty unstable landscape for new patent rules, I would like to ask you with respect to the precision personal medicine inventions for those chronic diseases for which the patient behavioral aspects are, or like self-management contributions are reasonable. So for example, for the type 2 diabetes, the FDA approved 3 years ago the mobile medical app as medical device, and these type of mobile medical applications carry the copyrights. So my question is actually, how do you view the copyrights as potential new players to increase the IP value and motivate the R&D for both diagnostics and pharmaceutical efforts?
Anybody want to take copyright?
I'll just take a very short thing. I think that there has been a mistake. Copyright is supposed to be for expression and not for function. And when Congress allowed copyrights on software, they got it wrong. There have been some good arguments that genetic sequences also should be subject to copyright protection. I think that's right to the extent you're talking about for one thing, not sequences that occur in nature that simply are there, but creative synthetic sequences, but not for the functions that they provide, only for the expression. So do you really care if somebody can use the sequence to do something that's got a medical application, but they simply can't reprint it in a book? That would be the way I would look at this issue.
Yeah, I would add to that. One of our colleagues, Christopher Holman, who's a professor at the University of Missouri, Kansas City, has filed with the Copyright Office a copyright registration form for very large DNA sequences. That was probably a couple of years ago. The Copyright Office has assiduously ignored that application, and we're not exactly sure what's going to happen to it.
Mandamus action at some point.
Yeah. I'm sorry, was there another question? Here?
How many countries in the world honor U.S. patents, and how is it enforceable?
So patents are territorial, and U.S. patents don't have any effect in other countries. The question is, I think, would be better asked, do other countries have different approaches to these issues under their own laws? The answer is yes. We used to be much more permissive in regard to patent-eligible subject matter than most countries. Now we're more restrictive.
Yeah. Rachel or Hans,
I think, yeah, if I can just disagree very briefly with that statement. That is, it's true, right? Every country honors its own patents, not somebody else's patents. I think that's an overall principle. Each countries take different approaches to patent-eligible subject matter because they frame different laws and they frame things differently. When you look at the kinds of things that are being patented by researchers or businesses or whoever seeks to patent, those tend to be much more similar. When you just look at technology, is this invention patented or not, you will usually find things that are patented in the US are also patentable in Europe, in Japan, and other industrialized countries. So I think patent law substantively is relatively close. There is an anomaly. I would say the anomaly now is in the area of patent-eligible subject matter, where the US now no longer allows categories of patent applications that remain patentable in Europe and in Japan and in Canada and in the countries of our main trading partners. Yeah, and what that may be a good or a bad thing, I'm just saying it's a disparity in the law, and it has certain economic implications that companies have to think through.
Rachel, did you want to add anything to either of these?
Yeah, just to touch base on the copyright issue. My guess is that whoever the vendor or the seller of that program realized or talked to a very good patent attorney and realized that there could be some issues getting a patent on that. And copyright is a way, one of the perhaps only ways to get any patent or any intellectual property protection. And so my guess is that that was the only one that was available, and so let's try to at least get some copyright coverage on that. And then regarding that question there, depending on the the claims of your patent, and Hans touched on this, clients, companies can choose to file patents in other countries. There's a patent cooperation treaty, PCT treaty, between most of the industrialized nations, where if you file a patent application with the PCT, you're able to cover most of the industrialized world and otherwise with the same patent application. The problem is you have to pay for that in every country, and so it becomes a numbers game. Can we afford it? Is the patent protection in, for example, South Africa worth it to pay those costs? Usually, and Hans alluded to this, Europe and Japan, you try to go for those. Those are good markets for your products, especially personalized medicine. But again, it's numbers. If you can't afford it, then you can maybe find a licensee, or you're just at risk.
Yeah. Numbers, and I believe that there's separate examination in each country. So if countries have different standards, as Hans said, it's
some have different
not
standards
automatic
than others. Yes.
Yeah. But we had a question in the front here.
Yes, I think we can all agree with respect to patentable subject matter. These are uncertain times. Uncertainty brings tremendous costs, and the costs are being borne by the industry and the public, actually. How do we reach certainty? I know that there have been calls for legislative action, but given the state of the U.S. Congress, I don't have much optimism. But I'd like to hear your thoughts on how do we reach certainty with respect to what is patentable.
Yeah, I would say Hans would
Wait,
be-
I think
yeah.
we all have something to say about that. I would say a prerequisite to like trying to reach certainty is a common understanding of what problem we're trying to fix and address. Right? The Supreme Court has given, I think, different signals of what it's trying to do. Right? The Supreme, in some respects, it looks like they don't like overbroad or disembodied, vague patents. Right? Nobody really does. They're kind of difficult to deal with. So that's one thing the Supreme Court doesn't like. And it looks like they're trying to tweak that with some of this jurisprudence. In the same cases, you hear, well, these things exist in nature. They're too important. They're like part of common heritage. They're given to us by God, whatever it might be. Well, you can't get a patent on that. So something very normative where you wonder, what's the doctrinal origin? You know, some Supreme Court justice in the 19th century said something about you can't patent the sun or the energy of the sun, and it becomes law. So anyway, right? So there's that. It's overbreadth. The Supreme Court has talked about preemption. We're very worried that if people get patents that crowd out too many others who would build on these discoveries, that they would prevent more innovation than they tend to promote, right? But none of these seem to stick when you go, and some even pull the decisions in different directions, right? So for example, look at like the preemption concern and another thing was inherent patent worthiness seems to be a concern of the Supreme Court as well. Why they say, well, we only want to give patents for things that are really inventive. And so you see this in the decisions that follow after the Supreme Court, where you have things where the patent owner says, but I don't preempt anyone. I have demonstrably, there's 5 different ways to do the same thing without infringing my patent. And the courts say, well, but it's not inventive. And then you have other instances where the courts say, oh, it's highly inventive, but it preempts too much. Right? And so you go like, which way should it go? We don't know. I think Congress is not interested at this time in addressing this. They're looking elsewhere. What do we do to get clarity? I think careful case law development would help. I don't see it from my personal vantage point because judges are very unsure about what to do. The Supreme Court gave this area of the law, and normally judges have an understanding that they're supposed to flesh it out and fill it with more detail. In this instance, I think judges have said, I don't know where the defining and outer boundaries are. I don't know which patents I wouldn't strike down if I rigorously applied these principles. And so these are uncertain times. I think it's not for the judges to do. I think eventually it's for Congress. But to close out, I think first and foremost, it should be for the Patent Office to do. And I've been very critical of the PTO in past instances and not shy on from being so now. The Patent Office views this issue as a problem of implementation only, right? It's only because the case law is so unclear that they're groaning and complaining that it's hard to implement and hard to apply in rejecting patents, right? If it could be done reliably, they'd be perfectly happy rejecting antibiotics and laundry detergent enzymes and other things that nobody ever complained about. I think the Patent Office's job is also to advise the President on good IP policy. And if this is where the case law leads us, and if we're compelled to do this, then we should also be having a discussion on whether that's correct innovation policy and good trade policy and good otherwise industrial policy. And that's not happening in the PTO.
Okay, thanks.
Yeah, quickly, Bert, good question. As far as I'm concerned, the cynic in me says, hey, I've got a heck of a lot of job security. So honestly, who knows?
Students, listen up.
Yeah, patent law is the way to go. Who could have thought that what would have happened in the past 5 years would have happened? And Lord only knows what they're thinking now. So yeah, it's going to be an interesting couple of years.
So I don't know if you can put the slide back up, but job security for me as an academic, I started on this issue in 2005, so I'll be writing it for another 15 until I hopefully can retire. I think that the answer is mostly what Hans said, and let me reframe it just a little bit. It's clear thinking and teaching history. And let me give you a concrete example. The Supreme Court decision in Myriad, in 3 paragraphs, and the first of those 3 paragraphs says isolated DNA is naturally occurring. 2 paragraphs later, they acknowledge that it's man-made. That kind of lack of clear thinking by people who are well-trained in the top of the legal field is a disgrace. So we have to have clear thinking, we have to have clear statements of the policies, and then an understanding of the history of those policies. Then we'll get to the real difficult disagreements. At some level, I might ultimately agree with Hans that we need to reverse this doctrine if I didn't feel that the government could step in and fund the discoveries of nature again. I am optimistic for that. You can see the piece on the last slide that's not up, but maybe can be made available. And if anybody wants to see any of my briefs or any of these articles, I'm happy to email them to. It's all about clear thinking and making sure that when we have meaningful debates, we can address them in a polite, clear, and non-confrontational way. And at some point, decisions get made. That's how democracy works.
Yeah, no, I think that's an excellent wrap-up. One final set of words to leave you with. Nobody mentioned Justice Scalia's one-sentence concurring opinion in the Myriad case here, which I will leave you with, which was basically, I don't understand this biochemistry stuff, neither do any of you other justices, so why are we deciding this?
Because they have to.
They have to, yeah. So in any case, we are now on break. Could we please try to be back by 11:30, and then we will move on to the panel on the FDA, another government agency, and precision medicine. Thank you. And thanks to the panel. please take your seats. Next few seconds, we are going to move on to the third panel of the morning now, which will be moderated by my colleague, Professor Leslie Francis at the University of Utah, on regulation and the FDA and precision medicine. So, Leslie, to you.
Thank you. So we've heard this morning already about how there are difficulties in getting the money to fund particularly diagnostics for legacy treatments. We've heard all kinds of tough issues of intellectual property. And this session, the last of the morning, is going to be devoted to the regulatory environment, which is another very thorny area for precision medicine. I'm joined here by three panelists. We're going to start with James Sabin from Wiley-Rein, who represents many folks in the industry. Then Robert Meyer from the University of Virginia School of Medicine, who spent a number of years at the FDA and is now in the role of scholar. And Stephen Hansen from the U.S. Food and Drug Administration. So without further ado, Mr. Sabin.
Thanks, Leslie, and thanks to George Contreras for inviting me, a former law partner of mine many years ago. It's a beautiful, beautiful new facility here. I went to University of Virginia Law School, and I'm jealous that Bob gets to hang his hat there now. But as pretty as Charlottesville is, it doesn't hold a candle to the view just outside the door here. So I'm very, very happy to be here. I've practiced food and drug law on the pharmaceutical side primarily for almost 25 years, and representing both branded and generic drug companies, biotechnology companies, some food, medical device companies, et cetera. And so I'm not here to represent specifically industry viewpoint, but more of an outsider's viewpoint of FDA and some of the processes and challenges that it poses for companies developing therapeutic products. So I've got sort of two sets of issues. I'll address one and then get back to the other if there's time or in the question and answer. The first is sort of the overview of what FDA has done in the last several years administratively to try to address and prepare for the regulation of what we now call precision medicine. And while there's been a lot of fanfare over the President's Precision Medicine Initiative, as if it somehow represents some great new revelation and some imminent new government benefit that will cure all that ails us, that's really not the case. And the reality is as well that the biopharmaceutical industry and academia have long been the drivers and have been in the forefront of innovation in precision medicine, and will, of necessity, have to remain in the forefront. In fact, the government's involvement in this area has far greater potential to restrain progress than to accelerate it. So in that vein, I'll provide a general overview of some of what FDA has done over the past few years, with a few barbs thrown in, and it's nothing personal to Bob or to Steve, and sort of set it up for their discussion of some of the more detailed initiatives and activities that FDA is pursuing now and in the near future. And then afterwards, in the question and answer perhaps, I can address some of the incentives and exclusivity issues that are available and important in this space. So, as I said, the Precision Medicine Initiative is by no means the beginning of the government's efforts to address this emerging field. Indeed, FDA has been very busy for at least the last 10 or 12 years in administrative activities trying to teach itself and to prepare the ground for addressing these issues. In fact, in October of 2013, FDA issued a lengthy report titled "Paving the Way for Personalized Medicine, FDA's Role in a New Era of Medical Product Development." And this was more than a year before the Precision Medicine Initiative was announced. The Paving the Way report described many of FDA's administrative activities, and I will go through some of them in a fairly high level of detail. But first, to sort of set the stage to some of the commentary around this, in 2001, as a younger law firm partner, I published an article for the Food and Drug Law Institute titled Pharmacogenomics, the Uncertain Path to Decoding the Regulatory Genome. In the conclusion to that article, I wrote that with the rise of the pharmacogenomics revolution, quote, there will likely be an increasing focus on areas in which FDA's regulatory oversight needs bolstering, because pharmacogenomics technology encompasses an inseparable combination of biologics, devices, and drugs, simply resolving the jurisdictional overlap between the various FDA centers, Centers for Biologics, Centers for Drugs, Centers for Devices, will present difficult organizational challenges that will require a cooperative, holistic approach within FDA and the regulated industry. Indeed, mapping an appropriate regulatory blueprint may take as long or longer than mapping the genome itself. So now, nearly 15 years later, I'm here to confess that I may have been too optimistic and insufficiently skeptical in my prior assessment. So let's talk about some of what FDA has done and see if you agree. According to the Paving the Way report, since about 2005, FDA has taken the following infrastructure actions to deal with what we call precision medicine. It created an interdisciplinary pharmacogenomics review group within the National Center for Toxicological Research. It established within an NCTR a Center of Excellence for bioinformatics, functional genomics, and structural genomics. It created a new office within CDRH, the Office of In Vitro Diagnostics Device Evaluation and Safety, known as OIVD. It launched within CDER a voluntary genomic data submission program, created a genomics and targeted therapy group within CDER. It reorganized and renamed a CDRH Office of Science and Technology into the Office of Science and Engineering Laboratories, OSEL. It reorganized NCTR's previous division of pharmacogenomics and molecular epidemiology into a new division of personalized nutrition and medicine, created a personalized medicine staff within CDRH. It created within CBER a personalized medicine team. It launched an Advancing Regulatory Science initiative, agency-wide, developed within CBER an intramural consortium of research scientists. It launched within CBER a genomics evaluation team for safety. It restructured FDA overall to create 4 directorates, including the Office of Medical Products and Tobacco. It established an inter-center drug diagnostic collaborative with representatives from CBER, CDER, CDRH, and OMPT. It created a new office for special medical programs. It reorganized NCTR staff to form 3 new branches within the Division of Systems Biology. And it launched FDA's Genomic Working Group. So to summarize all of this activity in the spirit of questionable Christmas gifts, and with apologies in advance, I would summarize as follows. Over the last 12 years, FDA gave to us 1 working group, 2 other groups, 1 center of excellence, 2 new offices, 1 new division, 1 new staff, 2 new teams, 3 new branches, 4 new directorates, 1 reorg division, 1 reorged office, 1 reorged staff, 1 initiative, 1 collaborative, and 1 intramural consortium. And to top all that off, between 2005 and 2013, FDA has issued at least 22 separate guidances, 3 International Conference on Harmonization guidances, 1 concept paper, and 3 Manual of Policies and Procedures, all related in some way to precision medicine. So that's a lot of paving. So surely by now, FDA must be fully set up and properly organized to efficiently deal with any and all issues that may arise in the regulation of precision medicine, right? Not according to President Obama. The President's Precision Medicine Initiative pledges an additional $10 million to FDA, in part to pursue regulatory modernization in precision medicine. Not according to pharma, which has stated that a top unmet need that should be addressed by the government is to, quote, ensure a clear and transparent regulatory framework for the development of targeted therapies and co-developed diagnostics. And not according to FDA itself, which has stated that it needs to, quote, help address the pipeline problem for drugs and medical devices by identifying opportunities for streamlining regulatory processes and advancing the science and tools that will help drive innovation. So what has FDA actually paved? I'm not sure if they have paved a parking lot without lines and no exit, or if they've paved an oval racetrack that you just go around and around in circles. But that's my cynical view. And again, with no personal offense to my FDA colleagues on the panel, I will turn it over to them to explain why I'm all wet on these critiques.
All right, thanks. I didn't know there was going to be singing. I didn't bring my guitar.
That was the multimedia portion of my slideless presentation.
All right, how do we get this up?
Slides.
So, incidentally, I was actually on a couple of those working groups, which tells you how old some of them are. What I'd like to do, first of all, I just want to say that we're finally getting our rotunda back. That's the signature building of the university, which is actually a UNESCO World Heritage Site. And it's been under considerable reconstruction. So we're finally getting to see it again, which is nice. It's not open yet for the students, however. But in any case, one of the issues that I think is really tough in talking about precision medicine is around definitions. And depending where you look at the FDA's own definitions, it can be as broad as the right drug to the right patient at the right time, which I think echoes one of the Will's slides earlier. I would call that more personalized medicine. Precision medicine is I think, a subset of that. And for the purposes of talking about the regulatory challenges and FDA's oversight of precision medicine, I'm really going to define it more as pertaining to therapeutics that are based on a specific mechanistic understanding of disease that varies by patient characteristics. And those characteristics may be genetic, they may be phenotypic and measurable and precise, or by some other measure of a defined biologic state. So one of the big challenges, and it's actually reflected in the list of the 12 days of Christmas we just heard, is around the co-development of an in vitro diagnostic and a therapeutic. So whether these structural changes within FDA have been helpful or not, this technology means that you have to have a way to define the right patient to be able to then assign them as eligible for treatment or perhaps ineligible for treatment. And the regulatory paradigms for evaluating an in vitro diagnostic, which is a device and overseen by the Center for Devices and Radiologic Health, or CDRH, and the therapeutics, which are largely overseen by CDER, the Center for Drug Evaluation and Research, are quite different. They're different in terms of the specific regulations, guidances. They're different in terms of timelines. They're different in terms of expectations. So for instance, what I found when I was working there and subsequently when I was in industry is that the devices center may actually have more rigorous expectations for clinical validity than CDER. So if you took the example of the 1 in 83 patients who might benefit from a mortality advantage if given statins, There are many people in CDER, particularly in the clinical pharmacology group, would be delighted with a test that might get that to 1 in 41, or maybe 1 in 25. CDER-H, besides their sort of engineering and technical validity concerns, would much rather see that be even more predictive than that. So their expectations around the clinical validity that they see, I think, is informed by their oversight of tests that are not related to specific therapeutics. And I think that tension has yet to fully play out between the two centers. From a company standpoint, one of the difficulties with some of the expectations is that, for instance, there may be an expectation that an in vitro diagnostic being developed for a new cancer therapeutic would have sufficient development and validity to meet CLIA, the laboratory standards, at phase 1, which sounds good because then you have a fairly locked down test. The problem for a company is when you enter into phase 1, you have about a 1 in 5 chance of that drug becoming a marketed product. And to have to invest all the money into developing this test, and in fact, for most companies, it means working with an outside entity because they don't have an in-house devices arm. To invest in that, at that standpoint, is a big challenge when, in fact, they may have a 1 in 5 chance of that drug not working out. Next thing that I think presents an interesting challenge for FDA and actually for industry are pathways for rare mutations. So a disease may have multiple genotypes that contribute to it or that define it. And the question is how a company needs to gain approval for each specific and then increasingly rare genotype. And a very good example of this is for cystic fibrosis and the drug called ivacaftor. Ivacaftor does something to a class of genetic mutations that are called gating mutations, where the CFTR, the chloride channel, makes it to the plasma membrane, so it makes it to the respiratory epithelium, but it doesn't open normally. Turns out that that genetic defect overall is only about 5% of all cystic fibrosis cases, but 80% of those are a particular gene, which is called G551D. The only reason I mention that is because that was what the company studied first and gained approval for, and that was fine. But the remaining 1% of mutations in cystic fibrosis, or the other 20% of the gating mutations, were quite variable in numbers. And in fact, some of the mutations that contribute to gating mutations may be only seen in 6 to 8 individuals in the entire planet. So the company went back and did a study where they identified patients of a variety of mutations and did essentially the same studies they'd done with the 551D. And they showed, again, impressive results, which is one of the good things, incidentally, about precision medicine. If you really know what you're doing, you can actually do much more efficient development, which was mentioned earlier. But in this case, FDA looked at the results by genotype, and they actually took out from the indication certain genotypes because they didn't like the clinical response, which may or may not be scientifically defensible, but it's a very, very tough question to understand. So how do you gain a specific genotype mentioned in the label if you have to show statistical or important effect in each one of those? And what does that mean for the efficiency of the program? And if it's not listed, what does it mean for patient access? Validation of a complex set of characterizations is another big issue. So for instance, if you have a defined set of oncogenic defects in a cancer, not just one pathway, but multiple pathways, it raises both a technical validation issue in terms of the specific test. In other words, is that test reliably telling you the correct status for each permutation? But it also raises, again, clinical and development issues. So that if you looked at, say, 3 different oncogenic expressions in a cancer, how would you prove that patients broadly classified by those three oncogenes responds or not to a medicine? Notice I've got more questions here than answers, but I think this shows how tough some of this is. One of the interesting things about precision medicine from the FDA standpoint is that the Orphan Drug Act has really done a great job of incenting drug development in a class of diseases that would not otherwise make economic sense. But as you get into precision medicine and you define your patient populations more and more exactly, you actually come into a situation where every disease becomes an orphan. So even in hypertension, if you parse that out by genetics or phenotypic characterizations sufficiently, you could render a drug an orphan, which is fewer than 200,000 patients in the entire US who would be treated. Where we see this play out right now is that relatively common cancers such as lung cancer may be the treatments may actually end up being orphan drugs, like the crizotinib, which was a Pfizer drug for ALK-positive non-small cell lung cancers. That turns out to be 4% of non-small cell lung cancers. This is not necessarily a bad thing, but it has ramifications for what the Orphan Drug Act has done and what the alignment of incentives should be from a regulatory perspective as well as from a development perspective. Another interesting issue for FDA is around the change in disease taxonomy. In other words, right now, most drugs are indicated by a disease state. So even in cancers, it might be lung cancer, non-small cell lung cancer, there might be breast cancer, and that might be subdivided by histology. But it may well be that at some point drugs start getting approved not for where the cancer is, but for the specific genotypic aberrations that are being seen. So a drug that affects EGFR, for instance, might affect a colon cancer, lung cancer, even some forms of brain cancer. And the question is whether we shift the paradigm from approval by where the disease is and what it looks like under a microscope to what its precise mechanism is. Interestingly enough, even in antibiotics, FDA has generally approved them not just on what microbes are covered, but where the disease is. I don't know why I left out the rest of that, but finally, I think the other challenge for FDA and for the public and the companies is around the change in FDA and the practice of medicine. So by and large, the practice of medicine is not something FDA seeks to rigorously oversee. As you probably realize, the practice of medicine generally is done through state institutions and not so much on a federal level. And FDA has been, in general practice, happy to have a drug used off-label by learned intermediaries. But FDA has, particularly in recent years, become much more prescriptive about the use of medicines, particularly when it involves the safe use, the optimization of safe use. But if you think about it, as you get more precise in your mechanistic understanding and identifying the patients who are likely to benefit, it means that there's more imperative to make sure that that drug is used only in the patients for whom there is likely to be benefit. And this has implications for how FDA might label and demand these drugs are marketed, so that it's not so much in the hands of the practitioners, but really there's pathways to assure that the patients are properly identified and treated only if they have the specific qualifying biomarkers or otherwise have the precise targets known. So I'm going to end there. Those are just some of the considerations, and I think we probably have some healthy discussion points that we can go through later. So I'll turn it down to Stephen.
I'm Steve Hansen. I'm with FDA's Office of Regulatory Affairs. I think you'll find the tone and tenor of this will be a little more pro-FDA than Jim's was.
I would hope so.
But as much as I'm not a policy maker, what I'll plan to do is talk about FDA's public statements and what they've discussed publicly and sort of what they're doing going forward right now with precision medicine. And in particular, I'll talk a little bit about next generation sequencing, as much as there's been a lot of activity, relatively speaking, lately within the FDA for that. And so, of course, the obligatory disclaimer. Precision medicine, and in particular next generation sequencing, because it is raising new questions about policy and regulatory issues. So once again, everything I say here and the topics discussed, they're preliminary. They don't represent FDA's finalized or even proposed policy on the subject. And as we've probably seen several times throughout this seminar series, this was a mission statement taken from the White House.gov precision medicine paper they put out. And again, it's the idea of bringing research and technology to the individual for their own personal medical health. FDA has been on board with this, perhaps not as fast for Jim as he would like, but FDA has been addressing this issue for a while now. It precedes the Precision Medicine Initiative. In 2011, FDA released the Strategic Plan for Advancing Regulatory Science. There were 8 points on there that FDA discussed. Point number 2, of course, was precision medicine and moving that forward. This is the 2013 report put out by FDA, Paving the Way Forward for Personalized Medicine. It was a broad report. It discussed a lot of things at a high level. Among other things they discussed, of course, was, for example, 3D printing. I won't be talking about that per se, but some of the things discussed there were the various things happening within the agency, at least up until 2013. And we had a very nice song about that. Here are a couple of highlights from the song. And because it was such a nice one, I probably won't labor on it too much, other than to say that yes, there is changes within the agency. This is a figure from the report that was put out, and we probably already all have seen something similar to this several times. I'll quickly go through it. On the left-hand side there is a heterogeneous group of people. It's the one-size-fits-all approach to medicine, and they've all been prescribed to 100 milligrams of drug X. And in the right-hand box, we see the group is now segregated out by genotype, and so they're getting more personalized dosage, from 500 milligrams on the far left side to 10 milligrams on the right side, based upon this putative genotype for metabolism. And we've seen this also several times before, and several people have talked about it very nicely. The right treatment, the right patient at the right time. And that's predicated on having the right diagnosis. And this will kind of segue into at least next generation sequencing and what I plan to talk a little bit more about throughout the remainder of this. Under the traditional paradigm, the FDA followed the one test, one disease for medical device and diagnostics and whatnot. So a particular device was approved to diagnose in a certain condition, condition Y, for example, that I've given up there. And that works well for most things. However, with next generation sequencing, being at least relatively speaking a newer technology, a younger technology, it's created a disruptive event, if you will, in as much as now there are millions and millions of data points per patient. With this comes some opportunity, if you will, to optimize FDA's regulatory approach. Some of the issues that we're dealing with are, when we're talking about next generation sequencing and whole genome sequencing of an individual, Not all variants are known, and not all variants are clinically relevant. So in as much as there might be a readout from the genome that the physician discusses with the patient, but that doesn't necessarily mean they will start chemotherapy that evening, depending on how well known that variant is. Again, with next generation sequencing, being a younger technology, the results are not 100% accurate, nor are they 100% specific to the extent of, for example, false positives, false negatives. So FDA is in the position of metering, if you will, safety versus innovation. And it doesn't necessarily have to be a either or. They can go hand in hand. But as this new technology is coming more of a reality, FDA is looking at ways to optimize the regulations concerning, for example, medical devices and how to treat next generation sequencing. Primarily, there's the assurance of safe and effective diagnostics. Do these new technologies, do they have the analytical validity to actually test what they purport to test? And then, of course, there's the clinical validity. What does all of this mean, this deluge of data that comes through? What sort of evidentiary standards will the FDA consider? What do they allow? Biomarkers, for example, what to do in the cases of the error rates, false positive and false negatives. What is an acceptable error rate when we're talking about determining someone's genome? Clearly, there will be a difference in the way clinical trials are conducted, as was discussed earlier, where it's not just all persons with, for example, breast cancer, but rather clinical trials might be more specific to persons with breast cancer that express a certain variant of a gene. And then the bioinformatics is still also an area that we get this huge amount of data. What do we do with it? How do we interpret it? And what is done in a meaningful way? As far as product interdependency is concerned, this was also discussed. Within FDA, it's divided into various centers. CDER, for example, would cover, regulate, and approve drugs, CDRH, medical devices. When we start talking about pharmacotreatments and companion diagnostics, now there does need to be a lot more interaction between the centers. The various regulations are going to be different, whether it's a drug versus a medical device. And at least to the private industry side, there's going to be a lot more, or potentially, partnerships with companies as the pharmaceutical company develops a drug and the device company develops a medical device. We've talked a little bit about this throughout the seminar, as well as what about labeling? So far, FDA has approved over 100 drugs with labeling that has information about biomarkers. This drug would be more effective with a particular biomarker versus another. And then post-marketing surveillance, it's always important, but as clinical trials have the potential to shrink in N size, it becomes even more relevant. That's not to say that the regulations that are currently in place are completely ossified and unworkable. FDA has adopted a flexible approach. For example, in 2013, FDA approved Illumina's MySequencing diagnostic device and its universal reagent kit. Here, the company was not required to show, for example, that their MySeq instrument could detect all possible variants. Rather, there was a selection of variants that the company demonstrated repeatedly across different machines, across different users, across different reagent lots, that they could get the same results. The approval also depended upon other aspects, the reference materials, for example, from Genome in a Bottle, the consortium of FDA, NIST, and other private and public entities, as well as the CFTR2 database for the cystic fibrosis. It's a well-curated database from medical providers and patients for cystic fibrosis. So, as FDA is looking to optimize regulations concerning next generation sequencing, and again, making it very personal to the individual with the potential to look at down to the very genome, What sort of things are going to be looked at when we're talking about approval of NGS standards? Should the device simply be required to show a performance at a standard performance regardless of design? Or rather, should quality design be built into it right from the ground? As far as material standards, what sort of reference samples are being used? What sort of controls are being used? What are acceptable? With regards to the informatics, the alignment software, should there be a standard throughout the industry of what is acceptable? What sort of filters are being used? What sort of reference sequence is being used? The interchangeability of data formats, for example, and then nomenclature as well. Should there be a standard nomenclature across the field regardless if it's in cancer databases or others? And then with regards to these databases, who takes care of them? Where's the curation? Should there be a certification process? Should there be a review process? These are all things that are being openly discussed right now with FDA. And I've spoken a bit on next generation sequencing, particularly because FDA has been fairly active in the last year. I should say going back to 2011, but in the last year, FDA has hosted a number of seminars and workshops on next generation sequencing, bringing in both private and public entities to discuss the issue. These are all publicly available. There's a URL address listed at the bottom there where you can get transcripts and watch video from the workshops. Also, FDA has developed a new website, Precision FDA. This is something that is completely new. It was in closed beta testing starting in July, and as I understand it, come the middle of this month, it will be for open beta testing. It's free to use. All a person or an organization needs to do is request access. The idea behind this is for users to upload data and essentially play with the tools of Precision FDA. It's a science tool right now. It's not a regulatory tool. It's going to be crowdsourced. People upload their sequences and work with the software there. Do they get similar output from their sequence as others? It's both private and public domains within it, so if you just want to go in and play around, you could upload your sequences, see what you can do with it. If you wanted to share that, you could put it into the public domain of the website and get feedback and have others look at it as well. And quite frankly, the goal of this initially is for FDA just to look at what sort of informatics information is available, what can it do, what can it not do. The long-term goal is to use this website to help advance the regulatory science and potentially develop regulations from this. And FDA has been active, as was mentioned earlier, about issuing guidance documents and draft guidances. There is no draft guidance right now for next generation sequencing. It is in the works from what I understand. Thank you.
I'm going to do the same thing that the prior moderators did and ask for a show of hands about how much in the way of questions we have from the audience. Go to the audience first and see what comes up, and then I've got some questions as well. So those in the audience? Okay. Yeah. Got one. Yeah, there's one. Yeah, there's a hand. Yeah.
Love the song. But to the FDA, the last thing I have not heard of, the Precision FDA site, but one of the issues potentially in a very large bureaucracy, one of the things that comes to mind when I was listening to what you said is it could be useful, but George Church has been doing that at Harvard with the Personal Genome Project, and I'm wondering, for example, do you coordinate with that? And he's been doing a spectacular job for a decade. So that's not mentioned in the same comment.
Like I said earlier, I'm going to constrain everything I've said to FDA's public comments. FDA, for Precision FDA, we have reached out to the various community to help develop the website. There's a lot more information about it. I don't want to speak specifically to that because I don't know the answer right off the top of my head.
Others? One over there.
So I'm just wondering because you know a lot of the discussion today has been premised for any of the panels premised on the idea of particularly the next generation gene sequencing. But I'm wondering about efforts sort of moving beyond genetic variation in drug response to all the other omics that are out there that keep coming on the horizon as we keep getting one thing and we're getting more. So whether to speak to sort of what efforts are being made to sort of examine, epigenomics or microbiome or metabolomics, proteome, all of these things, and whether their relevance for understanding the drug development and drug approval process, whether there are efforts to be sort of integrating it into it, again from anybody, but and how they see that playing in.
So maybe I'll start on that. So the back in the mid-2000s, the FDA wanted to establish a way for companies to have, or interested parties, but they're largely companies, to have discussions with FDA that were sort of non-prejudicial about the future considerations for the drug development program, sort of a safe harbor. And they started this pharmacogenomics working group with a pathway where people could come in to have exploratory talks. I think part of the, I'm going to just step back for a second. One of the difficulties from a regulatory perspective is regulation is very much driven by experience and knowing what works and what doesn't. A lot of what we're talking about here, there is no experience. There's, learned thought about how things might play out, but learned thought can be wrong too. So this was a way to bring the companies in and hopefully learn together. That has been expanded to be broader than just pharmacogenomics, and it's gone beyond genomics in general. So some of those discussions are occurring in that kind of setting. So the company may come in with some early phase data, phase 2 data, and with some evidence around genomics or epigenomics or some other metabolomics data and correlations, and talk to the FDA about this is what we see, this is what we think, what do you think? That group is not, in some ways, it's sort of walled off from the review groups that might otherwise be seeing that drug later. It'll have a few of those folks mixed in, but it's sort of walled off. And the idea, I think the companies are concerned, and maybe they're right, maybe they're wrong, that FDA may see something out of those data that begins to concern them and may be harmful to their drug development program. I don't think that's, I haven't heard of examples where that's actually played out. And it has been, I think, a useful pathway to help FDA get more comfort, but also for the companies to have sort of forward-looking discussions. Now, how much that's really greased the skids in terms of getting these things incorporated, I guess at this point I'd say it's still a work in progress. But I think having the ability to have those kind of discussions where it's not around the specifics of, well, how do we get this drug approved, but more early stage and saying this is what we're thinking, this is what we're seeing, is a good thing. Now, it's not easy for the companies and it's not easy for FDA, but I think it is a good thing. So it was part of the list that both Jim and Stephen showed, but I don't think it's just a sort of a disingenuous effort on the FDA's part. I think it really is them trying to learn and trying to define a pathway where none exists currently.
So maybe I'll jump in with an observation and then a question for the three of you. The observation is that something that's new about all of this is in some ways how particularized it is. And regulation tends to function in generalities. And so that's the observation. The question that, the big question in the first panel, as I understood the first panel, is how do we try to figure out how to get the incentives so that there's actually some money to be made here. The big question for the second panel was, should this be a matter of discovery that we actually grant intellectual property rights over? Should we be moving away from invention to discovery in the role of intellectual property rights? What I see as a big question for this panel is, what's the role of a regulator here? Is the role of a regulator in some ways just to convene information, which is what the FDA is doing a bit, or is this really the kind of thing that the FDA can perform its historical, let's look at safety and efficacy role before this gets to individuals? Or is this a whole new world in which what ought to be happening is, let's let 1,000 flowers bloom out there in the private sphere? So, I mean, I'm really asking perhaps for James to start out saying, you know, is really what's behind some of your worries about the FDA, fundamental worries about the role of a regulator here?
Well, it's an interesting philosophical and practical question in some ways. FDA and most federal agencies at least operate in sort of two modes, sort of a regulatory mode and an adjudicatory mode. Regulatory mode, they issue regulations that have general applicability to, you know, particular regulated entities and whatnot. The adjudicatory mode is when they receive an application and they look at the data and they make a decision. Does it show what it needs to show in terms of safety and efficacy and so forth? And the result is an approval, and it's an approval that's specific to one entity, that particular applicant. And that dichotomy has, you know, important implications in regulatory law, but in terms of precision medicine, I think one key point is that there's currently nothing in FDA law or regulation that prevents an applicant from putting forth a precision medicine product for review, and there's nothing that prevents FDA from reviewing and approving it. These are just new drug applications or new biologics applications with particular elements that we call precision medicine, whether it's a companion diagnostic or a specific genetically defined patient population or particular genetically defined contraindications or warnings. One of the challenges, and it goes to Bob's prior comments as well, is that companies face a lot of risk and a lot of financial risk if they go into the development and review and approval process uncertain of how FDA is going to react. And so they often seek guidance, whether private guidance in meetings with FDA, pre-IND meetings, pre-NDA meetings, other informal meetings, like Bob alluded to, hoping to get more certainty, guide their business decisions, and ideally, in a lot of cases, try to nail FDA down to particular policies with respect to an application so that they don't get the rug pulled out from under them after they've done their clinical trials. And this is something that industry has complained about for a long time. The FDA, for its part, and I think the Precision Medicine Initiative as well, looks at it much more, more from the perspective of, yes, let's try to define the universe of pathways and data analysis and quality of studies and so forth in advance, both for the sake of giving applicants more certainty, but I think, turning to my cynical mode again, a little bit more to claim governmental credit for this, because pricing, drug pricing, as we all know and have heard earlier today, is a huge political issue. It's a huge concern for policymakers. And I think that to some extent, the more the government can claim credit for helping discover some of the precision medicine advances, helping to facilitate the development and approval of those inventions, there is more of a political argument to be made that the government should have more authority over price controls on the back end. So I do see some element of that in all of this.
I think the only thing I might add or emphasize out of what you just said was around the tension for FDA in terms of providing specific advice to individual companies, which is very labor intensive. An average 1-hour meeting for the company and for the FDA may take 30, 40, 50 FTE hours to plan and conduct, if not more, versus being able to put out more generalized guidance. And I think for a lot of this space right now, they are in the position where it has to be more the former and less of the latter, because there's not the experience to really build those more generalized guidances. They've attempted to do that, but I don't think that they have the experience to do that at this point. So it's a tough thing, and from the company's perspective, it's tough to get face time with the FDA because they're resource constrained. So I would hope as the FDA experience and the drug development experience develops, that they're able to move more of this into generalized guidance. It gives the companies more certainty for planning, and there'll be less need for these very specific and time-consuming interactions. Not that those should not exist. I think that the amount of dialogue between companies and FDA, if anything, should go up. But it is a resource-constrained environment, and I think the more the FDA can be general, but where you can take a specific case through it and understand where you're likely to face problems and where you're likely to face success is the ultimate goal here. But I think in some of these arenas, we're probably years away from being able to have that available.
Other questions from the audience? I've got one.
So my question relates to next generation sequencing in the context of whole exome sequencing or whole genome sequencing. Recently had a provider order whole exome sequencing on his patient from 3 different testing laboratories. As you know, it's a very competitive market. The 3 different testing laboratories yielded a different number of clinically actionable variants with differing interpretations from each of the testing laboratory. As you're well aware, every testing laboratory uses its own internal proprietary criteria to classify these variants, and that results in a differing interpretation of these variants. So my question is, do you anticipate that the FDA will potentially provide some type of regulatory oversight in this aspect of whole exome sequencing?
I guess I'll take that. As I was talking about earlier in the slide presentation, one of the things that FDA is considering as it looks to optimizing regulations is standards. And so as we've hosted these workshops and we've had public and private entities come in and discuss things, everyone's in agreement. There needs to be standards that the same input material, regardless of what platform it's being run on, regardless of what chemistries are being used, regardless of what analytics, should give the same meaningful results. So that is something that FDA is looking at and currently talking about.
I think part of the tension around this is that some of these are still in the category of laboratory developed tests versus a FDA cleared test. And I think where FDA is trying to walk the line there, and this is very controversial in the world of in vitro diagnostics, but is if the laboratory developed test has some critical characteristics in terms of clinical decision making and outcomes for the patients, they are declaring right now that laboratory tests in general are under their purview, but that they're giving enforcement discretion basically on them. But if they start crossing that line into making sort of critical recommendations or therapeutic decisions, FDA has said that they're then going to say, we're no longer giving you enforcement discretion, we're going to bring those into regulatory pathways.
And kind of jump on that. Last October of 2014, FDA released a draft guidance with regards to laboratory developed tests and what we believe will be the actions going forward. So the draft guidance is available on the website that you can freely look at.
Yeah, laboratory developed tests, this is another follow-up comment, is unfortunately a very broad category that can include anything from a microarray to a whole exome, and all of them will impact medical management. So it'll be interesting to see what the FDA comes up with. Thank you.
More of a comment than a question. Is that acceptable?
Absolutely.
Okay. So I've been working in precision medicine for a fairly long time on both company sides and others, and I think the FDA actually deserves a great commendation for how well they've actually been working through fairly complex science, and they have actually, in most of the products that I have seen approved, and even those that have been disallowed, they've actually violated their own procedures repeatedly to follow the science to get good products to patients quickly when the evidence is clear. And when the evidence where companies have complained, quite frankly, it's mostly been they're trying to rescue a fairly poor drug with a very bad diagnostic to try to get it through the FDA. But they've been remarkably flexible on getting good science and products to patients and reconciling, frankly, two separate pieces of legislation. They were too modest to bring it up, but you should know that the law by which drugs are approved is different than the law that covers diagnostics, and they contain different criteria which are actually in conflict at times. And the FDA has been trying to reconcile those two pieces of legislation to do the right thing for patients in most cases. And the people I found most inflexible and most difficult to work with are actually company regulatory people who claim that they know what the FDA is going to do, and you have to do these outrageously high bar things, and they're afraid to talk to the FDA and find out that's not the case.
To be clear, you're not describing any of my clients.
Well, I feel badly for your clients.
Having been head of global regulatory at Merck, I take a little exception to the last comment. Although I was often went from FDA to Merck, and I was often in the position of having to convince the rest of the organization that they should go ask FDA and be a little bit more aggressive. But I did want to say specifically a couple of examples of where FDA I think has been quite flexible. If you take the recent approvals of the HCV medicines, a lot of that took place before the specific genotyping of the HCV virus was actually considered a qualified test. And I mean, there were certainly tests out there to genotype, but they were not necessarily, from a regulatory standpoint, well qualified. And if you go back even farther, that was true of Herceptin, its original approval. The test for the HER2 status at the time of that approval actually wasn't FDA cleared or validated.
That raises an interesting point, too, that I think goes to the prior question. With Herceptin, the drug was co-labeled for the particular test. And that actually has commercial regulatory advantages for some companies in terms of patents and exclusivities if you can get a drug labeled for use only with a particular company's test. But where you have a lot of different LDTs out there that all claim to test or identify the same things, and a drug is not labeled for any particular one of them, there are implications for efficacy of the product and safety to patients. And I think that's one of the things that FDA is also concerned about in its efforts to bring more of the LDTs under more of a device clearance or approval mechanism.
I'm curious as to whether you talked about the safety and how precision medicine is going to indicate drugs for specific therapies. And I'm wondering if that's going to help or hurt with sort of the contraindications or the alternative uses that certain drugs have found that have been beneficial that weren't in the original analysis.
So I think there's probably a couple of things I'd say in that regard. First of all, I think a lot of the drugs that we're talking about are going to be quite expensive. And I won't get into whether that's good or bad, but I think it's certainly true and was well illustrated earlier on that when you're looking at a smaller patient population at the end, you're going to have a different pricing considerations. The reason I'm raising that is I think some of the off-label use is already going to be restricted by the payers unless the patient is willing to absorb that cost themselves. I think FDA can actually be assured that the payers probably won't pay for a lot of off-label use. That all being said, I think where we'll probably end up with most of these from a labeling and FDA perspective is well illustrated by the Herceptin example, where you have to have this test, get that result, and get that drug. And I think in some ways it will restrict the more anecdotal use off-label, but I don't think it will restrict the sort of the scientific-based use off-label or label expansion, but that probably will be done under more rigorous experimental pathways rather than just in clinical use. Nonetheless, I think there's still issues like the ivacaftor, where what do you do if you're one of those rare mutations that FDA has now taken out of the label, but you are a gating mutation and you have every expectation you'd work? How do you convince the payers? How do you get that drug? So these are not totally settled yet.
Were you gonna?
I'm good.
No. I mean, one of the clearly complex issues in all of this is whether, I mean, maybe I could ask each of you to comment more on what you think should be the interaction between whether something is on a label with an indication and the payer structure. For example, one thing that could be the case is that payers would pay for off-label uses, but only if people are in trials where at least data are collected about what the treatment outcomes look like.
I'm not really much of a reimbursement type person, but I think your point, Bob, was a good one, in that the tiering structures for the health insurance companies and the government are, getting more and more restraining, and perhaps appropriately so. Patients and doctors complain about that a lot, I'm sure. I had a second related thought. It has escaped my mind. I'm sorry.
Don't worry about it.
Well, and, one wonders whether, for instance, I hate to keep using the same case, but with the ivacaftor, so if you were one of those patients, could you get your payer to say, we will pay for it, but you have to have this under an N of 1 trial?
Right.
And if you show certain criteria of benefit, then we will continue to pay for it. If not, we will stop. And I think from many standpoints, that makes a lot of sense, from the patients, the providers, and from the insurance companies, because providing large sums of money, that particular drug is over $300,000 a year, and it's a lifetime drug. Continue to do that in a patient who's not adequately responding makes no sense. It makes no sense for anybody.
So the other follow-up sort of had to do with your question about access, and whether you framed it as, should reimbursement be allowed if the drug is in clinical trials for a particular off-label use? And it raises the issue of access to investigational drugs that has been very contentious with a lot of patient groups very strongly advocating for early access to unapproved drugs, typically in the context of a drug that's never been approved for anything, but in phase 1 or phase 2 has shown promising results. And generally speaking, the company can't give broader access to that drug other than through the clinical trials. Have been procedures to open that up a bit, and there were some reforms that were meant to encourage that, but none of those require a company to give access, and the companies in some cases have refused to give access for reasons of liability and the ability to complete clinical trials that will be robust enough to convince FDA of the safety and efficacy. And for simply also for reasons of they just don't have enough of it available to make it available to some very, very sympathetic patients, children who are, certain to die soon from a particular disease. So whether that comes into play for an approved drug that's under investigation for a new, genotypic indication or not is a little bit of a different set of issues.
Any final? So, go for it. Yeah.
So a final question is the use of observational data. We use it quite often for safety signals and black box warnings. We haven't used it very much for efficacy in the US, while the EMA is much more open to that in Europe, the KRAS marker for cetuximab, for instance. The Odyssey project that the FDA has been running is somewhat skeptical, I think, of observational data ever playing a role, but I'd love to hear your thoughts on that, if you care to comment.
Well, certainly one of the issues, one of the big issues here is the incentive structure for, incentivizing more research. And, pharma has talked about incentives on the patent side, on the regulatory exclusivity side, but also has called for, and I think I've got the quotes in the right place here, that the need to develop a framework for incorporation of larger and more diverse data sets, real-world data, patient-centered outcomes, biomarkers, et cetera, to help reduce the costs of showing the efficacy and safety that's needed. So it's a fair point. It's one that's certainly out there. And I think as you and I talked about at dinner the other night, FDA is perfectly willing to use real-world and anecdotal data to tighten safety labeling, but not on the reverse side to expand indication language. And it's, a pretty standard application of the precautionary principle.
Yeah, I actually have a whole talk on that, but I won't give it. Yeah, I'm standing between you and lunch. But I think the hope for the analytics around big data and real-world observational data being meaningful for efficacy determinations, where there's a pretty high legal standard for efficacy and substantial evidence. I think it's a hope, but I think it at this point is largely a hope. The breast cancer example that we heard yesterday, that was driven by the original study was actually sort of a real-world study of what seemed, and they were contemporaneous data or outcomes from matched patients, if you will. I mean, it wasn't rigorous in some respects, but showed that the breast cancer survival rate with the autologous bone marrow transplant was dramatically better. But when they did the randomized controlled trial, in fact, it was worse. So, I think there are a lot of cautionary examples out there. So I think it's a hope for the future, but I think some people, including many in Congress, think it's something that can be accomplished today, and I'm not convinced of that.
Okay, thank you all very, very much. This was a terrific panel. I need to make an announcement about lunch. There is lunch, and there are places to eat lunch that do not involve coming back here into the moot courtroom. We've got some tables set up right in the ante room, but also if you go down the hall and turn left, There are a couple of rooms where there are tables that you can sit around and be comfortable and enjoy following up on this rich morning with one another. And we'll see you all back here at 1:45. So enjoy. this second panel of, the second session of the day, first panel of the afternoon. The topic of this panel is the ethics of precision medicine consent. And I am delighted to be joined by 3 panelists. We're not going to go in exactly the order that's on the program because it seemed to make more sense the way we're going to do it. The first panelist will be Leslie Wolf from Georgia State University College of Law. The second panelist will be Carrie Wolonetz from the NIH. And the third panelist will be Aaron Rothwell from the University of Utah College of Nursing and Division of Medical Ethics and Humanities. So with that, Leslie.
Thank you so much. It's such a pleasure to be here. I've had such a good time from this morning's sessions and looking forward to the rest of the day. I am going to take our charge a little bit more broadly rather than focus just on consent, but to think about research more generally. The work, or some of the issues I'm talking about is coming out of a project I'm working on. I'll give up my slide that tells you we're funded by the NIH and my team members on this. We are in the relatively early stages of this, but I'm going to give you some background first and then tell you a little bit about what we're trying to do here. And the first is to realize the full potential of precision medicine, we're going to need research, right? Which means we all need to participate in some level in order to get the kinds of information we need to be able to do what we've been talking about all morning. And so I want to talk about some of the challenges that result in this context. And so to make sure we're all on the same page, I want to start with some basic ethics and regulatory information, which is in the United States and sort of globally, we have some general principles that we follow in research, which is respect for persons, beneficence, and justice. Respect for persons, meaning you mostly hear about this in terms of requiring consent, the topic of our panel this afternoon, as well as I always look at it as an obligation to protect confidentiality. And that's one of those issues that I think is being challenged within the context of precision medicine right now, as I understand it, and to talk a little bit more about that. Beneficence generally is thought to be the minimization of harms or risk and the maximization of benefits, and then justice, the equitable selection of the participants. And in addition to having these principles that in the United States get translated into the human subject regulations, which most often referred to as the common rule at 45 CFR 46, in addition to having these 3 requirements, you also have a requirement for independent oversight. So you have to have an institutional review board that reviews your study and determines whether or not it meets the regulatory criteria. The challenges in precision medicine and to the current regulatory approach is the fact that much of the research that we're talking about can actually be conducted outside of that general regulatory structure and ethical structure. That at least a lot of genomic research can be conducted without consent, either because it's not considered to be human subjects research at all, and that can be if you have, somebody has the identifiers, but they promise, cross my heart, I will not tell anybody else who this person is, and you can do it without consent. Or it might be exempt under the regulations if you're recording in such a way that you're not going to be able to go back to the identifiers. And even if you don't fit into those exemptions, you can get a waiver of consent from your institutional review board. So there's a lot of work that has been done up until this point that has been conducted without people's really knowledge or their consent. And there's some reasons for that, and that is sort of the underlying assumption that there's no physical risk to anybody. There's not really much risk at all, and so most people would agree. And the idea, too, that we can de-identify or use anonymous samples, and therefore, how is it going to harm somebody? On the other hand, there have been a host of studies over the last decade or more suggesting that maybe this de-identification thing isn't as good as we thought it was. And that you can take some information, combine it with other publicly available information, and re-identify people. Now, let's be clear, this is not something, or I'm not going to make assumptions about other people in the room. I can't do this, right? It takes some know-how in terms of really wanting to do it, having the technical savvy to do it, and the will to do it. Most of these studies are by researchers just trying to show we can do this. But it does raise questions about how we go about our, some of this research. That coupled with a couple of various cases recently that have suggested the assumption that people wouldn't mind isn't that true either. That there was evidence that people want to be asked to participate in research. So there were 2 cases, litigation in Minnesota and in Texas, involving newborn spots. So when babies are born, you take a spot, a heel prick, and you take their blood and you run DNA, genetic testing in order to see are they affected by any condition that you could address right then and there. Those spots on the Guthrie cards are then often stored, and they're a wonderful source for research. In part, you've got this wonderful population database in which you don't have to worry about selection bias. You have actually a representation of your population. But the problem was people weren't asking the parents. And in Minnesota and Texas, you had parents who filed a lawsuit and said, you should have asked us. As a result of settlements from those cases, you had millions of samples that were destroyed, and some other changes that were implemented. And now you've got the federal law as of December 2014 requiring permission. And so suggest people want to be asked, and in fact, some of the plaintiffs from those lawsuits said, it's not that I objected to the research, I just wanted to be asked. Another example suggests that some people don't only want to be asked, but they may object to some of the things that we put their materials to use. The example I have here is the Havasupai lawsuit. So the Havasupai are small Native American tribe in the Grand Canyon. They had some of their blood taken for diabetes research. It was an issue of concern for the tribe. So they went to researchers asking for help. And the researchers then gave some of that material to other researchers to use for other things, including research on schizophrenia, inbreeding, and migration. And I think we can say under any circumstance, schizophrenia research and inbreeding research may be considered stigmatizing at some level. The migration research was particularly troubling for the Havasupai because as part of their creation story, they came out of the blue-green waters of the Grand Canyon. If you've ever seen pictures of the area of the Havasupai, it's spectacular. And this migration research said they came over the Bering Strait. And it was very clear that the Havasupai would never have agreed to any of this research that was done. And they objected, they brought a lawsuit. Arizona State University actually, I think, did something remarkable. They apologized to the Havasupai, even though what they did was legal, right? The regulations still permit those other uses, but they recognized a wrong that was done to the Havasupai and actually returned their specimens, which again is another thing that I've not seen done. So at least we know that there's some of our assumptions are not necessarily correct, at least in some circumstances. So where does that fit in with precision medicine? And I want to be clear too, because Carrie's going to be talking about the precision medicine initiative itself that NIH is sponsoring. I'm not necessarily talking about that initiative in and of itself, although we are using it, or a precision medicine-like initiative-like situation in our study, but that, the concept of combining all of this various data that we can collect. So it is the genomic information. It is the information we are used in research for a long, long time, asking questions, but also the information from my Fitbit, my cell phone, and all of those other places, and combining it in various ways that really can give us a incredible picture of both the genetic information and things that are happening for people in a particular condition at various times, in just a wealth of data. But it also raises unique issues under our current regulatory scheme in the sense of the quantity of the data combined. If the thought of we can maybe de-identify people, we can keep things protected, start to be much, much harder when we are combining all of those different streams of data, and might become much more identifiable if people want to do that. The other thing is this challenge to confidentiality that's not just about de-identifiability. We have certain assumptions about how we protect data in research. Typical model, you have a researcher, and they have access to the data, and they will take on certain approaches. They will limit who has access on their team to the data. They keep it in a locked room and hopefully on a secure computer, and do other things to try to protect it. It's quite different if the person who holds the data is the research participant themselves. The mechanisms that we have in place, like HIPAA, like a certificate of confidentiality, which is a research tool that allows you to protect sensitive research data, is that data is not held by the researcher anymore, and those laws may not apply. And so changing the research modality here actually changes the legal tools we have available to us to protect the research data and to protect the participants and their willingness to participate in the first place. So there have been a few responses to these challenges. If you're aware of research ethics and following that, you'll know there's been a notice of proposed rulemaking, which is suggesting changes to the common rule. They would require broad consent for biospecimen research, which may address some of the issues, but it still would not address, for example, the Havasupai case. And they also would still include exemptions for records rather than the specimens, which raises other questions. So if we are just having all of our DNA information translated into a computer file, it may still be able to be used without consent. We'll see what happens to the NPRM. There was an advance notice of proposed rulemaking in 2011. It took us, 4 years to get to the notice of proposed rulemaking, and yesterday the Secretary's Advisory Committee on Human Research Protections suggested they go back to the drawing board at some level. So we'll see. There's also been a number of participant-centric models that really are suggesting that people ought to have greater control over how they consent to data, and I don't know, Aaron might be able to speak to some of this, and that you can choose who has access to it and have a finer grain level of providing consent. But again, if it's not clear that some of the rules will apply to some of the models that are out there. And so, as I say, some solutions may not respond to all of those issues and may actually create some new ones. In my remaining minute or so, I just want to talk to you about what we are doing in our project. And what we're trying to do, we've got a component which my colleagues at Duke are conducting, which is talking to thought leaders in the area and trying to identify where areas of concern are. And I'm leading a team at Georgia State, and we are actually looking at the range, as my title suggested, at the web of legal protections available in research. And so we've been looking at a number of different laws. We are still in that process, so I can't report results, but trying to look at both federal and state laws and seeing where there are sort of gaps and where there are strengths, and trying to identify, as we move into a new era, are there new gaps that we weren't aware of? And how do we respond to that so that we can make recommendations so that we can ensure that this really incredibly important research goes forward, but we are continuing to maintain our promises to participants and encourage them to continue to participate in the research that we want.
Thank you.
Not clicking on the right spot. See if you can do it. It's not liking me. Yeah, it's just not letting us close. There it goes.
There we go. Of course, just as you arrive.
Yeah.
It's always the way it works.
The IT magic.
That's right. You just get close enough and it works.
You have to click. It's not a tab.
Double click. Oh.
There you go.
Oh. And then you're
Right, not a tap. Got it. Hello. So now that we've handled our technical difficulties here, I'm going to talk a little bit about the Precision Medicine Initiative cohort program. So taking Leslie's sort of theoretical precision medicine program and putting some flesh on its bones and turning back to some of the ethics and policy issues that we see resulting from that. I'm going to fly through some of this in the interest of time and because I'm a naturally fast talker, but I'm happy to dwell on anything you'd like during questions. So we've heard a lot about this already, the challenges that precision medicine is really trying to address in terms of treating the population not as sort of a general population, but as individuals with key differences in their genetics and their lifestyles and their responses to various health interventions. But I think another very important aspect that precision medicine is trying to address, which Leslie just touched on, is really turning the research paradigm on its head. So we are trying to really re-engineer clinical research as we know it. And part of that is really making sure that research participants are active partners at the table of precision medicine. What does that mean exactly? I think that's something that is shaping up as we go along, but I'll touch a little bit on that as well. And then integrating through partnership with healthcare provider organizations, the research and practice of health in a very sort of real-time integrated way that allows much quicker translation into medical practice. So everyone wants to know about the money. So here's the money. There are two sort of branches that NIH has responsibility for. There is the PMI oncology program. This is really sort of a very cancer-focused and much farther along kind of therapeutic development program. But I want to talk about our cohort program specifically. So just a little bit of background, there was a working group of the advisory committee to the NIH director that came up with the vision for the PMI cohort program. And in a nutshell, it's at least 1 million person, possibly more, because why stop at 1 million, right? You might as well keep going. Research cohorts that is really designed to create a sort of large research resource for the entire biomedical enterprise. And some of the very sort of top of the order questions that the working group had to struggle with is, do we leverage existing research cohorts, sort of creating a patchwork quilt of them? Do we create a new cohort de novo? How do we make sure this is diverse? What kinds of data are we talking about here? And ultimately, what policies do we need to be in place to make sure that the vision for PMI can really be fulfilled? So this is a working group, very important people. So they spent a lot of time in very rapid speed fashion collecting information in a lot of ways. There were a number of workshops that were held over the spring and the summer on various topics related to PMI, in which we drew on a lot of the expertise out there across the country. We had a number of requests for information, particularly on building the cohort itself and addressing issues of representation and health disparities. We did some survey research to figure out what does the public really think about precision medicine in particular, participating in it. And we've been working, of course, this is a trans-government initiative. We've been working very closely with the White House, who's had a special focus on privacy and trust in the context of precision medicine. I don't want to spend a lot of time on the scientific opportunities for precision medicine. You could spend all day on that. Suffice it to say, they're really exciting. You talk to a lot of scientists, and once their imaginations start running away with them, they begin to sort of drool with excitement about the possibilities such a large cohort would provide. So the commitment to assembling the PMI cohort based on this vision that the working group really articulated was to create a cohort of, as I mentioned, 1 million or more volunteers that are really reflective of the broad diversity of the U.S. population, but not necessarily representative. So representative, has a very specific term, statistically speaking. So and can be quite difficult from a feasibility point of view to put together. But we do want to make sure that there's broad representation from traditionally underrepresented groups, and that that the cohort reflects a great diversity in age and in health status, et cetera. It's envisioned as a longitudinal cohort, so it'll be around for a long time with sort of ongoing interactions with the research community, and will be available for recontactable studies. So it's not like someone just gets one bite at the apple of the precision medicine cohort. This is really seen as sort of a long-term human resource for the research enterprise. And being involved in the Precision Medicine Initiative will mean supplying your electronic medical record, essentially, a biospecimen, which is likely to be a blood or saliva sample, participating in a survey related to sort of your lifestyle and health status, perhaps, and some sort of baseline health exam. We are right now anticipating we'll have sort of 2 methods of recruitment. There's the direct volunteer program, in which any of you or anybody in the country can raise their hand and say, I want to sign up for the Precision Medicine Initiative. And then we're also, to help us with that goal of a broad and diverse representation, partnering with healthcare organizations, particularly the federally qualified health centers, to allow us to reach traditionally underrepresented communities and make sure that we are hitting those diversity goals. One of the advantages of healthcare provider organizations is they have built in a lot of the infrastructure that is necessary for the precision medicine cohort to succeed, the electronic health records, the relationship with participants that allows easily recontactability, et cetera. Some of the benefits of this approach, of course, is that when you've got a large and diverse cohort, there are some economies of scale that come into play there. It allows you to do smaller but very statistically well-powered research projects. And it allows us, in a way that we've never done, because this is such a monumental effort, we just haven't had a cohort on this scale, to begin to see some of those associations between health conditions and the environment, perhaps, or genes in the environment that you just can't see in a smaller population size. And it allows us to focus on communities sort of within the cohort. And the idea here is that the Precision Medicine Initiative is not replacing all those other cohorts you may have heard of, whether it's the Framingham Heart Study or the Nurses Study or the soon-to-be-revised Children's Health Initiative, but really to complement existing initiatives that are out there. So what are we talking about in terms of the kinds of data that we're collecting? It's envisioned that everyone participating in the Precision Medicine Initiative will provide a core data set. I've already mentioned a little bit about this. A blood sample, for example, access to their electronic health records. In addition, it's anticipated there's going to be a big mobile health or mobile technology component of the precision medicine. So participants will have a mobile device or a Fitbit that will allow the initiative to collect sort of ongoing data related to smartphones or wearable sensors. And all of this will be centrally coordinated and stored by a data coordinating center. And the idea is we're trying to make this as interoperable as possible, to be able to align it with existing data sets. For example, the Millions Veterans Program, which already has a tremendous number of volunteers, and allows us to hopefully leverage existing data standards whenever possible and common data elements. We're not looking to totally reinvent the wheel here when it comes to the data itself. There's a lot going on in this space when it comes to big data, and we want to make sure that we are taking advantage of work that has already been done. So this is basically what I just said in graphical form, that you'll have direct volunteers, you'll have healthcare provided volunteers, and they'll all be providing these baseline sort of data elements, which will be stored somewhere in a cloud, presumably. And so one of the very first items in order of business to make sure this gets off the ground is establishing a biobank. And just last week, 2 weeks ago, time's blending together, there was actually a funding opportunity announcement to establish a biobank. And we're trying to anticipate what future uses of those would be. This, has sort of natural alignment with what Leslie just talked about in terms of where the common rule is going and consent for biospecimen. And these are things we're paying a lot of attention to. And there is also, there's this initial sort of core data set, but we also want to be open to the possibility that when you recontact participants, you may offer them the opportunity for a greater interaction in a research study where they might provide other samples in the future, whether it's biopsy samples, stool samples, what have you. And so another thing that we are very cognizant of is making sure we're in alignment with CLIA, the Clinical Laboratory Improvement Amendment, so that we can return results and make sure we've got sort of certification and standardization across the board. I've already mentioned those. So then, how does the data get out? This is an interesting question which is triggering a lot of policy discussions, both within NIH and across the federal government and research community. There is certainly clearly data that goes out to the research community because we want researchers to be able to take advantage of this rich resource. President Obama himself has made it very clear that he is very committed to making sure that participants in the PMI cohort are able to access their own data and that there's a return of results to participants. What return of result means is very different to many people, and so that's one of those things we have to figure out. And then there is also an anticipation that in some form we want to make this data public, and what form that is, what sorts of protections need to be in place in order to do that is something we're spending a lot of time thinking about. And we anticipate that the data is going to accumulate very, very rapidly, and so that raises a lot of infrastructure and resource questions that clearly need to be addressed. So return of results, I mentioned that President Obama himself is committed to this, and this is something we've heard loud and clear from the participant voice who've been engaged thus far in the Precision Medicine Initiative. People want their results returned to them. Some people want the results returned to them in real time at raw data, individual level. Others really want specific health, more health relevant information. Others just want to know what the study's doing. They want ongoing updates. And some say, just tell me when it's over and what your conclusions are. And so we want to make sure that the cohort program can accommodate that sort of range of desires in participants and think about how that's going to work operationally in terms of the people involved. So I'm the head of the Office of Science Policy at NIH, so where I spend a lot of time thinking about the Precision Medicine Initiative is really sort of what are all the moving parts of policy that we need to coordinate in terms of making sure that the Precision Medicine Initiative cohort program can launch effectively. And I think herding cats is not really an adequate analogy for this. I don't know what scrambles faster than cats, herding ants or fleas perhaps is a better analogy, because there's a lot of pieces. Just to give you a few examples, I think it's going to be pretty critical that the Precision Medicine Initiative be able to take advantage of a single institutional review board for review of pieces of the study, because this is going to be a very large cohort, and if you have to go through hundreds of sites in order to get a protocol reviewed, it could be incredibly delaying. We're thinking a lot about privacy and security, standards for data security. This is a lot of potentially sensitive data that we're going to be collecting. How do we make sure that it is secured appropriately? And how do you put in place safeguards against unintended or deliberate release of that data, as well as penalties for those sorts of things? Penalties both for unauthorized access as well as unauthorized re-identification. As Leslie already mentioned, in some ways, science and technology is progressing in such that the term identification is sort of losing its meaning in a lot of ways, or the line between identifiable and de-identified is really not a very dark line anymore. And so knowing that it may not be possible to protect data against identifiability, what sort of very high walls or penalties can we put into place so that if you did try to re-identify that data inappropriately, you would get hit with a very large hammer? And so that's some of the things we're thinking about. Making sure that current regulations, including CLIO, which I mentioned, and HIPAA, allow the sorts of return of results to participants and access to researchers that we really see as part of the PMI cohort vision. And then we're spending a lot of time, too, thinking about if we want this diverse and long-term cohort, there are a lot of policy considerations related to vulnerable populations. So ultimately, we'd like to have children included in the PMI cohort program, and so that raises questions about consent and the ethics of the types of studies you can do. Decisionally impaired. Now, this is interesting because it's not only people who are decisionally impaired when signing up for the cohort, but you could presume that you could have people who are going to have changes in their cognitive or decisional impairment status along the way if this is a really long-term cohort. And so how do you deal with those issues? And then, another issue which is quite relevant is if you have a large and diverse cohort, you can reasonably anticipate that some portion is going to be incarcerated for some period of time during the course of their participant in PMI. In some states, for example, it may not be possible to give consent to participate in research while you're incarcerated. And so how do you deal with that in the context of cohort continuity? Do you allow those people to re-enter the cohort? Are there state and federal laws that need to be reconciled? So these are the things keeping me up at night. I will stop there, flip through this, and just give you a feel for how all of these pieces relate to each other. We're hoping to pretty quickly set up the direct-to-volunteer recruitment early in the new year. And you may have seen, as I mentioned just a couple of weeks ago, that we issued a number of funding opportunity announcements to put together the coordinating center, the biobanks, and participating healthcare organizations. So these are out on the street, and we hope to get those pieces in place soon. Told they are.
Okay, well, I'm last, and I hope you guys are all still awake after lunch. That was a great meal. And I'm going to talk about precision medicine and the actual consent and what they wrote in the document. So one of the things I did in preparation for this is I actually read the white paper from beginning to end last week with this, and I also kind of analyzed some of the terms there and what they were talking about. So one of the things I want to point out is that some of the things that have been really reiterated through the document is this new model of clinical care, and Carrie spoke very concisely about that, and to engage individuals as active partners. And they feel like this changing role of the science of medicine is correlated with this changing culture of how people want to engage with their medical care and medical research. They want to be partners, and researchers want patients to be partners in their health care. And they want to get results back quickly, and they want basically more actionable items quicker. I mean, who doesn't? One thing I want to point out, though, is the role of informed consent over the past 25 years has really increased in importance. Some people have argued that it's been put in place to protect researchers or institutions from accusation, litigation, compensation claims. Some people have now argued that informed consent is in place because it makes it harder to deceive, manipulate, or coerce research subjects, and it helps indirectly with building those trust relationships. Why some people still think informed consent is a way to protect patient autonomy in these relationships. But are there limits to informed consent? It's well noted in the research evidence that the consent process right now is seriously flawed. Over a 45-year period where people were recruited into clinical research trials in a one-to-one scenario where they're actually talking to a research assistant, at best, only 50% of the people could comprehend or remember what the purpose of the clinical research was, the risks, the benefits. So right then and there, that's setting up some challenges for consent for the precision. I just want to start over, sorry. For the precision medicine consent form. So one of the things that the precision medicine outlines in their document is that first they want consent to be delivered on a digital platform, which is great. And they want to include these specific aspects of information. So collection of their identifying information, and that they would keep it secure, permission to use their identifiers to link across data sources using those identifiers, permission to recontact, permission to share specimens and data for future unlimited or future research. Sorry, I was thinking the notice proposal we're making. And then clarification that the data already contributed to research studies cannot be withdrawn if they withdraw from the cohort study. So before I go into the next slide, I just want to set up this my assumption here that I do think precision medicine is a good thing. I want it to work. But I also have done an extensive amount of research on people's perceptions about research. You know, we have an R01, Carrie talked about, you know, biobanking and newborn screening. We have one with the state of Michigan looking at how can we improve the consent process so that parents are making an educated, informed decision. That's working closely with the Genetic Science Learning Center, who are great at educating the public and teachers and schools about genetics. And then, you know, I'm on an NIH working group to study the consent process and how best to explain to participants how to share their biospecimens and data. So in saying that, when you look at what should be included in the consent form for the Precision Medicine Initiative, a lot of people are going to think the government wants unlimited access to my healthcare data. The government wants my DNA. The government wants to recontact me so they potentially could be following me. And the government does really not have any hypothesis-driven research at this time to tell me how my data, how they're going to keep my contact information, and how they're going to keep my biospecimens to be used in what studies yet. And that's okay. I mean, we're developing this resource, this cohort, but there's no changes to the whole foundational process or document that is binding that relationship between precision medicine and the research subject. And I have this question, do we undermine trust because research subjects are unable to form an accurate opinion about the research if we're not improving the consent document? When you look at the precision medicine document, 88 times they mention the word engage or engagement. They really want to engage with the public, but there are no noticeable suggestions or changes to how they're going to educate or improve the consent process so that people understand clearly what they are signing up to. We've done extensive work with biobanking, and a lot of people don't understand what unlimited research is. They're like, yes, you can use my biospecimen any way you want. And they're like, great, so you're okay with broad future unlimited research? And they're like, yes, but every time you use my biospecimen, can you contact me and let me know? So there's this disconnect about what a resource is, what's future unlimited research, and what people are expecting. Bless you. So we're proposing this new model of clinical care, but we're not proposing a new model of consent. Again, engagement, engagement, engagement. We really want the public to be partners in this precision medicine initiative. We want new methods to engage. We want them to be active. And most of all, we want them to trust in this initiative. And we have millions upon millions of dollars going into this, and it's a promise. I think we're at the right time for this initiative to actually make a difference in healthcare on a much larger and faster timeline. One thing I want to point out that's in the precision medicine document is they have one sentence in there, and it says it will be critical that educational efforts and general safeguards are undertaken to limit, they're not denying this, the likelihood of investigators unintentionally breaching trust. And if you think about it, if you think about everything that Carrie and Leslie have talked about, the number one breach to, I think, confidentiality, privacy, or even undermining that trust with the public is how the investigator on his own or her own uses that data in a way that is consistent with what the intended purposes are. Some people can use it for other ways, and the Havasu pie is one issue. The newborn screening lawsuits are another issue. And we have to realize that it's not that they were doing anything wrong, but even with the new changes to the proposed notice of rulemaking, we are changing the paradigm, I think, to how research is done, and we're giving less oversight to some types of research. We're giving more independence to investigators through the use of broad consent for future unlimited research. And in general, we are trusting investigators more to do the right thing. So I hate when people criticize, and then they don't propose a solution. So, I have two solutions that have been working quite well with our research team. The new model of consent cannot just be that document like, read this, sign here. It has to include 3 different components. It has to include education. One thing that we've learned is that people, in general, when you're talking about biobanking, they don't understand that biobanking is taking a specimen and storing it. And then someone later, when they have a research study, will access it and use it in a manner that they don't know how they're going to use it yet. You have to engage participants, and I think one of the things that Carrie talked about is that asking people their preference for how they want the return of results. Some people, I think that was posted in Nature today, the IRB was telling this researcher they don't want you to return results, and so he Twittered, do you think it's okay to return results to participants? My IRB doesn't think so. What would you suggest? And it kind of went viral, and they wrote the article up, and so engagement, I'm not quite sure how that's going to be done, whether it's going to be through crowdsourcing and not just having one person serve on a committee. I'm on the IRB, we have community members involved, and it's one person who's highly educated and retired, because who has time to volunteer in the IRB if they're a working mom? And then ethics. So that's one solution to potentially how to improve the consent process. You can't really think about consent as just a document. You have to think about it as a process that involves education, engagement, and then ethical behavior. But I also admit that there is a limit to consent as a standalone process and document. How many people here are on their iPhone and Apple says, here, if you want to continue using iPhones or iTunes, click here. I've never read that, and I know it said give up your firstborn child, but give me my iPhone, my iTunes, so I can listen to music. So something that we've been looking at is this culture of investigator behavior. So I conducted interviews with investigators through the Intermountain West, asking, what would you think about if we had an investigator oath? Or what if we had an investigator consent process, where it's not just the participant consenting all the time? Why is the investigator, who's the one continually using the data, continually accessing the biospecimens, and engaging in research without recontacting the donor, why aren't they signing a consent form? Why aren't they having some type of oath that says that they'll do it? Thank you. And so we conducted interviews, and for decades, the FDA has required a letter of commitment by investigators before they allow them to conduct the research. This isn't a new idea. So it's something that popped up is a lot in these interviews with investigators is they kept referencing the Hippocratic Oath. And they said, I know I'm doing research, but the type of research that I'm doing is changing. I'm no longer looking at broad societal impact. My research can have an individual impact. It may not be on the same timeline as a physician, but 5 years later, my research is going to impact someone's individual health. So this changing dynamic of investigators is out there. And then most importantly, who cares if an investigator signs an oath if it's not made public? So, it's kind of like the honor code. Students who sign the honor code and it's made public, they actually cheat less. So I asked investigators, how comfortable would you be signing an investigator oath saying that you will engage in these trustworthy activities and giving it to the research subject when they sign consent for the Precision Medicine Initiative or for broad consent for future unlimited research? And everyone's like, great idea. I'm like, what should it include? And they're listing off ideas. Then I asked, well, what if we made that oath public and hung a poster up in the clinical waiting room with your signature on it? they're like, yeah, I could do that. I'm like, all right, what if we add the oath in the clinical waiting room of a hospital and added your picture? And they're like, well, why? I said, well, I mean, you're saying that you're going to engage in these honorable behaviors, that you're not going to try to re-identify someone. Or I mean, the oath components were quite reasonable. I'm not going to share my biospecimens with my buddy in another institution without an MTA. I'm only going to engage in research that I find is to be a benefit to society. Nothing controversial like giving up your firstborn child. And then I asked, well, what if I video record you and put that on a website? 100% of the investigators in the Intermountain West that I interviewed said no. There's no way. I'm like, well, then why are you asking for donors to give their biospecimens, their health data, and putting basically their privacy in your hands? And they just said, I just don't feel comfortable doing that. And so that just was like a red flag to me. And so, of course, this data has been accepted for publication. But, you know, I also think about the Utah Genome Project. You know, Utah has an extremely high participation rate for genetics research, and that's because they have a high level of trust. But Utah is not like the rest of the United States. We don't have some centralized religious organization working in, you know, connection with a pretty much Salt Lake City where there's these one large hospital serving the state. It's a unique entity. I mean, if we're going to truly move the precision medicine initiative forward, the investigators also have to consent and agree to ethical standards of behavior like we're asking participants. I know it's not a novel idea, but it's an idea that we're pursuing, and we're in the middle of a Delphi study to finalize the oath, and it's quite interesting. So thank you.
Thank you to all three of our panelists, and the floor is now open to all of you. There's one. There's several right over there. One back there.
Hello. My doctor's nurse contacted me a few weeks ago about participating in a clinical trial, and I agreed. So last week I went out to the clinic to fill out all of the papers, and I got handed about 15 sheets of questions about me personally and my medical background. And it's all talking about how this is your personal information. We're going to convert it to a number, and that's the number that's going to be given to clinics and to labs and things like that. So nobody will know who this is associated with. And that was all good until I got down to about the 10th page, and at the top was HIPAA. And
you actually read all of them? All the pages?
Well, after 30 years of practicing law, I thought, you know, I think I better read this one. So anyway, and here's this HIPAA deal, and it says, okay, well, we're going to protect your privacy and all of that. And then it says, but we're only going to, but you agree that we can reveal and provide your personal information to the following. And one of them was this national organization that put together the study and blah, blah, blah. And then about the fourth one down, it says, or any other regulatory agency. And I went, whoa, wait a sec, what does that mean? And then below that was a paragraph that said, and if any of these people who we reveal it to, they reveal it to anybody else, then your personal privacy is no longer covered. And I walked away thinking, is that the standard of consent and privacy in these things? What's going on here? This is, I mean, as far as I'm concerned, this is a great lawsuit. But anyway, and that was last week, and I actually had to take that with me because I wanted to read it again, and I just couldn't believe it. Is that the standard? What's going on there? I mean, there are studies going on all the time, and I asked the guy, I said, what is going on here? This essentially is no promise at all. And he says, well, you're the first person out of hundreds that has ever said anything about it. And I mean, there must be hundreds, maybe even thousands of people out there who just waive their rights to any privacy at all. What is the standard? What's going on?
Well, I would say one of the reasons why you were the first was you read it. right? And that, in fact, I mean, one of the things that one has to say in a HIPAA authorization are the exceptions. And our general assumption about HIPAA is it's the be-all, end-all, and it will give us major protections, right? And that is, of course, some of the intention is to provide a uniform standard of protection across the nation. But there are a large number of exceptions, including, so for the regulatory agencies, like if the regulatory agency has a good reason to come in and look at the hospital or clinic, then they may get access to your data. And so they are giving you that information and telling you some of those exceptions. But as I say, you are one of the few people to actually have read and realize that there are those exceptions built into the HIPAA protections.
Well, and I also want to point out that, I mean, let's think about this on a broader scale. If you think about biospecimen research, there has not been really one case of actual harm. There has been, you know, the Havasu Pi and some law cases, but that has actually resulted in harm to an individual. So most of this is minimal risk research. And for the most part, HIPAA, I mean, I think was the 2013 Reauthorization Act. They made a change that it didn't have to be study-specific information, but more general information about how your health data is going to be used to help facilitate research. And this is something that why you have to sit down and educate people, whether it's through exciting multimedia videos created by the Genetic Science Learning Center, or, but you have to make people understand what that actually means. What does that really look like? Is, you know, are they going to really, I mean, release it to some insurance company or, you know, health insurance? I mean, no, not really, but that language in there is forced. So to have some type of education to help people understand really what does that language mean, what does this look like in concrete examples, that's going to help improve the consent process.
It actually goes to Carrie's point, too, about the kinds of protections they're talking about for the Precision Medicine Initiative, because, again, the changes to HIPAA have said it used to be just the covered entity, really, the hospital, right? And now with the amendments, it now extends to their business associates, and they can be penalized at the same level. And so it can get out, but there are mechanisms and expressing that and letting people know that there are other mechanisms at work to discourage others from revealing the information.
You may have answered my question, because it seemed to me the most important part of what he was saying there is that we may give this information out, and once we do that, we're not responsible. And that is kind of worrying, because you have no control about how they give you your information out, and they've just told you that once it's gone, they're not responsible. Is that true?
So
I'll let you take this one, Carrie.
Yeah. You know, this comes back to sort of my point about related to the point about sort of identifiability and where do you put the pressure points from a policy point of view? And I think a sort of good analogy is remember the missed dig campaign, where you're supposed to call before you dig so you don't hit any power lines, kind of a thing. And so it used to be they would try to prevent people from digging up power lines because it was causing all of these crashes of the grid, and that just didn't work. So eventually what they did is sort of put redundant systems in place, and that seemed to work better. I mean, in thinking about where you put protections, you could put protections on access, so who accesses the data and how that data can be accessed. Or, another option is you could sort of accept that, there are limits to the feasibility of that because data might be shared inadvertently or deliberately, and make sure that you're putting in place severe penalties for that in a way that incentivizes people to behave responsibly. And so that's a lot of what we're thinking about. And also the use of data comes into this too, right? So one of the reasons people are concerned about release of genomic or health-related data is because there are actually very few legal protections in place in terms of what the world can do with that data once they find out about it. So, we've got our Genetic Information Non-Discrimination Act, GINA, which does protect against some sort of misuse of that data or data, to make health insurance decisions, that sort of thing. But there are very few of those protections in place. And so making sure that we're looking at this sort of comprehensively and holistically so that it's not just this kind of hodgepodge of, well, we've got these big gaps in between our various sort of privacy protections, but that we've got a whole series of protections in place so that, someone inadvertently or deliberately shares your data. Well, there's a big penalty for that. And, even if they do that, the data is not going to do anyone any good because there are penalties for people misusing those data, and making sure that every step of the way contains those protections in a way that is sort of risk commensurate. And but that requires a lot of sort of reconciliation of quite a diverse array of different sort of rules and regulations currently existing.
Before I start, I think I will accept that you probably won't be able to give me a good answer. I noticed there's a Facebook logo up on the screen. And I'm on Facebook, but just minimally. But my kids are on Facebook, and the data that they give out comes back to me. Same analogy, or same thing applies to genetic data that I, or my wife, or my parents, or my cousins, how much that comes and identifies me, and what rights I might have, or future generations might have to control that data.
So you're right that there's not necessarily a good answer to that in terms of there hasn't been a definitive look to say you are clearly a research participant if your children decided to participate and that information could go back to you. Our research regulations don't think about necessarily think about the impact on others, which is why I think the Havasupai case remains a problem. There was a case now many years ago at Virginia Commonwealth University in which a very long questionnaire went out, and it came to the parents' home because it was a college student. And when they looked, there were very, very specific questions that very much were about the parents and would have been identifiable. And since our regulations are about is the information, private information, identifiable information on an individual, that meant they should have been considered a participant in the study. But we still do lots of this that, so that it's been raised, but I don't think that we've gotten a great solution for people who might be concerned about that.
Well, and I think to Erin's point earlier about the misuse of biospecimens and whether actual harm has been done. The other thing as we have these conversations to always sort of keep reminding ourselves is at the end of the day, this isn't just a risk analysis, it's a risk-benefit analysis, right? So there's great benefit to free sharing of information and potentially an access to information. There's great benefit to the use of participation in research and providing your genomic information to the research community. And so I think it's really a question of making sure we're balancing those two things, the benefits of, sort of broad access and to biospecimens, to information, to be shared among research communities and participation in research itself, with the potential risk that presents to a population, to an individual, to those related to the individuals, because it's really easy to get focused on one or the other and not think about them in a comprehensive way. And I think it's really important to do that because you don't want to lose sight of that balance.
Well, and that's why it's so important to educate people about the precision medicine safeguards. But your point also is very relevant to, highly penetrant cancer genes. And you know that this is a highly penetrant cancer gene. You should tell your sisters, you should tell your nieces, and it's that patient's responsibility to share that information with family members at this time. That's the recommendation with the genetic counselors. And so, but people are also like, I should reach out to these other family members, and I just don't know what to do. So I feel like you're asking a question that's still being struggled to within the clinical context as we keep moving forward. But for the most part, I mean, education and engagement is going to help improve that and preparing people to share that information. Because I think family history is still the most accurate and best way to diagnose a genetic condition running in your family.
I think we can do one more quick question. There's one here. Yeah.
Thank you. My question concerns how you balance the very obvious benefits of providing research results and a payback to a public who have funded and who have volunteered in research with the very likely possibility of changing the results of dozens or even hundreds of ongoing studies. So as someone who studies the effects of giving people genetic test results, these are themselves very powerful manipulations. Could you say a little bit about how that might be handled in a project of this scope?
It's a great question.
It is a great question, and I don't know is sort of the actual answer. So this is something that is really going to have to be worked out in the structure and governance of the cohort program very early on, because this sort of commitment to returning results and the integration with the healthcare provider organizations, in particular, the use of self-reported data and mobile technology does present an interesting situation in which you have very sort of real-world effects going on, and how do you build those into the design of your research experiments? I mean, this is something that it was brought up at the very first workshop on precision medicine. So you envision this world in which someone, but through the participation, is getting sort of real-time return of results related to blood sugar measurements, for example, and they're talking with their clinician, and they make some change. Well, this is very different than kind of what we think of as your classically designed, experiments in which people are passive subjects, and you say you're going to do A, B, or C, and then you compare those groups. And it's an evolution in the way we do research, quite honestly, and I think is something that there's going to have to be a lot more discussion among the scientific community, and in terms of the thinking through the design of the experiment itself. It's also something else I think we haven't figured out that we're sort of learning as we go along is part of this concept of participants as partners is they want to be at the table from day one. I mean, so they want to think about what are the scientific questions that we want answered. What are the scientific questions we don't want answered, and how do you structure those appropriately? And that's a real paradigm shift for the scientific community. Is it good? Is it bad? I don't have the answers to that, but is certainly very timely in terms of precision medicine. And there is a little bit of a feel of making it up as we go along, for sure. But I generally think that one of the positive outcomes of all of this focus is the engagement among the participant community and sort of the excitement to be involved and work through this kind of transformation is tremendous, and so that's positive. But there are a lot of questions that need to be answered in very near time, and so if anyone has answers, I'm in the NIH directory. Feel free to drop me an email.
I would like to suggest, and I think it goes to some of what Erin was talking about in terms of education, because my own discussion with and looking at the issue of return of results is participants don't necessarily mean always that they want their own results. And if you educated them about the uncertainty, they may not want the real-time results. They just want to know what's going on a lot of times. And that in and of itself is a transformation that many times researchers don't even say, wow, we got these results out of this and we're publishing something on it, so that if we do something, we are doing a lot of what participants want, and that they know, in fact, something good is coming out of their participation.
I hate to cut this off, but I think I need to thank this wonderfully rich panel, because we've got another one to come. Thank you all very much.
Okay. Hello? We back? Okay, if we could get people to take their seats, we will get started with the last, but by no means the least panel of the day, led by my colleague Tenniel Brown from the College of Law on precision medicine and the very important question of race. So, Tenniel?
Great, thanks. Thank you very much. I'm sort of losing my voice, so I hope that's not too annoying. As George mentioned, my name is Tenniel Brown. I'm a professor here at the law school, and we this exciting opportunity, thank you for persisting in the day, to talk about the ethics of the use of race in precision medicine. And many of us are old enough to remember, even the students I hope, in 2000 and the announcement of the mapping of the human genome, how so much of the excitement surrounded the idea of what we have in common and what we share, and how quickly that turned in some of the research to this, what some have called logic of difference and what we do not share. And there are obviously important reasons for that. But I'm not going to spend a lot of time introducing the panel. I'd rather just introduce our speakers and then hop right to it. So we're very lucky to have 4 distinguished speakers with us today to talk about different components of the ethics of the use of race in precision medicine. First, we have Jonathan Kahn, all the way at the end of the table. He holds a PhD in history from Cornell University and a JD from Berkeley's Hall. He writes on issues of history, politics, and law, and specializes in biotechnology's implications for our ideas of identity, rights, and citizenship, with a particular focus on race and justice. Professor Kahn received 2 grants from the NHGRI ELSI program to support projects exploring the ethical and legal ramifications of the increasing use of racial and ethnic categories in the context of gene patenting and drug development. He's done a fantastic job writing a book on the BIDL. Perfect placement for this. Let's see. Jonathan will be speaking with us today on the dynamic whereby race is entering biomedical research and practice as an interim sort of placeholder or stepping stone on the path towards the promised land of truly individualized precision medicine. And he will consider some of the concerns and issues that this raises. So join me first in welcoming Jonathan, and then I'll introduce each of the speakers, and then at the end, they'll each speak for 10 minutes. Chanita Hughes-Halbert is next. She holds a PhD in psychology from Howard and is a professor in the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina, where she is the AT&T Endowed Chair for Cancer Equity. Dr. Hughes-Halbert is a world-renowned expert in racial disparities in health, and specifically in cancer prevention and control. Her research is supported by numerous grants from NCI, NHGRI, and the National Institute on Minority Health and Health Disparities. Chanita will be speaking with us today on the ethical, legal, and social issues involved in conducting precision medicine research in medically underserved populations. As part of this, she will describe the results of her research developing strategies to increase access to genetic services among African Americans and studies that examine barriers and facilitators to donations to biobanks. So hopefully some great connections to the previous panel. Next, we have Dr. Kimberly Kaffingst. She received her doctorate from the Harvard School of Public Health and is a professor in the Department of Communication at the University of Utah and an investigator in the Cancer Control and Population Sciences program here at the Huntsman Cancer Institute. Dr. Kaffingst's current research is focused on genomic literacy. Areas of major focus in her lab include developing methods for returning genome sequencing results that meet the information needs of patients and providers, and engaging community participants in consent for biobanks. Again, great connections, I hope, to the previous panel. Kim will be speaking with us today on the use of different communication strategies to recruit individuals from racial and ethnic minority groups, focusing on data and findings from studies conducted with Hispanic populations. And then finally, we have Sean Taftigian. He holds a PhD in molecular and biochemistry from Caltech and is a professor in the Department of Oncological Sciences at the University of Utah and a Huntsman Cancer Institute investigator. He is a co-leader of the Cancer Control and Population Sciences program. His research in his lab concentrates on 2 areas of genetic susceptibility to cancer. The first is identification and characterization of intermediate risk and high-risk cancer susceptibility genes, and the second is analysis of unclassified variants that are observed during the clinical testing of established high-risk cancer susceptibility genes. And I believe BRCA2, correct, in the cloning, responsible for the cloning.
BRCA1, BRCA2, and PTEN.
and P10. Great. So this is a terrific panel coming at it from different perspectives. We'll have each speaker speak for 10 minutes, and then we will turn it to you to ask questions. Please keep those questions or comments pretty brief so that we can hear from as many people as possible. And then I will intersperse with some questions, and feel free to ask questions of each other as well. So we'll start with Jonathan.
Great, thanks. Okay, I think my slides are about to come up. Okay, we got one. There's the other. Okay, so this is the title of the talk. So where I begin with is juxtaposing these 19th and 20th century political theorists on both sides. First, we have on your left, we have Marx and Engels, who posited this idea that come the communist millennium, the state would wither away. There would no longer be a need for the state. And I sort of analogize that to a lot of the discussion of precision medicine and race, the idea being that come the promised land, the millennium of precision medicine, we will no longer need to use race in medicine anymore. I contrast that with a century later with Buddy Holly and the Crickets, also profound thinkers of their time, who would, whose song, hit song "Not Fade Away," begins with the words, "I'm going to tell you how it's going to be," which is meaning that, my idea here being that race doesn't just simply fade away; it persists, and it is persisting, even as we're proceeding down this road towards precision medicine. So this is just an article from Nature, fairly standard, recent article just from this past summer, about the Tailored Medicine Project, and this is part of the PMI cohort we were just talking about. Aims for ethnic balance. It's front and center in a lot of this work. And so the thing about using race and ethnicity in precision medicine or in any medicine is that there's a place for the use of race, right? So the issue isn't whether to use race. The issue is how and under what circumstances. So particularly with respect to precision medicine, if you're using it, for instance, to do something like capture gene-environment interaction, there can be a lot of reasonable uses for race there, because you're looking at sort of social, historical, environmental context in relationship to genetics, and that there's clearly these interactions going on. I think it is important to consider that the environment doesn't involve more than methyl groups, that expands beyond the backbone of the DNA. But if you're only looking at molecules, the use of race becomes much more problematic. And let's face it, most precision medicine initiatives primarily, there are tons of exceptions, but primarily are looking at molecules. We've been talking about whole genome sequencing and all that sort of stuff. And when you do that and you start bringing racial categories in, there is this inevitable tendency to geneticize race, which for a wide variety of reasons, both practical and sort of political or philosophical, is extremely problematic. And so what I want to talk about here is just look at some of the ways in which race is persisting. So I begin with these two quotes. One from Lawrence Lesko, this is again a decade ago: race-based medicine could be a stepping stone to the higher goal of targeted treatment. And the second one from around the same time: as the science of pharmacogenetics, genomics develops more accurate tools to identify the molecular underpinnings of drug response, the need for classification by race will be replaced, right, by these genetic markers. And so this is the idea of sort of, the promised land. And both of these quotes came down in the context of the passage, the approval of the drug Bidil, which was it's a cardiovascular drug for heart failure. The first drug, and is so far the only drug ever approved by the FDA with a race-specific indication for the treatment of heart failure in a black patient. I've written a whole book about that, and I won't and related issues, which I'm not going to go into in great depth here, actually. But Bidil is sort of the original stepping stone in this context of precision medicine, about being held up as this idea of it will get us from now through this interim period, right? We'll use race in the meantime, because we haven't quite reached true precision medicine yet. My basic concern is that stepping stones have this way of kind of sticking around, right? Even after you've reached your destination, that the means to getting to an end can themselves sort of devolve into an end in themselves. And sort of race, once you're using race, it tends to stick around. So, and these are three of the ways I see race being used and sticking around. I talk about residual categories, commerce, and inertia, which is one of my favorite things in life. And so I'll probably just have time to talk about this idea of what I call residual categories before my time
expires, but we'll see. If I get commerce is sort of the Bidel story, and inertia is warfarin algorithm dosing. So this is an article. This is just, again, a sort of a representative article or example of how race gets geneticized in certain kinds of biomedical research. It's really a cautionary tale, right, about using race. So this is an article in Time, why racial profiling persists in medical research, and it's a story of it reports on this meta-analysis of 19,000 cancer patients, a study that's findings, quote, all other factors being equal, black patients had on average a significantly lower cancer survival rate than whites, right? So this difference, this observed racial difference, creates a space, right, for race to enter into the biomedical arena. And the next step then becomes moves from there to a genetic explanation, right? Something big is going on here. They observe this difference, right? Because they're getting equal care. And that's something, the authors conclude, must be some unknown biological or genetic factor that differs by race, right? So there's this observed phenotypic racial difference that they are presuming must be indicative of, right, in the meantime, before we have the genes, must be indicative of some underlying genetic difference. So the key thing here is to deconstruct what they mean by all, to see how this happens, you need to deconstruct what they mean by all other factors being considered. So in this case, all other factors being considered meant controlling for individual income and education via zip code, right? Which are, a zip code, geocoding in public health has a lot of good public uses. Being used as an individual level control is not one of them, right? It's a methodology that has been proven flawed in published literature. Nancy Krieger, who's developed the geocoding program at Harvard, herself has argued that as I say up there, the method is for monitoring disease trends, not for use as individual level controls. And when you break out the data from the study itself, you find that the SES data was missing from 27 to 79% of the subjects, depending on the particular study being included in the meta-analysis. So it's extremely flawed. And yet even with that, they're moving to this idea of there must be some genetic it underlying the difference. So this is leads to what I call the productive power of the unknown in the meantime, right? The idea that this is a quote from Albain from the Time article, right? For Albain's part, she says, race is a surrogate for unknown genes, right? This is the whole thing, surrogate markers, right? Which the scientists agree play a significant role in health outcomes. When we find out what the genetic it is, we will be able to test everyone for it, and we will find some Caucasians who have it and some blacks who don't, and we won't be talking about black and white anymore, right? Race will wither away, right? But again, right now, race is made front and center in ways that are extremely problematic and really in many ways not justified. So this leads to the power of what I call race as a residual category, and it was one of my core concerns with the use of race in these contexts, if it's not done carefully, is that personalized medicine in many respects is depending on race to get us through this meantime, right? Many people are, until we reach the promised land, let's use race as a surrogate marker. Race tends to cover what's left over, right? We observe this difference, and we say, well, race, there must be some genetic explanation to observe this racial difference. And so what we don't know about this difference, about the racial, I should say where it says what we don't know become racialized actually becomes geneticized, I should say. In other words, we observe a racial difference, but we don't know what's underlying it. That unknown is a racial difference that becomes geneticized, right? And the problem is that there will always be something we don't know. Right? It'll always be possible to find racial differences around something because it's always possible to find any sort of phenotypic difference depending on how you want to slice the pie, right? Or more likely slice the soup. It's, because it all just merges back together again. But so the great irony here is that we are personalizing cancer identities, for instance, through EGFR kind of typing and things, that stuff. But we're racializing human identities in this process. So if I have like a minute left or something, I'll just jump to this idea of inertia in the genetic dosing algorithm. This was one of the first sort of really validated, strong studies of trying to develop a genetic dosing algorithm for warfarin, which is sort of the perfect prototype to develop a genetic dosing algorithm because so much of the inter-individual variability is accounted for by genetic variation. up to 40 to 50%, depending on the study. So this study says, essentially genes make race insignificant, right? This example, in one of the examples in that article published in 2009, they say, the example shows that racial differences in the estimated dose become insignificant when genetic information is added to the model, right? So this, again, seems to be an example of the promised land being reached, right? We have, genetic dosing algorithm clear because historically race played a big role in genetic dosing algorithms. But you go to the supplement, and this is my last slide. You go to the supplement, and this is the dosing algorithm they developed. And I don't have a pointer, but if you look at the bottom third of the slide, you see, it starts out with, VCORC1 and so forth. It's going all the way in. You've got CYP2C9. You go down, 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 down. And then you've got Asian race, Black or African, missing or mixed race. Right, boom. So race is front and center in this. Even though it's insignificant, it's persisting, right? And that's my idea of inertia. Once you get race into a category, it's a way people think about doing things. It stays in. And that's the other concern, that even as we're developing these genetic dosing algorithms, race remains front and center. Okay, so I'll stop there.
Well, as I pull up the slides, I just want to take a moment to thank the symposium organizers for inviting me to talk about the work that I've been doing related to genomics and genetics in African Americans. And I thought, I'm like totally lost with this.
Yeah.
With this thing. Oh, no.
Okay, where are you? There you are.
Yeah, thank you. It's like, it's too fancy. Thank you.
And then here.
So again, I'm really excited to be here to engage in this dialogue with you about precision medicine. And I think, like everyone in the room, I was really excited when the Precision Medicine Initiative was announced. And some people said, well, why are you excited as a behavioral scientist? Because this has nothing to do with the work that you do. And I was really excited by it because I was enthusiastic and glad to see that it was an approach that was being developed by considering a variety of factors that include genetics, lifestyle factors, environmental factors. So it included encompassed the entire experience that one has with respect to their disease and health and illness. And so moving beyond, the potential to move beyond race as an explanatory variable was really compelling to me. And I think this idea about the 1 billion person cohort was really exciting because it provided a way to provide different types of resources for all types of investigators to think about questions related to precision medicine. At the same time, and I was really excited to hear about the precision medicine cohorts be described by the presenter in the previous panel, because I think there's a lot of excitement, but also reservations and concerns about how this cohort will be, how it will be developed and who will be included and who will be excluded. And what I wanted to talk about today were sort of general questions about personalized medicine, which are shown here, that were described by Joyner in a recent article in JAMA, but really thinking about questions around equitable access to precision medicine, and particularly starting with the precision medicine cohort. And I've been thinking about this in a couple of key research questions within the context of what I think about as being ethical, legal, and social issues. The first one being, what are some effective strategies for ensuring equitable access to and outcomes for precision medicine? There's a wealth of data from prior studies which have shown that racial and ethnic minority groups are underrepresented in clinical trials, underrepresented in genomic research. And so if you think about that sort of downstream effect, where the knowledge that's generated about the effects of genetics and environment and gene-environment interactions, then our understanding about how those variables play out in diverse populations is likely to be not what we anticipate or not what we hope will be if the cohorts are not adequately diverse in terms of their racial and ethnic diversity. We've heard a lot from the previous panel about how to engage stakeholders in precision medicine. And as someone who has done studies using community-based participatory research as the overarching framework, I think it's really important to think about those questions and develop models and systems for engaging multiple stakeholders in the precision medicine initiative. And then the last three questions, I think, are really critical about how we deliver precision medicine. One of the roles that I play is at the NHGRI on their National Advisory Council, and I think it's fascinating that with many of the initiatives that are ongoing, the study locations, the institutions where the research is being conducted, really does set up a sequence where I think there's going to be create a situation of disparities in terms of outcomes, because the knowledge that we're generating about the effects of different genetic variables and markers on outcomes and the delivery and the availability of the technology are really limited to high resource institutions. And I think that sets us up for a number of different challenges that we'll have to deal with in terms of who has access to all the benefits that are likely to be accrued through the investments being made in the precision medicine initiative. So what I wanted to share with you is some of the experiences that I've had working in the context of genetic services. And my very early studies started with BRCA1 and BRCA2 and genetic testing, and were done at a time when testing was becoming integrated and available to women who were at high risk. And one of the things I noticed was that these programs were being built at a number of the leading academic institutions, but they really weren't diverse in terms of their clinical populations. And so we set out to build this genetic counseling and testing program specifically for African Americans. And I'll say the take-home point, because I just got my little thing telling me I had 5 minutes left, is that if you build it, doesn't mean that people will come. And I just want to share with you some examples of that from our own research. And this is data from a randomized trial that compared two different models of delivering genetic counseling, where we found that if you start out with in this case, we started out with 203 women who enrolled in the study, and this was described as a genetic counseling program specifically for African American women. And even with that, at the end of the day, we had about 49%, half of those who participated in genetic counseling, and only 25% of those women received their genetic test results. And so again, I think the take-home message here is that even if you build it, people will not come. So I think that has really significant implications for the precision medicine cohorts that are being developed. And if we rely on individuals to volunteer through traditional mechanisms, I think we'll be underwhelmed with the diversity of respondents who are likely to volunteer. Similarly, if we build these programs at sort of the traditional places where this type of research where genetics research is typically done, I think we'll still be similarly underwhelmed. Just as an example, we looked at participation intentions among African Americans who were participating in a national survey study that was designed to understand barriers and facilitators to minority participation in cancer genetics research. And what we found was that about 73% said that they would be willing to participate in a cancer genetics research study. This next slide shows you some of the factors that they would think about as they were making a decision about enrollment. Most would think about the potential benefits to themselves or to others in their community. Again, sort of thinking, to me, that suggests that folks are really wanting to understand what will happen, what will a positive outcome be as a result of their participation. This describes the sample characteristics, showing that it was all African American and about half of them were men. And so we had a very diverse sample in terms of our socioeconomic characteristics. I'm going to skip over some of these slides. But what we found in terms of when we asked respondents in this survey, how likely would it be that they would donate a sample to a biobank, 53% of respondents said, well, yes, I would be likely to donate a biospecimen to a biobank. We found that those who were concerned about who are distrustful of research, and the issue of distrust came up in the previous panel. But in addition to that, those who had greater positive expectations about participating in cancer genetics research relative to their perceptions about participation barriers were also more likely to participate. So I think that the expectations that individuals have about the potential benefits that they will accrue or that individuals close to them will accrue is really important to think about as we develop the precision medicine cohorts. So a question that I've been asking myself is, well, how do we conduct precision medicine research in populations that are less willing to participate? And if you think about the data that I showed where there's a high level of intentions to participate in research and sort of enrollment rates that are actually, when you ask someone to sign and provide informed consent for enrollment, that there's a big disconnect between the two. And what we've been asking now is, what are the different attributes that are important to people as they think about participating in different types of studies. And these are data, again, from the national survey that I described just previously. And what we found was that people said that whether or not they got results about their personal health or general research results would be the most important thing that they would think about. And sort of data usage, which was surprising to me, was one of the least important aspects of a study. And so we've been developing, we've recently created these in different research vignettes where we've asked people the likelihood that they would participate in a study that was sponsored by the government, where they had to provide a questionnaire, provide information about themselves. The data would be used for current and future studies, and participants would not receive results. And so this, in our minds, sort of approximated some of the key characteristics of the precision medicine initiative as we understood it. So we asked people would they participate, and most people said, no, I wouldn't participate. 31% said that they would participate. And we did find differences about who would participate and the reasons why they would participate. And I will end there. I get anxious with the timekeeper, you know. It's like I stop talking immediately.
Thank you.
Thank you.
Passing the mic.
All right, so I'm hoping that my comments build nicely both on what you've just heard from Shanita as well as comments in the previous panel. So I think a lot about how do we actually recruit a precision medicine cohort that is broadly representative across different population subgroups. But I approach this from the standpoint of a health communications scholar. So the first thing we look at is, what do people know now about genetics? What are their attitudes toward genetics? And what might be their likelihood of participation? And how does that differ across subgroups? So I am a data person. I'm going to show you a few slides with data on it, but I will talk you through what I think are the major messages of some of the larger studies that have addressed these issues. So first, there are a number of studies that have looked at awareness. And consistently, what we've seen is what you see on this slide. So there is lower awareness of genetic testing, and in this case, a lower awareness of genetic testing for cancer risk for most racial and ethnic minority populations. So this was a large nationally representative sample, and what they saw was that people who identified as Hispanic were only half as likely to know that there was such a thing as genetic testing for cancer risk compared to white participants. And similarly, African American and Asian respondents were also significantly less likely to know or be aware of. These data are now about 8 years old, but similar trends in differences have continued in, across population subgroups for awareness. We see something different with knowledge, and I know that this slide is busy, but I wanted to show you a few patterns. This was from a large survey that one of my colleagues at the University of Michigan conducted. And the nice thing about this survey is they actually had equal representation for white men, white women, black men, and black women. And they looked at differences in different types of knowledge across those 4 different groups. And actually what they saw was more similarities than differences. So I'll highlight a few of the different items where we actually did see differences in knowledge. So the top item, when they're born, identical twins have exactly the same genes. You can see that a majority of people actually got that item correct, although white men had significantly lower knowledge. The more interesting one, I think, is the third item. Our genes tell us which race we belong to. There was, again, a lower proportion of white men and white women compared to black participants who got that item correct. But I think what's striking about it is you can see that a low percentage of people got that item correct across the different population subgroups.
I hope the answer was no.
It was no. Yes, I should have said that is a disagree item, so that is a false item. But what these authors pointed out, and I think what is striking about these data, is generally knowledge is pretty low across population subgroups. So I think in thinking about knowledge, focusing on relatively minor differences across racial and ethnic groups is obscuring the point that generally our population doesn't know much about genetics. We see, again, something different when we looked at attitudes toward genetic testing. And this is an older study, but I think has been replicated since. So this is looking at people's attitudes. Would they want a genetic test for a treatable disease, for colon cancer, for an untreatable disease, or for Huntington's disease? And you can see that there was representation from African Americans, Latinos, as well as white respondents. What is hopefully showing up here as blue and bolded font were the significant differences. So again, attitudes were pretty similar. Would you want to receive a genetic test for treatable disease or colon cancer was pretty similar across groups. But African Americans were more likely to say they would want to receive a genetic test for untreatable disease compared to white participants, and also more likely to say they would want to receive a genetic test for Huntington's disease compared to white participants. And that was also true for Hispanic respondents who said they would also be more likely to want to receive a genetic test for Huntington's disease. I also wanted to point out a very large study conducted by Dave Kaufman, who is now at NIH, which looked at attitudes toward participation in a large cohort that had biobanked DNA samples, so sort of approximating a precision medicine-like cohort. And the nice thing about this survey was that it was actually large enough to be able to look across 5 different racial and ethnic groups. So the middle category is showing what their attitudes were toward the cohort study. How many people said that this type of cohort study definitely or probably should be done? And you can see that actually, thank you, a large majority of people across the different subgroups thought that that should be done. But I did want to highlight the noticeable and significantly lower agreement among American Indians and Alaska Natives. We have less data on attitudes and knowledge in general in that population, and this was one of the studies that I'm aware of who have looked at this. If you move over to the column on the right, looking at the percentage of people who would definitely or probably agree to participate in this type of cohort, you can see that it's a majority, but not as strong as the people who said, yes, we should do this type of study. As Shanita already alluded to, though, just because people say they would participate in a cohort in a survey doesn't actually mean they will participate in a cohort. So this is data I collected with colleagues at the Washington University School of Medicine, looking at 1,900 men who had agreed to participate in a prostate cancer biorepository. So these are people who have signed up for a biobank. And they were asked a series of questions about future research uses of their biospecimens. And I think quite strikingly, only 10% of men agreed to have their PHI linked to their biospecimen, so, which is, of course, much less useful for a lot of different research purposes. 88% said, yes, you can use my biospecimens across a different set of research uses, but only if you do not link my PHI to my biospecimen. Only 2% actually said, no, you can't use my biospecimen for future research. And I have to admit, when we looked at differences by race, what we saw was not what we expected. So the diagonal lines are respondents who identified as African American or Black, and the solid bars are white participants. So Black participants were more likely, somewhat, to say that, no, you cannot use my biospecimens for future research use. But conversely, among those who agreed to allow future research uses of their biospecimens, African American men were also more likely to say, yes, you can link my PHI, which is something that we had not expected. And I think actually speaks to the trust issue that Shanita brought up. So these were people who were patients at our cancer center and I think had a strong level of trust in the cancer center researchers. So then where does this leave us? We know that there's lower levels of awareness about genetic testing among minority racial and ethnic groups, but probably somewhat more favorable attitudes toward genetic testing as well as similar attitudes toward cohort participation. But we do know that there's generally relatively low knowledge about genetics in our population. And so what I'm approaching now in some of my current work here is thinking about what do people actually need to be recruited into a precision medicine cohort and actually give informed consent to participate in that sort of cohort. What sort of details, what sort of information do we need to provide? And I'm going to go through this last example fairly quickly because I feel like we're going to get this stopped pretty soon. But my current thinking on this is informed by some of work I did at NIH, looking at decision-making regarding a multiplex genetic susceptibility test. We created a web-based module to be able to look at what information people actually looked at when they were making a real decision about whether they should get the multiplex test or not. So we showed them possible information about the test, information about the 8 different health conditions on the test, as well as information about 15 different genes that were represented on the test. And what people actually looked at, and some of our open-ended data reflect, what people cared about was what was actually involved. So most specifically, did they need a blood draw? Because people, as it turns out, really don't like having their blood drawn. But they were much less likely to look at all of our intricately crafted web pages that focused on the details of the different genes. So at least this suggests that some of the logistic details that I think we don't necessarily focus on enough are going to be of interest. But I also should mention, just because I am on a panel about race, even controlling for the amount of information that people read, Black individuals were still much less likely to agree to take the test compared to white individuals who looked at the same amount of information. And we're currently exploring in some of my current work why that might be, why there's differential responses to what looks like the same information. So then finally, just to wrap up, I wanted to highlight some of what I think are the major research gaps in this area, things that we really need to grapple with as we think about recruitment into a precision medicine cohort. I think it's likely that there are differences in information needs across population subgroups, but generally low knowledge about genetics within the US public. We really need to start looking about within the larger groups like Hispanic or even African American, what does that actually mean? Because there's going to be a lot of heterogeneity in knowledge, attitudes, information needs, and we have not really delved into this very much. I'm interested in developing and testing some culturally tailored recruitment approaches to try to engage some of those communities who have not historically engaged with genetic research. And finally, I have to mention this because this is my own area, genomic literacy. So how are we going to recruit people who have more limited reading skills and particularly more limited number skills or numeracy? I think that is another challenge that we have not yet grappled with. Thank you.
Thank you, Kim.
Oops. Can you reach it?
Okay, so my name is Sean Teftigan, and the work that I do is all about identifying cancer susceptibility genes and refining what we understand about the risks of cancer, the magnitude of risk of cancer that inherited variation in those genes confers. And I've just tried to put together a couple of slides that at the very end will make a connection between stuff that I have learned over the last couple of decades and a race-ethnicity intersection. So first of all, excluding Lynn Jordy. Does anybody in the room know what this slide is actually showing? Well, it's an electrophoresis, but what it's actually showing, do I have a pointer here that works? I do, but it's on. So right here in this lane, this lane, this lane, and this lane of this early 1990s style mutation screening gel is the very first mutation in the gene BRCA1 found on, looks like, July the 13th, 1994 by a technician named Tang Tran at Myriad and witnessed that same day by Donna Shattuck-Idens from Myriad Genetics. And BRCA1 is a classical high-risk cancer susceptibility gene. So when I think about new susceptibility genes and what I want to know, one important thing not shown on this slide is what is the spectrum of cancers where inherited mutations in the gene are conferring increased risk. But then shown on the slide are two other important questions. One is, what is the magnitude of risk conferred by those inherited sequence variants? And the other is, in the general population, what is the frequency or some frequency of the pathogenic alleles in those genes? And at this point in the breast cancer genetics world, and also in the colorectal cancer genetics world, and I think to a lesser extent, but sort of generally true even in the melanoma susceptibility world, the susceptibility genes are kind of breaking down into three groups. There are high-risk susceptibility genes like BRCA1 and BRCA2, where the inherited mutations are causing 5 to 10-fold increased risk of breast and other cancer. I mean, enormously increased risk. But the summed frequency of the pathogenic alleles of those genes in the population is extremely low, something on the order of 0.1 to 0.2, maybe 0.3%. Then there are moderate risk genes like ATM and CHEK2, which confer 2 to 3-fold increased risk of disease and have slightly higher summed allele frequency. So the individual pathogenic variants can be extraordinarily low. They can be pedigree specific. But across all of the pathogenic variants in the population, the summed frequency might be 0.5% to 1% in an individual gene and is maybe 3 or 4% across the whole set of such genes. And then finally, there are common modest risk SNPs. These guys are conferring sort of 1.1 to 1.2-fold increased risk of disease, but there are many of them in our genome, and some of them are very common, so they can have allele frequencies of 10, 20, even 50%. Okay. Now, we have to answer a question before I can go on to the rest of the talk about what does it mean for a sequence variant to be pathogenic. I have a longtime collaborator from University of Vermont named Mark Greenblatt, and who's a clinical geneticist, among other things. And after talking about it, we decided, well, an individual sequence variant by itself is pathogenic when knowing the genotype is going to change a patient's medical management. So if we look at this from a breast cancer point of view, a relatively low-risk segment of the population has a lifetime, in the United States, has a lifetime risk of breast cancer of about 9%. And under NCCN guidelines and also American Cancer Society guidelines, a person has to have 20 to 25% lifetime risk of cancer. We'll take 20% as the basic threshold before a clinical geneticist or genetic counselor would do something to change their medical management, where that change would be to recommend early mammography or maybe breast MRI in addition to mammography to increase the chance of early detection of a cancer because they're at high enough risk to justify attempting early detection. And so if a low risk segment of the population has sort of an 8 to 9% lifetime risk, an individual distinct genotype would have to confer 2.5-fold increased risk to reach the medically actionable threshold and to be called pathogenic. So if we come back to here, the high-risk genes are obviously have pathogenic variants in them, and that these moderate risk genes actually just reach the threshold of being individually pathogenic, whereas the modest risk SNPs do not. So, bringing it over to a little bit of a race ethnicity issue. For the high risk, for all of these genes, so far as we can tell right now, there are basic multiplicative interactions between lifestyle and so on risk factors and the genetic risk that's being conferred by an individual variant. For the high risk genes, where we're talking about 5 to 10-fold increased risk of disease, it doesn't matter what a person's race or ethnicity is, and it matters very little what their lifestyle exposures have been, because none of these things confer a big enough decrease in risk to counterbalance that 5 to 10-fold increased risk. A carrier of a mutation in BRCA1 is at enough of an increased risk to change their medical management, irrespective of what their race or ethnicity is. Okay. Moderate risk genes, it's a little bit less clear. In general, the presence of these things, of the pathogenic alleles in the population, is race and ethnicity independent. A moderate risk gene among Caucasians will be a moderate risk gene among African Americans and East Asians and other ethnic groups. There will be bigger allele frequency differences across ethnic groups, but the main moderate risk susceptibility genes remain moderate risk susceptibility genes. One thing that does become interesting, though, is that there are lifestyle effects that can have that can cause twofold increased risk or decreased risk, or let's say multiple lifestyle effects multiplied together can make a twofold difference, which means that they actually can modify the risk conferred by an inherited variant in a moderate risk gene. And one could imagine that these things might sometimes be variable enough across racial and ethnic groups to have an impact on a person's medical management if they carry pathogenic allele in a moderate risk gene and other issues. But when we come to the moderate risk SNPs, things are completely different. Okay? So the individual moderate risk SNPs do not confer enough risk of disease to be medically actionable, period. But in the breast cancer world, we actually know of about 100 of these moderate risk SNPs. And we know, based on very large studies of on the order of 40 to 50,000 cases and controls, that in the general population, something like 2 to 3% of people have inherited the higher risk allele at a sufficiently disproportionate fraction of all of the moderate risk SNPs that they've inherited a 2 to 2.5-fold increased risk of disease, okay, which would be medically actionable. Individual SNPs, not medically actionable. The ensemble of individual SNPs that a person carried can be medically actionable and can be detected by current genotyping technologies. But here's the kicker. Most of these SNPs that we know about are not the true pathogenic or the true risk allele in the person's genome. Rather, they're merely markers for another risk allele that's present and may be known, may be unknown. Okay? And it's very, very clear that the patterns of co-inheritance between the marker alleles and the true pathogenic alleles for these common SNPs are very different among different racial and ethnic groups. Which means that the current polygenic risk profiles, for instance, published in a paper by Doug Easton's group just 3 or 4 months ago, are very Caucasian specific and totally inaccurate when applied to other ethnic groups. So while I've been sitting here, I did a little chain calculation having to do with this 1 million-person precision medicine cohort. So if the 1 million-person cohort were to sample African Americans proportionally, it would end up with about 100,000 or so African Americans in the cohort, which would result in 50,000 African American women. And if you followed them all the way until age 75, about 5,000 African American women with breast cancer. Now, to accurately detect and then tune the polygenic models that it takes to use the common modest risk SNPs in a medical setting takes studies of 40 to 50,000 cases and controls. And so, believe it or not, a 1 million-person cohort would be horrendously underpowered to address the problem of using the modest risk SNPs properly for medical care of women in the United States. And with that, the work that I showed has received contributions from gobs of graduate students and postdocs and other scientists around the world over the years. Thank you so much.
Great. So join me, please, in thanking our panelists on their very thoughtful comments. And now we will turn to you for questions. Please wait to begin your question until one of our fellows has been able to bring you the microphone so that it can be recorded and broadcast through the web.
I actually have a question that relates very specifically to exactly what you were just talking about. When we breast cancer among women, that's a really high risk, 9% overall. When we start thinking about more specific, smaller, lower percentage diseases, how do you get a representative population like that?
Well, The studies to identify the high risk and moderate risk susceptibility genes don't require tens of thousands of cases and controls. And so it's generally doable with diseases down to frequencies of about 2%. When frequencies go below 1%, then it only becomes possible with large pedigree studies rather than population-based studies, right? The modest risk SNPs problem requires lots and lots of subjects, and it would become almost impossible to do representative studies.
While we're with your discussion, I wondered the degree to which the notion of medically actionable is affected by cost considerations. That is, what counts as medically actionable is a decision about gains and losses. Well, anyway, it's about cost. Is this a circular claim is what I'm trying to ask.
Well, I think it has to do a lot with harms versus benefits, right? Because as the whole goal on the breast cancer side is really detection of breast cancers in women in, say, their 40s and early 50s, because those women, if they get breast cancer, are highly disproportionate probability to die of breast cancer rather than some competing cause. But as you do screening on women who are younger and younger, the balance of false positive findings that lead to unnecessary biopsies and so on gets higher and higher towards the false positive findings and away from detection of cancers, and which is also a cost-benefit problem. So the answer is yes, and the current harm benefit and cost benefit analyses put the appropriate level of risk at about 2.5-fold. That could change as technology changes.
So I actually have a question. Didn't see a hand raised, sorry. Knowing what we know now, given the data that we just saw, and as it links back to the previous panel, I was curious as to what does this data actually translate to? Doesn't it make sense that most people would be interested in having a study and conducting a study or a cohort, but not be willing to participate themselves?
So I think, yes, you raise a really interesting question. I think even more recent studies that have come out show a sort of general a support for this type of study, but I think what we're going to see is lower participation without the sort of community engagement strategies that Carrie and others have alluded to in their presentations. So more targeted strategies that are appropriate for different communities and really speak to their needs, their information needs. I think otherwise we do run the risk that what we're going to get are the very motivated, healthy volunteers who participate in studies more easily. And lose a lot of the other parts of our population that probably have different health risks. And we do need to come up with more targeted strategies to reach those. I think that's a great question. In the back.
Thank you. This is sort of a loaded question, but I'm curious.
About race?
Well, I'm a philosophy grad student. It's sort of all we can ask is loaded questions. But on the one side, given that racial minorities have been underrepresented in medical research, and then on the other side, given some of the worries that Professor Khan has brought up in his talk, is race a useful category for precision medicine? Is this something that we want to use as we go forward in this research, or is this something that we should try and exclude from the beginning? We just shouldn't include racial categories at the start.
Well, as I said at the beginning, I mean, I think the question is, not is race a useful category for precision medicine, but how or under what conditions can it be made useful? Because there is the irony, of course, of which Tennille, or I think the whole thing opened. Tennille opened with that we're all supposed to be the same, right, genetically. if at the molecular level, right, we're all 99.5% the same, then what's the point of even getting an ethnically diverse cohort for the PMI or for anything, right? But right, so on the one hand, it's like, what's the point of, what role should ethnicity play in that? But on the other hand, right, you want to capture the fact that different racial and ethnic populations have experienced different health histories that have, significant impacts on, the functioning of their biology that might be able to be captured in part at the relationship of the genetic level to the way the biology, the larger biology of the body is functioning, and a well-engineered, diverse, and well-powered cohort study that has more than just molecular information, that has the kinds of personal health information and ideally broader information, which is much trickier for something that's 1 million large. But there are other smaller studies going on there that can look at things that affect the body that happen outside the body as well. Their race, you might be able to find something out about how the variations that you might find in race in different diseases and different correlating with different genetic variants might tell you, the gene-environment interactions or whatever else that correlate with race are significant here, and race is useful for finding that out. But the idea that but the danger is that we're just going to say that, we're seeing these variants by race, and that you're just looking at the genes at race as a function of the molecular variation, allele frequencies. That's where my concerns come in.
I would agree with that comment, and I think that a couple of points just came to my mind as you were talking. One of the things we've been doing at MUSC is trying to understand the reasons why race and ethnicity might be missing from a patient's clinical record, and it actually is missing quite commonly. And part of it is because patients aren't asked to provide their racial and ethnic background. It's either that the registrar sort of makes an observation in their own judgment, and so it's not collected reliably in the cases that it is available. But often and maybe this is just a point of being in South Carolina, where there's the history, it is what it is, where there's difficulty asking people about their race and sort of a discomfort asking about racial and ethnic background. So I said all that to say is that I think it's really important as the data collection tools be developed for the Precision Medicine Initiative that it give individuals the opportunity to self-identify their racial and ethnic background in the way that makes sense for them and the way that they've experienced in reality and lived their lives. But it's also important to collect data on environmental factors and lifestyle factors that are typically not part of an epidemiological study. So I think, geocoding is one important step, but I also think that people experience the places where they live differently. So even if you're in a low-income environment, that doesn't mean that you sort of feel that and experience it in that way. So I do think asking about race and giving people the opportunity to self-identify that in a way that makes sense to them, as well as asking about their lifestyle and environment and where they live and their perceptions of where they live is really important to think about as the cohort is developed.
So I actually have some questions too. I think maybe following up on what you just said, Shanita, curious if in your national study you did where you showed that, what was it, 30% were willing to participate, and if it were government sponsored. I'm curious if you did see differences then in dramatic differences in groups from, say, the Southeast or from areas where there was much more historical racism.
So that's a great question, and no, we haven't looked at differences based on the respondents' region of the country. And so we divided the regions into north, south, it was 4, north, south, west, and and then Utah.
Yeah.
But that's a good question. No, we haven't looked at it, but we'll do that.
Or age, for example, might be something. If you lived through the 1960s, 1970s,
Sure,
you'd have a
absolutely.
different view.
We didn't see an effective age. We included that variable in our model, but we did not include geographic region, which we can do.
Great. I'll look for the audience before I ask more.
I just had a question about, do you think there's any implication for access to medical care? Could precision medicine perhaps level the playing field, or do you think these disparities might continue?
Well, I'll start. I mean, I think access to medical care is an important issue that, it's curious to me. I guess I'll talk about this maybe from my own perception. So I was excited to see the announcement about the precision medicine cohorts, and I was like, yay, this is great. It's an opportunity for all of us to kind of be in the game of and be part of the process. And then as I read it, I read the announcement more closely. In my view, it seemed like only a small number of institutions would be really competitive and likely to apply for to serve as the data coordinating center, to serve as one of the sites that would be kind of enrolling. And so in my view, I think there's a risk of many of the same challenges and limitations of where studies are being conducted being perpetuated within the precision medicine initiative. And what I mean by that is that I don't want to call on any one particular institution, but I think that there's some places that have a tremendously strong track record, and that's wonderful, that's great, but to compete against them for that type of funding, I think is really challenging. So smaller places that don't have the institutional resources or infrastructure already established, I think would be really challenged to be a competitive player. And so what that translates to me and is sort of the effect of that is, well, so we're going to have the same sort of access to the same clinical populations that tend to have better access to medical care to begin with. And so, that's a concern for me. And so I don't know if others have a different opinion.
I think there's a deeper issue about precision medicine more broadly beyond the PMI cohort study or similar studies, is about access, not just access to healthcare, but access to sort of the fruits of this research. All right, because in things like developing the cohort, we are asking 1 million people or more, right? Or, and if you include the million veteran program, that's a whole other million, which I'm just wondering how many cohort things we've got building here. But, and they're essentially, these citizens, right, are being asked to contribute a huge public resource, right? Because what this is, it's not just individual information, it's a public resource. And what's being made of this, right? In terms of, it's, on one of the earlier slides, we saw about, getting it to research. But, research isn't where it ends, right? It ends in products, right? This is about really, most of this, it's about producing diagnostics and therapeutic interventions, producing drugs. And so the question of access is this massive investment of public dollars and public bodies, right, citizens' bodies, into this, what is going to be sort of the equity comeback, right? So because there's a lot of talk about sort of the citizen duty to participate in biomedical research, and a lot of appeals, to your altruism in these recruiting projects. Again, very prominent, especially in things like the Million Veteran Program, but also in any enrollment. You're helping humanity, which is all true and it's all really good. But there's not a similar sort of appeal or generally about, well, okay, what are the duties of the corporations that are producing the pharmaceuticals from this public resource? And that's in terms of the access. Who's going to ultimately have access to this? We still don't have universal health care. We still have, even though the coverage is better than what we have, the drug coverage is not so good, things of that sort. And so, who's really going to be getting access to these drugs? And should there be sort of concomitant claims being made upon not just the citizenry in developing precision medicine, but upon the people who are developing the actual medicines that are coming out of this? And I think that's sort of the flip side that needs in many respects, they should mirror each other. The idea of civic commitment should be on both sides.
And I think just to add one point to what Jonathan mentioned, in research looking at diffusion of genetic technologies more generally, the people who benefit from a lot of genetic research tend to start to be the highly educated, high-income white populations, and then there is a much slower diffusion of the benefits of that research to other populations. And so I think among colleagues who work in that area, there is attention being paid to how can we prevent some of that exclusion from the benefits of the precision medicine cohort so that this slow diffusion of technology doesn't happen in quite the same way.
Okay, I think I'll use my moderator's prerogative to ask one more question. I'm curious, Kim, and maybe for Shanita as well, or any of you, how we might break apart the idea of distrust and how we might see differences between the different populations based on what it is that they're not trusting. I was curious, I think it was your slide that showed that the data use was actually a very low concern. And I'm wondering if you might see differences then with, say, Native American populations where the use of the data might be, the distrust in the use of the data might be more paramount because of things like the Havasupai case or challenging ancestry stories, where in some African Americans in a cancer treatment facility would trust their clinicians but may not trust other uses, other research uses, or the government having access to that and potential future discrimination. So I'm curious if you know any of the research, if there's been research in this area of unpacking the idea of what it is that they distrust and how that might affect enrollment in studies.
Sure. There's actually a huge literature on distrust, and I'm just trying to think where to start. So I think it's certainly so if you think about patient and providers, there's distrust in terms of patients believing that providers aren't simply acting in their best interest and are enrolling them and doing research without getting their consent and without asking. So that's sort of interpersonal distrust. And then there's distrust, I think, of research where it's like, well, it's not really designed to benefit me. It's not going to benefit me. It'll actually hurt me in some way by developing medications or drugs that I can't afford. We've been thinking of, so the interventions, as you were asking the question, what I thought about was, well, what are the interventions that have been put forth or attempted to be developed to try to facilitate trust? And there's been some work done in the space of addressing physician behaviors, where teaching them how to be more effective communicators with patients and giving more information and displaying trust in terms of the ways in which they interact with their patients sort of during a clinical encounter. And I think that's really important. But I think, trust, if you think about it, is really is based on the relationship between two people. And so I don't believe that there's a lot of work done to try to enhance trust among patients. Some of the things that we've tried to do to address that is start by giving people, using a community-based strategy to disseminate the results of research, because I think people fundamentally want to know what the research found, what happened with the study. I mean, particularly if they were involved in it. And I think this came up as one of the points that was raised in the previous panel, where people just want to know what happened. And one effort I think that NIH is making now is that investigators have to deposit their peer-reviewed article in PubMed as a way for people to have access to what the research showed, what the research found. And I think that's important, but I don't think it will really reach the segments of the population that have the greatest amount of distrust and want to know what the research found. So we used a community-based approach to talk about it's basically the STAR trial, the studies that did tamoxifen and raloxifene, and sort of communicate what that research found. And it actually, our preliminary data demonstrated that it did decrease the amount of distrust that African American women had about research and about physicians. So I think that's an important step, is to start thinking about, well, what type of interventions can we develop that are targeted to patients as well as physicians to help address trust. And I think within the research space, it starts by sharing what we found, what the studies are showing, and giving greater access to the findings from different studies, and not kind of, so yeah.
Just one quick thing I want to say about that, because there's an emerging critique of trust in bioethics literature, which I'm not that conversant with. Some other people in the audience might be more so, but it's the idea of basically sort of, instead of asking the question, why is there so much distrust among the patient community, ask the question is, why aren't researchers more trustworthy? Right, and so focusing not simply on gaining the patient's trust, but on researchers becoming more trustworthy, right? Why aren't we worthy of your trust as opposed to why don't you trust us, right? Yeah, right, yeah.
And just to add, to refer back to Erin's presentation, I think efforts to increase the public's trust in researchers hasn't received enough attention, as Jonathan said. So I think those sorts of efforts are really interesting. Is there a way that we can increase people's trust that their data and their samples are going to be handled well by researchers?
Well, then please join me again in thanking Sean, Kim, Shanita, and Jonathan for a very fascinating conversation. I'm going to turn the time over to George now.
Thank you all. No, this was wonderful, and this does bring us to the end of our sessions today. So I'd first like to just reiterate thanks to all of our speakers who came from around the country and around the university to participate with us here. So I'll have one more round of applause for all of our speakers and panels. It's really wonderful. Also, just as far as making a two-day conference like this happen, a lot went into it. First, I have to thank Dean Adler at the College of Law for giving us the use of this wonderful facility today, which I think has worked out very well. Also, our staff who really made this happen. Jackie Morrison, who's the program manager of the Center for Law and Biomedicine here, Aaron Reardon in our events department, Lance Finch, of course, up in the AV booth, Dana Wilson and Janelle White in the marketing group, and our wonderful team of student volunteers and BioLaw fellows who helped us out, Danny Barber, Kendra Brown, Dave Duncan, Mike Eisenberger, Dan Gosland, Anika Hoydel, Jerry Lynch, Courtney Neves, Kylie Orm, Austin Paulson, Michael Squires, Travis Walker, and Thomas Woodland. You guys all deserve a huge round of applause, so thank you very much. I also have to thank our colleagues from the School of Medicine who were wonderful to work with and to collaborate with on what, at least in my experience, is a relatively unprecedented level of cooperation and collaboration among different groups around campus. So Will Deere and Lynn Jordy and Emily Coonrad at the School of Medicine. And of course, though she couldn't be here, Mary Beckerly of the Huntsman Cancer Institute really had the vision quite a while ago that this sort of inter-campus-wide event would be a very valuable thing to have. And she's off in Washington arguing for many of the things that we've heard about today in the Capitol. So thanks to her and to all of our cross-campus collaborators. Okay, so just a few administrative announcements. Those of you who are lawyers and stuck around till the end to get your continuing legal education credit, the certificates for those much coveted ethics 2 hours of ethics CLE credit are available at the registration table on your way out. The video of both yesterday's and today's presentations are on the website now, I understand, but they will then be there in perpetuity, more or less. We have a YouTube channel that they will be transferred over to soon, not yet, but at some point, relatively soon. So you can relive the greatest moments of this symposium as many times as you like. And then finally, I want to thank you in the audience for participating and your great questions and enthusiasm. We would love to have your ideas and your feedback. There is talk about doing this again sometime in the coming years as we see what happens with the cohorts, what happens with the PMI, whether we will all be cured of all that ails us. So again, please give us your feedback and your comments and suggestions for later. I hope that you agree with me that this was an incredibly content-rich and provocative symposium. So thank you all. That's it. Okay.